malignant lesions. Incidence and mortality rates vary according to the cause of the disease. And today we are assembled here to discuss various updates on the discussion of anocolorectal diseases. Now, I would start the first discussion with which will be conducted by Dr. Sachin Agarwal, sir, radiologist in Department of Subharti Medical College, and the session will be chaired by M.K. Mittal, sir. M.K. Mittal, sir, is the head of Department of Radiology. He is his major achievements are Sir J.C. Bose Oration of Area from the year 2009, and he has Dr. N.K. Girg Memorial Oration and Keynote Address in 2016 of ICRI Distinguished Teacher Award by National Board of Examination at Presidential Awards from Recognition of Teachers in the year 2012. He is awarded FICR at 63rd Annual Congress of IRIA in 2000. He is Secretary, Delhi Chapter, IRIA 2005 to 2007. He was the President of Delhi Chapter of IRIA from 2007 to 2019. These are all the things which he has achieved in his life, and we are very lucky to have him here to chair the seminar. So I request Dr. Sachin Agarwal, sir, to come for the session. First session, Imaging in Colorectal Diseases. And I request Dr. M.K. Mittal, sir, for the chairing the session of.
Good morning, everyone. I'm Dr. Sachin Agarwal, going to present the imaging in colorectal diseases. First of all, I am going major investigation we can do in colorectal diseases. After this, I am going to discuss few important pathologies of colorectal area. First of all, there are batteries of investigation included plain radiograph, barium NMR studies, ultrasonography, computed tomography, and MRI imaging of colorectal region. One by one, I am going to discuss. First of all, it is radiograph. I am going to discuss advantage and disadvantage of radiograph and when it has to be used. Various views are available, including chest radiograph, erect, supine radiograph, abdomen, erect radiograph, abdomen, and horizontal beam radiograph to evaluate abdominal pathology. Among that, the chest radiograph erect is very sensitive in acute abdomen to detect the free gas air under diaphragm. And erect radiograph abdomen is less sensitive than the chest radiograph erect to detect the free gas under diaphragm. But horizontal beam radiograph is gold standard among all the radiograph to detect the free gas. What we can see on normal radiograph. First of all, we should look for normal air fluid level, which is almost always present in stomach, and up to 2 to 3 air fluid level are normal in small bowel loops, and in large bowel loop there is no air fluid level is seen, but in pathological condition like large bowel obstruction there may be air fluid level. How to identify large and small bowel loop on radiograph? We can identify by the location. Large bowel loop are peripherally located and small bowel loop are located centrally in the abdomen. How to detect the obstruction on the plain radiograph? On plain radiograph, a diameter up to 3 centimeter of small bowel loop are considered normal, and 6 centimeter for large bowel loop is considered normal. But for cecum, up to 9 centimeter, we will consider as a normal diameter. This is the representative plain radiograph, which indicate what all structure we can see on this. This is the example of a case, a 13-year-old female presented with the acute abdomen, in which we did a chest radiograph PA view, which detect no gas under diaphragm, but however, there was a strong suspicion of perforation peritonitis. Erect abdomen radiograph was also taken, which is also inconclusive. But in horizontal beam radiograph, there is a free air seen along the right lateral wall of abdomen, which is indicative of perforation peritonitis. So this is indicate the importance of lateral beam radiograph. Indication are First, for plain radiographer, it is a first line investigation in acute abdomen. It can detect the bowel gas pattern of a small bowel loop and large bowel loop, so we can diagnose the intestinal obstruction. It can detect also extraluminal air to diagnose perforation peritonitis, and sometimes calcification are very well detected on plain radiograph. Advantage of plain radiograph is cost and availability, and disadvantage is it is very less sensitive in detection of pathology and as well as specificity. Next is barium study. Barium study can be done by single contrast and double contrast. In single contrast, single column of barium is introduced through the rectum and serial radiograph has been taken. In double contrast, we use negative and positive contrast simultaneously. As a negative contrast, we usually use environmental air. This is the typical barium meal with single contrast study, which is showing anatomy of large bowel loop. Indication of barium is early detection of malignancy or mucosal pattern, and it can easily, barium enema can easily detect the narrowing at various level, and leakage of contrast can be seen on barium enema. Advantage of barium enema are mucosal definition and cost effectiveness of barium, and disadvantage of barium enema are it is time consuming and patient and operator dependent technology है. इसके बाद few example of barium enema with some pathologies. We can see in single contrast barium enema, there are multiple outpouching are seen in the barium, which is representative of diverticulitis. Another example of diverticula, we can see the contrast fill outpouching in the descending colon and sigmoid colon region. This is the example of double contrast barium enema, which shows multiple filling defect, which are suggestive of polyp. This is another example of diverticula, which show multiple outpouching in the descending colon region. Next imaging is ultrasound. Ultrasound nowadays first line investigation in most of colorectal diseases, and it is a real-time investigation, so we can do image-guided intervention like reduction of the intussusception colocolic, and we can do biopsies, drainage, and various procedure under the guidance of ultrasound. Typical ultrasound anatomy of bowel loops is there are 5 typical layer are seen on ultrasound, which give the gut signature sign on ultrasound. Innermost layer is superficial mucosa, which is appear echogenic. Echogenic means white on ultrasound. After that, there is a deep mucosa, which is appear black on ultrasound or hypoechoic. After deep mucosa, there is a submucosa, which is appear white, and after that, there is a muscularis layer, which is appear black on ultrasound, and serosa is appear white on ultrasound. This is the typical pattern from inside out on ultrasound. Superficial mucosa white, deep mucosa black, submucosa white, muscularis black, and serosa is white. In the large bowel, there are 3 fold of longitudinal muscle layer are seen, which is called tinea coli, which is appear as a focal thickening on ultrasound. These are the tinea coli. Ultrasound, advantage of ultrasound are this is very cheap investigation, first line investigation in colorectal diseases, and it is easily available in each and everywhere. And disadvantage is limited field of view. We cannot detect some extraluminal pathologies, and bowel loops is too large to be scanned completely. It is also operator dependent and suboptimal in case of fecal loaded bowel loops. Next investigation is colorectal. Next investigation is computed tomography. Computed tomography is nowadays considered a gold investigation of choice in most of colorectal disease, because its quality is not compromised due to bowel gases, and intraluminal, intramural, and extraluminal pathology can be detected on computed tomography, and extent of disease can be detected. This is a typical axial view of contrast enhanced CT, which show large bowel loaded with fecal matter and air, and small bowel loops filled with positive contrast. This is the another axial section of CT, which shows multiple small bowel loop filled with the contrast, and large bowel loop collapsed and filled with fecal matter at places. Advantage of computed tomography are it is a highly sensitive and specific investigation in some pathology, and it is not dependent on operator. And diagnosis as well as extent of disease can be tell on computed tomography. Disadvantage is cost is high, availability is not everywhere, and hazard of radiation and contrast is there in computed tomography. Next is magnetic resonance imaging. MRI is a gold standard in nowadays in colorectal malignancy, colorectal diseases, particularly in rectal region and anal region. MRI advantage of MRI is it is very high soft tissue. It is very high soft tissue resolution, and it is highly sensitive and specific. It is also not dependent on operator, and diagnosis as well as extent of disease can be tell on MRI. Again, disadvantages are cost and availability. MRI is not available at all places. This is a typical axial and sagittal MRI showing a T2 hyperintense lesion polypoidal within the rectal region, which can be also measured from the distance, can be also measured in from anal virgin sagittal section. Nowadays, we can do dynamic MRI for to see the rectal prolapse or pelvic floor descent. This is the example of MR difficogram, in which we can see there is a descent of rectum through the pelvis. Now I am going to discuss briefly about some colorectal disease under the heading of congenital colorectal disease, inflammatory bowel diseases, infective colorectal malignancy, and some miscellaneous condition. So first of all, I am going to tell some imaging feature of congenital colorectal disease, which include Hirschsprung disease. Hirschsprung disease, we all know there is a arrest in the normal cranial to caudal neural cell migration, so that there is a ganglionic segment in the rectum, which may be present as short segment, long segment, and total colonic disease. Clinical feature is usually failure of pars meconium within the first 48 hours of life, and if patient present in late year of life, it is present as a constipation or chronic constipation. Barium is the investigation of choice for the diagnosis of Hirschsprung disease, in which we can see inversion of rectosigmoid index. Usually, the rectum is wider than the sigmoid in pediatric age group, but in Hirschsprung disease, due to the aganglionic segment, the rectum is narrowed, but sigmoid colon is wider. Another features are irregular contraction of a aganglionic rectum, which is appear irregular in outline, poor rectal distension, and discrete zone of transition can be seen. Colon is slightly shorter and rather featureless, hepatic and splenic flexure lying more medially. But definitive diagnosis is absolutely rectal biopsy is the definitive diagnosis. This is the barium enema of Hirschsprung disease, which shows dilated sigmoid colon and narrowing of rectum with. This is the example of narrowing of rectum with dilated sigmoid colon and zone of transition is seen. Another example is meconium plug syndrome, also called function immaturity of colon, small left colon syndrome. This is the pathology behind the meconium plug syndrome is this is due to immaturity of bowel innervation and motility in full-term infant. It is a self-limiting disease which can be confused with the Hirschsprung disease. However, it is managed conservatively. It's present as a dilated ascending and transverse colon, but transition zone is seen at the level of splenic flexure of colon. A large mucus plug can be seen in splenic flexure, and in this case, rectosigmoid index is normal, not reverse. This is again self-limiting disease, and contrast anemia can be therapeutic as well as diagnostic maneuver. Next is colonic atresia. It is a rare congenital anomaly. On plain X-ray, it can be present as a low intestinal obstruction in the form of dilated transverse colon or dilated large bowel. In contrast anemia, it can be present as a contrast anemia. It be seen as a blind endic colon. This is the example of colonic atresia, in which the contrast is not passes beyond the splenic flexure of colon. Another is anorectal malformation. Classification of anorectal malformation is high type and low type. Clinical presentation of high and low type are different. In low type anorectal malformation, there is anteriorly placed stenotic anus or perineal fistula. Sometimes fistula may be seen in the vaginal vestibule. In high type of anorectal malformation, patient is present with no rectal opening, no anus opening, and presented with a feature of low intestinal obstruction. In this, blind-ended rectum is seen, and urinary tract fistula is also seen, which is communicating to the posterior urethra or bladder base. In female, it is presented as vaginal fistula. On radiograph, as I told, it is presented as low intestinal obstruction and feature of large bowel obstruction with air, sometime air within the bladder or intraluminal calcified meconium is also seen. On micturating cystourethrogram, fistula between urinary tract and gastrointestinal tract may be seen. Prone shoot radiograph was previously done, which shows false which is a not obsolete technique in nowadays because it can give false high level or false low level results. Perianal ultrasound are nowadays are increasing in use. It can be detected low lesion or high lesion very confidently. If the lesion is more than 15 mm, we will consider as a high anorectal malformation. And if the lesion is less than 10 mm in depth from the skin, we will consider as a low anorectal malformation. This is the example of micturating cystourethrogram in which bladder and posterior urethra is well visualized, which is communicating with the narrow fistulous tract with the rectum. This is a representative of high anorectal malformation. Another example of distal loopogram in which the distal loop is opacified with the contrast, which is communicating with the posterior urethra. Another example of colorectal disease is inflammatory bowel disease, which include Crohn's and ulcerative colitis. Inflammatory bowel disease consist of range of disease which include Crohn's disease and ulcerative colitis. Crohn's disease can affect any segment of GI tract. The disease may include this may cause stricture, inflammation, or lead to development of fistula. The key feature of Crohn's disease is that it involves all layer of the bowel. That means transmural involvement. During the later phase of disease, the mucosa will reveal a cobblestone appearance due to the inner linear ulcer between the normal mucosa. Crohn's disease most affect the colon and ileum, and only 5% of cases affect the gastroduodenal segment. Sparing of rectum is typical of Crohn's disease, but anorectal complications like fistula and abscess formation are also seen. In ulcerative colitis, there is always mucosal inflammation that lead to edema, ulcer, bleeding, and electrolyte loss. The inflammation in ulcerative colitis usually start in the rectum and progress in the uninterrupted fashion to the proximal colon. In close to 20% of patients with ulcerative colitis, the disease remain confined to the rectum. Pancolitis is seen in about 50% of patients. As the disorder become chronic, the colon become more rigid and short with loss of posterior marking, leading to lead pipe appearance. Extraintestinal manifestation of inflammatory bowel disease are gallstone, primary sclerosing cholangitis, hepatic abscess, pancreatitis, and deep vein thrombosis and osteoporosis. Clinical features are abdominal pain, diarrhea, weight loss, fever, fatigue, reduced appetite, and weight loss. Imaging wise, Crohn's diseases on barium present as aphthous ulcer, pseudosacculation, and strictures. These are the example of pseudosacculation. These are the outpouching seen from the antemesenteric wall of small intestine. This is narrowing, which is giving the string appearance or stricture. There are multiple filling defects seen in the bowel loops, which are suggestive of aphthous ulcer. On ultrasound, advantage of ultrasound in Crohn's disease, it is radiation free, low cost modality, it easy to use by radiographer, and can be performed with little preparation and without sedation. On ultrasound, various manifestations of Crohn's disease are bowel wall thickening, thickened submucosa or loss of normal stratification या gut signature sign, non-compressibility, stricture, ulcer, fistula, abscess, inflammation to the mesentery, and free fluid accumulation and enlarged lymphadenopathy. These are the few examples of Crohn's disease on ultrasound. We can see there is a diffuse concentric thickening of bowel loop, which shows loss of normal mural stratification. Another example of Crohn's disease in which compressibility can be checked. This is the compressible normal bowel wall. On Crohn's disease, on applying the pressure by the probe, there is no compressibility is seen in the bowl wall loops. This is loss of transmural signature. There is a normal loss of normal mural stratification in these ultrasound images. Another example is another finding is skip lesion. We can see there is normal signature pattern of a bowl wall on ultrasound in this segment, but loss of normal signature in this segment, which is suggestive of skip lesion. This is the example of mural ulceration, which is seen as a outpouching in the mucosa, which fill with luminal air. These are the example of multiple ulceration and surrounding ulcer formation, perilesional ulcer collection abscess formation. This is the another example of abscess formation in which we can see the collection are adjacent to the bowl loops. This is the another example which shows collection adjacent to the bowl loops. There may be fistulous communication can be seen on ultrasound. This is the ileum, and ilio-ileal communication is seen, which is hypoechoic tract, which is communicating ileum to the ileum. This is the example of late presentation of Crohn's disease in which stricture is formed with pre-stenotic dilatation of bowl loops. Another example of stricture with dilatation of bowl loops. There is inflammation of surrounding fat is also associated in Crohn's disease, which is called creeping fat, which shows increased vascularity, and there is inflammation in the surrounding fat in the form of increased echogenicity. That means whiteness of surrounding mesenteric fat. See, this is the Crohn's colitis in which echogenicity of fat is increased, and this is the ulcerative colitis in which echogenicity of surrounding fat is maintained. In infectious ileitis, echogenicity of surrounding fat is also maintained and mural stratification is preserved. But in Crohn's ileitis, there is loss of mural stratification and increased echogenicity of surrounding fat is seen. On computed tomography, Crohn's disease is present as mural hyperenhancement, fat halo sign in chronic cases, bowl wall thickening. Comb sign means there is engorgement of mesenteric vessel, which is giving appearance of comb. Perirectal fat, periantral fat is standing, and affected bowl loop separated by focal, regional, or increased fatty tissue. Stricture and fistula formation can be detected on CT, and there is mesenteric intra-abdominal abscess or phlegmonous formation. These are the example of Crohn's disease on CT, which shows there is mural enhancement with increased mesenteric vascularity. Another example of increased mural vascularity and ulceration of mucosa. This is the example of narrowing stricture with dilatation of pre-stenotic segment. This is phlegmonous clumping of small bowel loops in the right iliac fossa region. Another example of narrowing with periantral fat standing. Ulcerative colitis can be present in acute stage, subacute stage, and chronic stage with various radiological manifestation. This is the plain radiograph which shows dilated large bowel loop and small bowel loop with multiple radio opacity within the large bowel loop, suggestive of pseudo polyp. This is the example of aphthous ulcer, which shows collar button ulcer, which is seen as a filling defect in barium column. We can appreciate here and here also. This is the double tracking of contrast, which is seen in the ulcerative colitis, which is due to the large confluent ulcer. The track of barium is seen as double tracking. Another example of pseudo polyp, which shows multiple filling defect in barium column due to inflammatory hypertrophy of mucosa. This is the widening of prerectal space. This is the lateral barium enema, in which this is the rectum and this is presacral space and this is sacrum. There is widening of presacral space seen in the ulcerative colitis. This is the CT representation of ulcerative colitis, in which there is increased presacral fat and widening of presacral space. This is the CT colonography, 3D virtual CT colonography, which shows loss of haustration in the descending colon, which is suggestive of ulcerative colitis. Another example of ulcerative colitis in which there is inflammation of ileum is also seen. There is dilatation of cecum, which shows featureless morphology, and involvement of terminal ileum is also seen. This is IC junction. In chronic stage of ulcerative colitis, there is backwash ileitis is seen, which was shown in previous images. On ultrasound feature of ulcerative colitis is non-specific, which include bowel wall thickening, which may involve both the hypoechoic muscular coat and as well as echogenic mucosa. Wall thickness extended longitudinally, and there is a decreased echogenicity and luminal narrowing. This is the example of ulcerative colitis in which there is long segment thickening of wall of large bowel is seen with maintained mural stratification. This is the target sign of acute or subacute stage of ulcerative colitis, which is seen as a alternating layer of enhancement of rectum on CT scan. This is the enhancing layer with non-enhancing submucosa with another enhancing muscular layer. There we can see the enhancing long segment wall thickening of large bowel with multiple ulceration and submucosal fat deposition. On MR, we can see the different type of enhancement in ulcerative colitis, which include homogeneous transmural enhancement. This is homogeneous transmural enhancement with loss of mural stratification. This is target-like enhancement, which is layered enhancement, which can see alternating area of enhancement and non-enhancement. Another example of enhancement is mucosal enhancement with preservation of submucosal layer and muscularis layer. This is the main difference between ulcerative colitis and Crohn's diseases. Next is infective diseases. In infection, intestinal tuberculosis is the most common infection of a ileocecal region, which is we are going to discuss. On plain radiograph, we can see the fecolic feature of small intestinal obstruction, ascites, perforation, and calcified lymph node. On barium study, in first stage of ileocecal TB, we see the decreased transient time and increase the motility of intestine, which result in rapid passage of barium through the small bowel. In second stage, we can see ulcerative barium flakes surrounded by either a thickened wall or converging fold. In third stage of ileocecal TB, we can see multiple stricture with intervening dilatation. Ileocecal TB is most commonly affected area in gastrointestinal TB. Type imaging modality, we can do barium meal follow through, enteroclysis, barium enema, ultrasonography, and computed tomography. On barium enema, we can see few signs like Fleshner or inverted umbrella sign, in which the IC junction is pull up and there is inversion of cecum, which give the inverted umbrella sign, or conically shrunken retracted cecum. Another sign is gooseneck deformity in the ileocecal junction due to the pulled up cecum and straightening of terminal ileum. Another, on USG, we can see multiple large necrotic lymph node and dilatation of intervening bowel loops. On CT, we can see thickening of ileocecal junction and multiple enlarged necrotic lymph nodes. Next is colorectal malignancy. Colorectal cancer, also called colorectal carcinoma, is the most common cancer of gastrointestinal tract. CT and MRI is the modality most frequently used for staging. Presentation can be insidious in onset with altered bowel habit, and chronic occult blood loss may represent as iron deficiency anemia. Patient may be present with bowel obstruction, metastasis, or intussusception. Investigation can be done CT, MRI, CT colonoscopy, and barium study, which is no longer is in use now most of the center. This is the example of CA rectum, which is represented by long segment enhancing mural thickening in the cecum on sagittal CT with similar sagittal MR images shows similar images of rectum, and this is the post-operative specimen of rectum. Pre-malignant condition, we all know polyp is the pre-malignant condition of colorectal malignancy. We can detect colonic polyp by various investigation. double contrast barium is one of the most sensitive investigation in previous day before the colonoscopic era, which can detect up to 40% colonic polyp if it is size is less than 5 mm, and barium enema can detect up to the 60% colonic polyp if size is more than 10 mm. Typical sign are present on double contrast enema polyp. In polyp, there is meniscus formation of contrast, giving the bowler's head appearance. This is the filling defect. Thank you. This is the bowler head appearance, giving as a filling defect in barium column. CT colonography replace the barium enema, which can be done on normal CT scanner without the add of IV contrast. Some bowel preparation is required, but it can detect up to the 80% of polyp if size is less than 5 mm. This is the typical example of virtual colonoscopy, which shows a outgrowth as a polyp, which is seen on base images as a polypoidal thickening of mucosa, and this is the similar case with colonoscopic images. Now we can see colorectal malignancy. There is always controversy which investigation should be used. Either it is CT or MRI. Nowadays, MRI is replacing the CT because we are discussing two most important things before the treatment of colorectal malignancy: circumferential resection margin and total mesorectal excision. What is total mesorectal excision? Before going to the total mesorectal excision, I am going to discuss the mesorectum. Mesorectum is a fibrofatty tissue which is surrounding the rectum. This is the hypoechoic area seen on the axial MRI, which is surrounding the mesorectal fat and rectum. In the case of circumferential resection margin, chances of positivity is very less if the tumor is extend beyond the rectum but less than 2 millimeter depth from the mesorectal fascia. But chances of positivity of margin is very high if the mesorectal fascia is breached or it is reaching up to the 1 mm of depth from the mesorectal fascia. Next is, we can also decide the sphincter preserving surgery, low anterior resection or abdominopelvic resection on the basis of involvement of rectum. If high rectum is involved, we can go for sphincter preserving surgery. But in case of mid rectum involving the anus, we cannot preserve the anal sphincter. This is the another example of sagittal MRI, which tell the depth of the tumor from the anal verge, by which we can decide the extent of disease and planning the surgery. Few another pathologies are also I am going to discuss. Another colorectal tumor are lipoma, teratoma, hemangioma, and cystic hemangioma. Lipoma is present as fat density lesion within the mural wall. Hemangioma is present as a diffuse concentric thickening with vascularity within the mucosa, and cystic lymphangioma is present as intramural cystic spaces. Other colorectal tumor are GIST, lymphoma, and in lymphoma we can see aneurysmal dilatation of ascending colon, which is lymphoma of large bowel is uncommon, but in malignant GIST there is calcification can be seen in the rectal region. This is the example of diverticulitis, which is seen as an air-filled outpouching with surrounding fat stranding. Another pathology is epiploic appendiditis. It is sac of visceral peritoneum filled with fat and vascular structure and protrude from the serosal surface of colon. It is presented as fat-filled outpouching, thickened structure, which is filled with fat and some vascular structure. Next is pseudomembranous colitis. It happened due to overgrowth of Clostridium difficile, which is caused by clindamycin, ampicillin, cephalosporin, and ischemic causes. Clinical feature of pseudomembranous colitis is pain, diarrhea, fever, and elevation of WBC. On imaging wise, multiple layering of rectum is seen, and accordion sign is seen on transverse colon. This is the typical example of pseudomembranous colitis. Next is ischemic colitis. In ischemic colitis, we can see nematosis intestinalis, and level of narrowing is seen at the level of origin of superior mesenteric artery. Thank you.
Good morning, friends. Today's topic, that is imaging of colorectal cancer, was a very vast topic, and in our radiology conferences, it constitutes about half-day session. Dr. Sachin has done his best to cover all the aspects of the colorectal diseases as far as imaging is concerned. And I think his lecture will be very good for the residents because he has discussed mainly the basic things. Regarding colorectal diseases, what the surgeon expects from the radiologist, that we should be as near to pathologist as far as possible. And with the advent of newer imaging, that is newer technology and sequences in CT and MR, we are trying to do justice with that. Now there are few new upcoming modalities, not modalities, but techniques like dual energy CT. In the MRI, we are now going to use diffusion imaging, perfusion imaging, multiparametric imaging. All these can help the surgeon, by which we can give them as far as possible the exact tumor margin and depth. I think which are the requirement for the surgeon from the radiologist. And I am happy to say that soon in next 1 or 2 months, we will be having here 3 Tesla MRI, 180 slice CT, by which I think we can give the surgeons the best possible reports up to their expectation. I will thank Dr. Sasank Misra and his team for inviting me to chair the session. I will compliment Dr. Sachin, who is very popular radiologist among all of you, and he's always available, and he has done a good justice to that topic. Thank you very much. Any questions from the audience? Thank you.
Thank you for the informative talk, sir. I would like to invite Dr. N.K. Mittal, sir, to kindly felicitate Dr. Sachin, sir.
Thank you, sir. I would like to invite Dr. M.K. Maheshwari, sir, to kindly felicitate Dr. M.K. Mittal, sir. Next on stage, we would like to invite the young and dynamic Dr. Achal Garg, sir. He's a renowned gastroenterologist, hepatologist, and interventional endoscopist, and a several award and publication to his name.
Sir completed his DM in gastroenterology and hepatology from Ramaiah Medical College, Bangalore. He went on to pursue his advanced endoscopic fellowship from Spain.
He is currently enrolled in Wise World Endoscopy Organization, School of US, South Korea, and Egypt. The list of his achievements and acknowledgements are very inspiring.
Sir has made time from his busy schedule to educate us on the extremely relevant topic, role of colonoscopy and bowel preparation in anocolorectal diseases. We welcome you on stage, sir.
I would like to welcome Dr. M.K. Maheshwari, sir, an esteemed faculty in our Department of Surgery at our institute. Sir has a teaching experience of more than 25 years and various publications in national and international journals.
Sir has inspired numerous surgeons in the making and has been a beacon of goodwill and a pillar of support for all his students. We invite you on stage to chair the session, sir.
Good morning, everyone. So, an eminent faculty, thank you for the kind introduction as well. So, I would like to thank Subharti Hospital and Surgery Department for giving me this wonderful opportunity to present on this dais. Today, I'll be talking on role of colonoscopy and bowel preparation in colorectal disorders. And I would also like to thank Dr. Sachin Agarwal for presenting such an extensive talk, the last talk, as he has already discussed pathophysiology and clinical features of majority of the disorders. So he has made my job easy, though it was not planned between you and me, sir. So coming to the introduction, colonoscopy is essential for the diagnosis and management of various GI tract disorders. Presently, it is the standard investigation for assessing the mucosa of the entire colon. It is done mainly for the indications such as GI bleeding, abdominal pain, diarrhea, or any other indication based on the discretion of the clinician. The accuracy and safety of the procedure are highly dependent on colon cleansing, that is bowel preparation. Colonoscopy is a commonly used diagnostic and therapeutic procedure for colon disorders. It is basically inserting a flexible long colonoscope to different parts of large bowel up to cecum and terminal ileum through anal orifice. An experienced examiner can now successfully reach the cecum and terminal ileum in almost 100% of the patients. Its diagnostic spectrum encompasses macroscopic assessment of the condition of the mucosa, but also the possibility of collecting a targeted biopsy sample, and more recently, the use of dye spraying technique and magnification. The first successful colonoscopy was conducted in 1966 by Overholt and Pollard. It was done in UK. So there are some indications of doing colonoscopy. First, to find out the source of stool bleeding, like bleeding PR, or patient may present with melena, colon cancer, polyp checking, altered bowel habits, or maybe chronic constipation. Patient is having unexplained weight loss and unexplained iron deficiency. So the first two pictures are examples of adequate bowel preparation. We can see the mucosa very clearly. In the next, there are the bowel preparation is not so nice, so we can see it's an inadequate bowel preparation. So we may have a high chance of missing the pathologies in inadequate bowel preparation. Now coming to bowel preparation. So on the day of colonoscopic procedure, as on the previous day, clear liquid foods will only be allowed. The patient is not allowed to eat and drink anything 2 hours before the procedure. We can either give PEG, that is polyethylene glycol, or sodium picosulfate fleet enema. We can dissolve 1 packet of any one of these in 2 liters of fluid and ask the patient to consume. Patient will purge several times within few hours so that the bowel may get cleaned, and it can be done under IV sedation of midazolam, fentanyl, or propofol. Now, what is an ideal bowel preparation agent? An ideal BP agent should be effective, safe, tolerable, and should have a high compliance rate. Commonly used agents for BP include isoosmotic agents, that is high volume and low volume polyethylene glycol preparations, hypoosmotic agents, hyperosmotic agents, sodium sulfate, magnesium citrate, and sodium phosphate, and laxatives. PEG agents are the most commonly used bowel preparation agents, and several studies have assessed their safety and efficacy. It can be administered as a single dose on the same day or evening before, as 2 doses administered the same day or evening before morning of colonoscopy. Ingesting at least half the bowel preparation on the day of colonoscopy, that is known as split dosing regimen, is associated with higher adequate bowel preparation quality versus evening before dosing. Now, it was a study which was published in 2020, and it showed the importance of colonoscopy bowel preparation for the detection of colorectal lesions and colorectal cancer prevention. So in this study, it was shown that colonoscopy for CRC, that is colorectal cancer screening, has reduced CRC incidence and mortality and improved prognosis. Optimal bowel preparation and high quality endoscopic technique facilitate early CRC detection. High quality bowel preparation is integral for optimal CRC screening or surveillance by colonoscopy. Over the last 30 years, patients and providers have gained more options for bowel preparation, including low volume agents with enhanced tolerability and cleansing quality that are equivalent to 4-liter preparations. Split dosing is preferred for achieving a high quality preparation. Now we can do the preparation of colonoscopy like this, that a day before colonoscopy at around 7 p.m. we can ask the patient to have half pouch of the powder in 2 liters of normal water, and he can start consuming. Or the day of colonoscopy in the morning session, if the patient is having colonoscopy in the morning session, then we can ask the patient to take at around 6 p.m. the remaining half in 1 liter of water, and then he can start consuming. If the patient is having in afternoon or evening session, then he can start at around 11 to 12 p.m. Now, this is one scale. It is known as Boston Bowel Preparation Scale. So it has been divided according to the colon. So we can divide the colon in left colon, transverse colon, and right colon. So according to the regions of the colon, we have to see like whether the score 0 is it is unprepared colon segment with mucosa not seen because of solid stool that cannot be cleared. Score 1 could be portion of mucosa of the colon segment seen, but other areas of colon segment are not well seen because of staining, residual stool, or opaque liquid. Score 2 will be minor amount of residual staining, small fragments of stool, opaque liquid, but mucosa of the colon segment is seen well. And score 3 will be entire mucosa of the colon segment seen well with no residual staining, small fragments of stool or opaque liquid. So the bowel, according to this score, that is Boston Bowel Preparation Score, the ideal score is 9. So if we divide the colon in 3 segments, that is left colon, transverse colon, right colon, so it should be 3, 3, 3 in each segment. So it should be 9 for ideal score. Now it is a basic algorithm for selecting the optimal bowel preparation agent. So if there are any contraindications for bowel preparation, that is intestinal obstruction, perforation, or toxic colon, if yes, then we have to cancel the procedure and we have to consider alternatives. If there is no contraindication, then we have to look further if the patient is at risk of electrolyte or fluid imbalance. That is a patient who is a known case of CKD or CAD. So if the patient can take fluid, then we can ask him to take polyethylene glycol, or and we can ask him to avoid sodium picosulfate if the patient is at risk. If the patient is not at risk, then we can ask the patient for polyethylene glycol and sodium phosphate. So if the patient is concerned about tolerating full volume polyethylene glycol solution, if yes, then we can offer him low volume, that is around 1.5 to 2 liters preparation. If the patient is not at concerning, then we can give the patient around 3 to 4 liters of polyethylene glycol, especially if the patient is worried about cost or insurance coverage. Now, before doing a colonoscopy, we have to look for an anorectal examination. So first, we have done a preparation with a good BP agent. Then the position of the patient should be in the left lateral position. Second, the equipment, obviously a colonoscope should be there of high grade quality. Now, coming to the inspection of the local area, first inspection, we have to look for any skin rashes are there, fecal swelling or blood or mucus is there, any scars or fistula is present, any lumps are there, or any ulcers, especially fissures, are there or not. And trust me, not to land in this situation, that we definitely need to go for a colonoscopy so that we know what we are looking in for there. Now, role of colonoscopy in anorectal disorders, it can be divided into diagnostic as well as therapeutic. Now, coming to diagnostic, as we all know, hemorrhoids is the most common reason for doing a colonoscopy, as a patient usually present with bleed PR. So the etiological factors include vascular congestion. It could it derive from prolonged straining or increased intra-abdominal pressure due to ascites, obesity, or pregnancy, and mucosal prolapse that is developed secondary to derangement of internal sphincter, or through aging causing anatomic structures supporting muscularis submucosa to weaken, leading to prolapse of hemorrhoidal tissue. So classification of hemorrhoids can be done into external and internal. External hemorrhoids are situated distal to dentate line and are covered by enoderm that is sensitive to touch, temperature, and stretch because of innervation by somatic nerves. Coming to internal hemorrhoids, it are located proximal to dentate line and are graded based on the degree of prolapse. First degree hemorrhoids is they bleed and bulge into anal canal and prolapse beyond dentate line on straining. Second degree prolapse through anus but spontaneously reduce. Third degree, they prolapse through anal canal and require manual reduction. Fourth degree hemorrhoids prolapse but are irreducible and are thus are at risk for strangulation. Now, this is the colonoscopy view in which we have done a retroflexion. So retroflexion, we go into the rectum and we turn the big wheel up towards our side, and then we can see the retroflexion. So this is the anal sphincter, this one. This one is the anal sphincter, and these are the hemorrhoids. These are the external hemorrhoids, this one. This is also a retroflexion with hemorrhoids, and we can see a small polyp on the retroflexion. So in normal view, we can miss the small polyps which is in the rectum or in the maybe on the superior wall of the rectum. So with retroflexion, we usually does not miss the small pathologies like small polyp. Coming to the second condition, it is diverticulosis. It is uncommon cause of significant lower GI bleeding. It is more prevalent in developed countries and older patients. 70 to 80% are asymptomatic. Risk factors could be NSAIDs and advanced age. And it usually presents with abrupt painless bleeding. Most bleeding vessels or non-bleeding vessels identified during colonoscopy are located on the neck of the diverticulum. So this is how a colonoscopy picture of a diverticulosis is seen. So we can see the outpouching of the mucosa. It's basically it's like a well. We can see a well on the mucosa of the colon. So these are all diverticulum. This is, so we can see in this, the stool has been stuck in the diverticulum. That is the most common cause of patient having diverticulitis. That is, the patient will have inflammation of the wall of the diverticulosis, and then the patient will have features of diverticulitis. That is abdominal pain, fever. And in this picture, we can see it was a bleeding from it was a diverticular bleeding, and we have closed it with a hemoclip. This is another picture of a small diverticulum which is bleeding. Recognizable, it is recognized with a streak of blood. It is a diverticulum and a streak of blood can be seen. And this is another picture in which diverticulum is there, but a visible bleeding vessel, but it is now a clot with an adherent clot. Diverticulitis is basically, it is a bowel wall inflammation along the walls of the diverticulosis, along with the clinical features of diverticulitis. Coming to the third, which we usually encounter during colonoscopy, is polyps. It is in any uncircumscribed mass of tissue that arises from mucosa and protrude into lumen of rectum or any other area of colon. It is small clumps of cells that forms on the lining of the colon or rectum. It is common in children, particularly in first decade of life, but may occur in adults as well. It could be benign or malignant. Causes could be congenital, inflammatory, neoplastic, and others, that is pseudopolyps in conditions like ulcerative colitis or Crohn's disease, Crohn's colitis. The patient may present with streaks of blood in stool. Protrusion of mass during defecation can be one another presentation. It is usually painless, but if painful, then it is definitely infected. So this is the JNAT classification. It is a widely recognized classification in colorectal polyps, which we usually follow. So if it is type 1, so there's this technology which we have a button in colonoscope which we can use, and it is known as narrow band imaging. So the concept of narrow band imaging in colonoscope, as per say in any endoscope, is basically, so a colonoscope uses white light endoscopy. So a white light cannot differentiate between a normal and an abnormal structure until unless that abnormal structure is very much differentiated and can be seen on white light. So to see subtle lesions, we have to use an NBI. NBI is narrow band imaging. In narrow band imaging, what is done? We have to press one button. It is present on the colonoscope itself, and we can see the blue light which is coming through the colonoscope then. So blue light usually does not absorb blue light is not absorbed by the blood vessel. So as we know that any tumoral tissue will have neoangiogenesis. So any abnormal vasculature or any abnormal blood vessel which is present underlying the mucosa, it will be reflected by the blue light. So it will be seen totally different as compared to the normal tissue. So I'll show it to you. So type 1 will be, it will be likely, it will be a small serrated or a very flat lesion on the white light endoscopy, as we can see. And but on NBI, we can see it is easily differentiable from a white light as well as blue light. So surface pattern will be regular, dark or white spots. It will be similar to the surrounding normal mucosa. So the most likely histology will be hyperplastic polyp or sessile serrated polyp. Now coming to type 2. So type 2 has been differentiated between type 2A and type 2B. So in type 2A, we can see it, on white light, we can see a regular caliber and regular distribution. It is a normal pattern, regular. But on NBI, we can see it can be differentiated between a tubular, branched or papillary. So we can easily differentiate. So we can see that on first, it is not, it is a normal regular dark and white spots. But on second, we are seeing that it is a regular caliber and distribution, but the surface is not normal as compared to one. So we can easily say that it is a mainly an adenoma, and it should be a low-grade intramucosal neoplasia, and this type of polyp should be removed colonoscopically. Third should be a variable caliber or irregular distribution. So in this, we can see as compared to second type 2A and type 2B, you can see that there is a variable caliber and it is an irregular distribution. So the surface pattern is irregular and obscure, and it is definitely, in histology, it will come as high-grade intramucosal neoplasia or shallow submucosal invasive cancer. In such patients, we can do an ESD, that is endoscopic submucosal dissection. The last is loose vessel areas, interruption of thick vessels. It is surface pattern will be amorphous, and it will be a deep mucosal invasive cancer. As we can see, as we can compare from first and third, it is totally irregular as compared to first. And it is totally amorphous. So it will usually present as deep mucosal invasive cancer, and the patient has to go for surgery. So this is all the types of polyps. We can see it is a sessile polyp. This is a flat lesion. This is a pedunculated polyp. We can see a long stalk along with a pedunculated polyp. These all can be easily removed via colonoscopy. These are all some lesions. These are some syndromes are there with the polyposis, that is FAP, which we can see as familial adenomatous polyposis. This we have to remove every polyp. There are some lesions such as some syndromes like HNPCC and many other things. So these are some polyposis syndromes which can easily be diagnosed on colonoscopy. Now coming to the one of the most common etiology for which colonoscopy is done, which is known as IBD, which can be differentiated into Crohn's and ulcerative colitis. So among the common endoscopic feature of UC, that is ulcerative colitis, is seen within the colon are edema, erythema, mucosal friability and bleeding, erosions, ulcers, and loss of typical vascular pattern. These features, so this is these type of polyps are known as pseudopolyps. These are the ulcers which we can see on colonoscopy, and these are the ulcers along with the erythema and edema and loss of vascular pattern. There are no blood vessels which we can see in this picture. These pictures are seen within an anatomical disease extent categorized endoscopically into proctitis. Proctitis is basically if the disease is covering only the rectum. Proctosigmoides if the disease is covering rectum and sigmoid. Left-sided colitis if the disease is present till splenic flexure. And extensive colitis is if the disease goes beyond splenic flexure, then we grade the disease as extensive colitis. Other endoscopic designation associated with UC include backwash colitis and a cecal or periappendical patch. So this is an ulcerative proctitis. It is only involving the rectum. As we can see, this is the normal mucosa beyond, and this is the rectum part. This is backwash ileitis. That is the along with the extensive colitis, the disease is involving the terminal ileum as well, which is usually not present in ulcerative colitis in majority of the cases. And the third one is like backwash ileitis with widely patent IC valve. So this is the IC valve, this is the cecum, and this is the ileum. So we can see there are ulcers present on the IC valve as well. So assessment of disease activity through colonoscopy. So there are numerous scores, but the most common and the most validated scores are two. That is Mayo score and UCEIS score. That is ulcerative colitis endoscopic index of severity. Now this is one more example of Crohn's colitis, as it was already discussed by Dr. Sachin that Crohn's colitis is usually a disease of small bowel, but it can affect large bowel as well. But it is, let me tell you that it is sometimes it becomes very difficult how to differentiate between an ulcerative colitis and a Crohn's colitis. So recently I had two patients, they were getting treatment for ulcerative colitis. The disease was present in splenic flexure for one patient, the other patient disease was present in the transverse colon. So they were not responding to a normal regimen of ulcerative colitis. They came to me for a second opinion. I did a colonoscopy. It was definitely a Crohn's colitis. I started the patient for a treatment of Crohn's colitis, and within 3 months, there was no mucosal disease. Histologically, they was present because I took specimens, but mucosal, it was totally all gone. So coming to the another, which is an angiodysplasia, it is the most common, it is one of the most common cause of lower GI bleeding in 3 to 40% of patients. More than a half is located in the right colon, result from degeneration of submucosal venules, risk factors for bleeding. It should be usually suspected in patients which are older than 60 years, right-sided location, and certain conditions like aortic stenosis and chronic renal failure are the most common cause of angiodysplasia. So there is a syndrome which is known as Hayday syndrome. So if a patient is having aortic stenosis along with a history of melena, we should definitely go for colonoscopy to look for angiodysplasia. So this is how angiodysplasia looks like. It is a abnormal submucosal venules. It is a dilatation we can see, and this is another example of radiation colitis. Coming to the next etiology, which is known as ischemic colitis, it basically happens because the blood flow to the part of the large intestine is temporarily reduced. It is due to the narrowing of the blood vessels supplying the colon and lower blood pressure. Diagnosis is established by the combination of clinical setting, physical diagnosis, and diagnostic studies. One more etiology which we usually encounter and we have to suspect is pseudomembranous colitis. It has been already discussed, but the etiology is Clostridium difficile infection. So this is how a pseudocolitis is seen. We can see a pseudomembrane on the mucosa of the colon. And this is a ischemic colitis. So basically in books it is written, but usually we doesn't say, it is known as a strip sign. So we have to see on colonoscopy if the patient is having ulcers and the patient is having bleeding PR. So this is how a strip of ulcers will be seen. This is known as a strip sign, but it is present only in around 28% of patients. Usually 70% of patients will not have this strip sign. This is how a carcinoma of a colon or a rectum is seen. So we usually encounter with a ulceroproliferative or a proliferative infiltrative lesion in the colon or a rectum. So by macroscopically 99.9% we can usually say that the patient is having CA. Now coming to the therapeutic procedures which is associated with colonoscopy. So coming to the general information, it is an important arm of modern minimal access surgery. So it can be used for following areas, that is for hemostasis, resection, decompression, and extraction of the tissue. Now coming to the polypectomy, as we have seen a polyp, now we have to remove a polyp. So different methods are there. Smaller polyps that is less than 5 mm, we can use a cold forceps or a cold snare. Larger polyps that is maybe more than 5 or 10 mm, we can use a hot snare or hot polyps. That is, we have to use an electrocautery for that. We can do a tattooing of a polypectomy site. There are certain complications of post-polypectomy. Complications could be bleeding and perforation, but that can be easily manageable if we know that it has happened. So snare polypectomy for removal of polyps less than 1 centimeter or greater than size. Snare is self-contained metal ring that is opened over the polyp and then closed, entrapping polyp tissue for resection by closing the rim. Types of snares are oval and hexagonal. Barb snare is there, and crescent snares are there, which is used in endoscopic mucosal resection. High definition colonoscopy, chromoendoscopy, and narrowband imaging are useful to enhance polyp detection. Confocal laser endoscopy is an enhanced mode of polyp classification, and it is now evolving technology. In West, it is definitely used. In India, it is still not so used regularly. So this is how a snare polypectomy is done. We can see in this picture, it's a long stalk polyp. It is a pedunculated polyp. So we have hold the stalk with the help of a snare, and then we'll just cut it with the help of electrocautery. This is a sessile polyp. We will first inject it with a submucosal saline. We'll make a submucosal lift. We'll catch it hold of with a snare, and then we'll just cut it off. So this is how a post-polypectomy area should look like without a target sign. So if we are seeing a target sign at this site, that means we have done a perforation. So endoscopic mucosectomy, that is EMR, a procedure to remove precancerous early stage cancer or other abnormal tissues, lesions from GIT. Other indications for doing an EMR are Barrett's dysplasia in upper GI, esophageal squamous dysplasia, and small bowel and colorectal adenomas. It is less invasive alternative to surgery. So this, as we can see, this is, as we know that this is a mucosa, this is submucosa, and this is muscle layer. So EMR can be done till submucosal lesion, like if the lesion is present in mucosa, not involving the submucosa, or if it is involving the first part of the submucosa, that is SM1. Till that we can do an EMR. So we have to do a submucosal lift by injecting, as we can see in this picture, we are injecting. We can do with a normal saline along with methylene blue, and we can add an ADR in the submucosal space. We'll do a submucosal lift like this, and then we'll catch hold of the submucosal lift with the help of a snare, and then we'll just cut it off. In this, we can see that this is the help of a chromoendoscopy. We have made the polyp and the lesion little, we can see it better. Then with the help of a submucosal lift, we have hold it with the help of a snare. And this is how after EMR, we can see the lesion. In this, we have done a piecemeal EMR. That is, we are doing it step by step. Now, this is one more modality which is known as endoscopic submucosal dissection. It can be done if the lesion is present till submucosa, not beyond submucosa. So we have to do a marking with the help of a APC or a cautery. We will make a lesion make the lesion surrounded by a help of APC or cautery. Then we'll do an injection. We'll first cut the mucosa, then we'll do a dissection, and we'll continue proceeding the dissection, and we'll remove the complete resection. So this is how ESD is done. So basically the difference between submucosal resection and ESD is basically EMR and ESD. In EMR, we need not do a dissection. We need not remove the submucosa. But in ESD, we have definitely do a dissection, and we have to remove a submucosa. So there's one more etiology I have not completed in this. This is known as EFTR, that is endoscopic full thickness resection. Now there is a device which is being introduced by FTRD, and Ovesco is a company. It's so less than 2 centimeters. Resected tull serosa. We can resect the lesion of 2 centimeter, less than 2 centimeter, through and through. The patient need not go for surgery. If the lesion is less than 2 centimeter, we can definitely go for it. One more therapeutic procedure for colonoscopy will be a self-expandable metallic stent. It is a minimal invasive treatment for palliation of malignant colorectal strictures, and it is a bridge to surgery. For acute colonic obstruction in case of benign pathologies, as a bridge to surgery, avoiding emergency surgery. So this is a SIMS which was done for malignant stricture. So placement of metal stents is combined with balloon dilatation or bougie. So we can see in this picture that it's a stenosis which was caused by a tumor at a rectostigmoid junction. And we can see a livid color feces after balloon dilatation. So we have placed a wall stent. Wall stent is basically a stent which is by Boston Scientific. It's a partially uncovered, and this is how after dilatation we can see these are the stents which has totally engrossed. So now coming to the last topic, which is hemostasis for colorectal pathologies. It is one of the common of doing a colonoscopy also. So after tissue sampling through biopsy, partial or total removal requires the ability to assure hemostasis. In different colorectal conditions like angiodysplastic lesions, including vascular ectasias, through AVMs, telangiectasias of radiation proctosigmoides, polyp stalks, or malignancy. So hemostasis tools could be thermal. It could be done by a contact, that is a heater probe or a APC. Non-contact will be APC. Mechanical could be needle injector. It could be through the scopes clips or OTS clips, and it could be will be a hemospray. So hemostasis in colorectal pathologies can be done by coagulation of an angiodysplasia using an APC, that is argon plasma coagulation. So this is an angiodysplasia which we can see easily. So through the APC probe, we are burning the lesion. We have to keep the APC probe around 0.1 to 0.2 centimeter proximal to the lesion, and then we have to just spray. So the most common cause, which is known as spray coagulation, which is used, and it's actually very easy to do. Second is endoscopic hemostatic clip application. So if we can see a lesion is there and an underlying blood vessel is there, we have to attach a cap, a distal cap. We have to go and suck the mucosa. The underlying blood vessel can be seen, which is coming through the cap, and then we have to just place a hemoclip over the underlying blood vessel. So this is where we can see a bleeding, a blood is coming. We are going with the distal cap, we suck, and then we have placed a hemoclip. This is a diverticular bleeding. Now coming next is endoscopic band ligation. It is almost similar like an endoscopic clip application. In this, blood is coming in this. We can see there is a blood. We have already placed a hemoclip in the same patient. We have actually marked it with the help of a hemoclip so that we know the site where band application to be done. We'll just suck it with the help just like an EVL, and then we'll just paste a band. Now coming to the last, it is OTSC application. As I was already telling you, it is known as over the scope clips. So this is how over the scope clips is seen as. It is known as Ovesco clips as well. So we can see sharp jaw-like structures on the clip. We have to load it on the colonoscope. This is how it is being loaded. So this is known as a twin grasper. We have to take, so this twin grasper has two edges. So one edge is this, one edge is that. So it helps in closing a bleeding or a perforation. So with the help of a twin grasper, we can take the both the ends of a site. That is, if perforation or bleeding is there, we'll catch hold of both the sides, right and left side, and we'll place an Ovesco clip. And this is how a mucosa will be seen after placing a Ovesco clip. So it will just catch hold like a jaw of a tiger, and it will just close the mucosa. It could be help in bleeding or perforation. So thank you, and thank you for giving me the opportunity for presenting such a nice topic. And in the end, I would like to just be nice to your patient, suction air out before terminating the procedure.
Thank you, Dr. Achal Garg. Recently, he has joined Meerut as a private practitioner, and he has given a nice talk. He has covered the topic very well, how to prepare colon. And it is a important thing for residents that before submitting the patient for colonoscopy, how to prepare it. Unless the bowel preparation is good, they cannot give comments and they cannot diagnose properly. He has covered nicely the indications for colonoscopy and what therapeutic help we can have in different pathology, and nicely he has covered the topic, I said. Thank you.
Thank you, sir, for such knowledgeable talk. Now I request Dr. M.K. Maheshwari, sir, to facilitate Dr. Achal Garg, sir.
We may now request Dr. B.K. Jain, sir, to please be on stage and facilitate Dr. M.K. Maheshwari, sir. Thank you, sir. This is to request you to all the delegates, our faculty members, and our residents and colleagues to please proceed towards the breakfast. Till the meantime, we proceed with the inauguration ceremony. Thank you. Good morning, everyone. Thank you to each and every one of you for being here today. We bring you warm welcome from the Department of Surgery and the Organizing Committee of Surgery Update 2023. Netaji Subhash Chandra Bose Subharti Medical College is one of the finest medical colleges of the northern India. It is a constituent college of Subharti Swami Vivekanand Subharti University, Meerut. The college is located in a majestic building within a vast, sprawling campus, furnished with the latest and the best available audio-visual teaching aids such as LCD visualizers, electronic teaching boards, etc., providing in all lecture theatres, departments, and teaching points. The lectures are collaborated with practical exercises in each and every department having its own individual laboratory. The faculty members of the college, apart from teaching undergraduate and postgraduate students, are actively involved in research activities and have presented research papers at various national and international conferences in respective specialities. They have a number of publications to their credit in national and international journals. Many of them have even authored books on their own subjects. Various guest lectures, CMEs, symposia, seminars are being organized at a regular intervals for the faculty members and students to continuously upgrade their knowledge. The medical education unit of the college regularly holds workshop to upgrade the teaching skills of the faculty members.
The postgraduate department of surgery is undertaking all the general surgery, major and minor, specialist surgeries like neurosurgery, urology, burns and plastic and reconstructive surgeries, oncosurgery, GI surgeries, laparoscopic surgeries, endosurgeries, and including minimal invasive surgeries. The highlight of the operative surgical works are laparoscopic surgeries including lap cholecystectomy, lap appendicectomy, lap hernia repair, diagnostic laparoscopy, and other laparoscopic surgeries as and when required. Urology includes both open and endourological surgeries like operations on prostate, surgeries for stones, surgeries for stricture urethra, TORP, OIU. Neurosurgery department is well established and includes the elective and emergency neurosurgeries for EDH, intracranial single occlusion lesions, hydrocephalus, and surgery for congenital pediatric neurosurgical disorders, burns, plastic, and reconstructive surgeries, including flaps, skin grafting, reconstructive procedures, cosmetic surgery, oncosurgery, cancer surgeries for breast, head and neck cancers, GIT and genitourinary tract cancers, thoracic surgeries like thoracoscopy, thoracoplasty, thoracotomy, lobectomy, and decortications, etc.
Recently, Subharti has inaugurated Subharti Institute of the Cancer Management and Research, which aims to provide correct and best treatment with as well as supportive and rehabilitation. Tumor Board is a team of different specialty that are involved in the management of cancer treatment. Example, the radiational oncologist, surgical oncologist, medical oncologist, specialty surgeon, radiologist, pathologist, genetic counselor, etc. Every case is discussed in tumor board to decide the plan of treatment, sequence of treatment, and any special way to manage some unique cases. This multimodality approach is associated with the best hang of cure and higher quality of life. SIGMAR is a unique center like AIMS that has a separate wing for treatment of cancer patients. It has various department of oncology that is involved in the care of cancer patients. For example, high-tech radiation oncology department equipped with laser robotic linear accelerator called the True Beam Liniac, fully computerized high dose rate brachytherapy machine for internal radiation, Gamma Mediplus IX with 24 channels, real-time position management system RPM for management of moving tumors, expert and experienced team of the oncologists, surgeons, and support staff from many prestigious institutes of India like AIMS, TMH, PGI, etc. Patient-friendly and comfortable onco daycare wards, nuclear medicine department, state-of-art of OT complex, and surgical oncology department, which is the upcoming one. Medical oncology department, molecular and genetic labs, physiotherapy and rehabilitative treatments. SIGMAR provides excellent service in medical oncology, radiation oncology, surgical oncology, and pediatric oncology.
Now we proceed for lamp lighting. Every educational journey is incomplete without the divine blessing of Goddess Saraswati. Light is a symbol of life and knowledge. It drives away the darkness of ignorance from mind and illuminates it with knowledge. So, to mark the beginning of the auspicious journey, may I request the student to evoke the blessing of the divine power by lighting the ceremonial lamp. Shubham karoti kalyanam arogyam dhan sampada Shatru buddhi vinashaya deep kale namastute. I pay my salutations to the light, which brings auspiciousness, prosperity, good health, abundance of money and wealth. Today, we are extremely privileged to welcome Dr. Shashank Mishra sir, Head of Department of Surgery, and Dr. Shailya ma'am, CEO of Subharti Charitable Trust, Dr. YP Munga sir. I request Dr. Shekhar to escort the faculty for the lamp lighting ceremony. Dr. YP Munga sir, Principal of Subharti Medical College. Dr. Satyam Khare sir, Vice Principal of Subharti Medical College. Dr. Pradeep Bharti sir, HOD and Professor of Department of Neurosurgery. Dr. M.K. Maheshwari sir, Professor Department of Surgery. Dr. Sanjay Pandey sir, Professor Department of Surgery. Dr. Tripta Bhagat ma'am, Vice Chancellor Santosh Medical College. Dr. Shalabh Gupta sir, HOD Department of Surgery, Santosh Medical College. Dr. Bhavna Rastogi ma'am, HOD Department of Anesthesia. Dr. Mamta ma'am, Department of Gynae. Dr. Krishna Murthy sir, HOD Department of Emergency Medicine. Dr. B.K. Jain sir, पहले lightning को बताने दो, पहले lightning को बताने दो। सरस्वती वंदना है पूजा के साथ।
माँ सरस्वती शारदे, माँ सरस्वती शारदे, पूर्ण ईश अज्ञान उदधि से, पूर्ण ईश अज्ञान उदधि से, मीरा पाणी तार दे, तार दे, तार दे, माँ सरस्वती शारदे, माँ सरस्वती शारदे। सरस्वती, सरस्वती शारदे, माँ शारदे, शारदे माँ शारदे, सूर्य ब्रह्म शिव विष्णु गजानन, जिन चरणों को सेवते, सूर्य ब्रह्म इन चरणों को सेवते, हम शिशु है अज्ञानी माता, इन चरणों का प्यार दे। वीणा पानी तार दे, तार दे, तार दे, माँ सरस्वती शारदे, माँ सरस्वती शारदे। मूर्ख हम नहीं जाने जननी, पूजन वंदन ध्यान को। मूर्ख हम नहीं जाने जननी, पूजन वंदन ध्यान को। आदि शक्ति कर क्षमा हमें, आदि शक्ति कर क्षमा हमें, पूजा के उद्गार दे। वीणा पानी तार दे, तार दे, तार दे, माँ सरस्वती शारदे, माँ सरस्वती शारदे। सरस्वती, सरस्वती शारदे, माँ शारदे, शारदे, माँ शारदे।
Thank you. We feel extremely privileged to stand before you, and it's an absolute honor to call on stage Dr. Shashank Mishra, sir, professor and head of Department of Surgery, a postgraduate from LLRM Medical College, Meerut. Sir has attained fellowship in minimal access surgery, fellowship in Indian Association of Gastrointestinal Endosurgeons. Sir is also a fellow of International College of Laparoscopic Surgeons, a fellow of Association of Indian Surgeons during the period from 2012 to 2014, and has also achieved 2 copyrights for surgery literature, one in the field of safe gallbladder surgery by formulating evidence-based ICH-BS scoring system in 2018 and 2019, and second for developing a computer software with the name Gallbladder Walk on Play Store for Android platform in the year 2019. To share a few words with us, please.
Thank you, Aman. Jai Hind, and a very warm welcome to Dr. Shalya Raj, CEO, Dr. YP Monga sir, Dr. Pradeep Bharti Gupta sir, Dr. Satyam Kare sir, Dr. Krishnamurthy, head of departments, and all the faculty and delegates. It's my proud privilege to welcome you all to the Subharti Surgery Update 2023 with a focus on the basics as well as the recent advances in the management of anocolorectal disorders. In this conference, speakers and delegates from Uttarakhand, Uttar Pradesh, Delhi, and Haryana are participating. Just to name the few, speakers from AIIMS Delhi, AIIMS Rishikesh, and RML Lucknow, in addition to learned speakers from other medical colleges, will contribute in this academic feast. We have also included minimal access surgery approach in addition to the open surgery basics and management of anocolorectal disorders. From last year 2022, we started with Subharti Surgery Update on regular basis in the month of April every year. Now this year, we are conducting a PG quiz and poster presentation. And from Subharti Surgery Update 2024 onwards, we are planning to include free paper presentations and operating video case presentation. I think that is all from my side. Once again, I welcome all of you for this academic journey. Jai Hind.
Thank you so much, sir, for such words. And we may please request on stage Dr. M.K. Maheshwari, sir, Professor, Department of Surgery, Organizing Chairman, Surgery Subharti Update 2020, previous year, Vice Organizing Chairman 2023, to felicitate Dr. Shashank Mishra, sir, Organizing Chairman, Surgery Update 2023, current year, with good wishes.
Thank you so much, sir. We may now request Dr. Krishnamurthy, sir, DMS Subharti Medical College, Head of Department of Emergency Medicine, a young dynamic surgeon with equally brilliant administrative skills. Whenever surgery stepped on a ladder of success, he was the one who made it possible with his amazing and exceptional skills. He settled for nothing less than precision and excellence. For him, patient care is the utmost, and we can always find him round the clock in the hospital. Subharti made a benchmark in management of COVID cases during the pandemic. The institute was appreciated for its splendid performance, and person behind was none other than Dr. Krishnamurthy, sir. Sir, can we please have you on stage, please?
थैंक यू फॉर हैविंग मी ऑन स्टेज. इतनी सारी चीजें तो मुझे अपने बारे में भी नहीं पता थी. It was a good trend that we tried to start last year, and it is good to see that we are continuing with this. And मेरा बस before I get down, because there are so many senior people जिनके सामने मैं क्या बोलूं, मेरा बस ये request है to all the different colleges कि rather than it being considered as Subharti surgical update, it should be considered as a collaborative event of all our medical colleges. We should have कि हर साल फर्स्ट वीक ऑफ अप्रैल के आसपास, इस साल थोड़ा लेट हो गया, बट फर्स्ट वीक ऑफ अप्रैल के आसपास वी शुड गेट टुगेदर एंड see what are we doing and have a collaborative effort to get some academic excellence. So rather than having it as Subharti surgical update, it should be something that all of us are doing as a combined approach. That is all, and I hope we get something good out of this session. Thank you.
Now I request Dr. Satyam Khare, sir, to kindly felicitate Dr. Krishnamurthy, sir. Moving ahead with the ceremony, I request Dr. Pradeep Bharti, sir, MCH Neurosurgery and Head of Department of Neurosurgery, to kindly come on the stage and address the faculties and dignitaries with their words.
Thank you for the surprise for calling me on the dais. It's nice to be in the institution which you have seen born and grown up, especially with those who have studied with you, whom you have taught, whom you have mentored. They are making such an excellent institution in your parallel in the same city. I am proud of you, all of my students who are now professors and heads of departments. I wish you all the best for your future journey. I'm always with you whenever you need me. Thank you. Thank you.
Thank you so much, sir. We may now request Dr. YP Monga, sir, to please come on stage and facilitate Dr. Pradeep Bharti, sir.
Next, we would like to call on stage Dr. Y.P. Munga, sir, Principal and Dean, Netaji Subhash Chandra Bose Subharti Medical College and Associated Hospital. He is a profession-driven professional with nearly 47 years of experience in surgery. He is an alumni of Armed Force Medical College, Pune, passed in October 1975, and he has been 13 years rising to the rank of Surgeon Vice Admiral. He has also been an honorary surgeon to the President of India during his tenure as DGHS to the Armed Forces. He has been on the editorial board of several medical journals and also headed the Armed Force Medical Research Committee. Sir, it is an absolute honor to invite you on the stage to share some words with all of us.
Good morning to everyone, and thank you for inviting me on the stage. It's a great honor to be given an opportunity to speak. I congratulate the team headed by Dr. Shashank Mishra for organizing this, and also Dr. Krishnamurthy always backing the efforts at every step and always improving the efforts for organizing this excellent CME. And I'm sure it will go a long way for enhancing our knowledge in a very important subject. And that's all I have to say. And I wish the organizers the very best. I'm sure it will be an excellent CME. Thank you.
Thank you so much, sir. May we please request on stage Dr. Sanjay Pandey, sir, Professor, Department of Surgery, Vice Chairman, Surgery, Subharti Update 2023, to please facilitate Dr. Y.P. Munga, sir. Yananda, sir. Next, we may please request on stage our next patron, Dr. Shalya Raj ma'am, who did her graduation from SDM College of Dental Sciences, Dharwad, and completed her master's in conservative dentistry and endodontics from Subharti Medical Dental College. Her keen interest in academics was reflected in the fact that she has published numerous research papers, articles, books early in her career. She is also a guide to few selected students pursuing research. She is a popular teacher, academician, good clinician, and above all, a dedicated human being. It is these qualities that make her an integral part of all cultural and social events of the university. She is a trained Kathak dancer, a Hindi classical singer, and her efforts have won her various accolades in the field of painting, craft, and drama. Dr. Shalya Raj has received over 25 awards for her work in the social academic field, the Empower Women Prosper India Award by Globe Media, under her guidance. The Trust received the award of the Globe Peace Ambassador conferred by Avyat. The Trust has also received appreciation for donation from the Army Welfare Fund and CM Relief.
Thank you so much. Jai Hind. I welcome all the esteemed dignitaries who've come to our beautiful campus today. Thank you for taking out time and coming. I congratulate the Department of Surgery for organizing such a beautiful CME today, and especially Dr. Ruchi, not Dr. Shashank, because I motivated her. I was like, ma'am, ye to karna hi karna hai. I'm sure you must be already doing it, but it is always the better half who should be congratulated. Department of Surgery is very, very close to my heart. Also Department of Medicine. इसके बहुत सारे reasons हैं. सबसे पहला reason है मेरा नाम शल्य है because it's शल्य चिकित्सक. शल्य चिकित्सक is शल्यक surgeon की बेटी. So my father, Dr. Atul Krishna, is a surgeon. So I also wanted to be a surgeon. However, he decided that I should not be a surgeon but a dental surgeon. But अब जो parents कहते हैं हम पहले ज़माने में ऐसे ही होता था. I mean, आप सब लोग भी पहले ज़माने वाले हैं, but हम उससे कम पहले ज़माने के हैं. But हमारे ज़माने तक भी ऐसा ही होता था. However, so one reason is that. The second is Dr. Sanjay has been my teacher also. However, after that, I chose to go to Dharwad. And Department of Medicine, for obvious reasons, my mother was a professor of medicine. So I'm very happy today that we have such a beautiful CME, and I'm a part of it. So thank you for having me here. I will not say anything about surgery because I'm sure that all of you stalwarts, all the stalwarts of the field are sitting here, so I have nothing to say about it. I will just say that it's a beautiful function, especially the opening of it. I think the students sang beautifully, and especially because I am more into dancing, so I would like to congratulate the girl who danced. Can you come here, please? What is your name? Ashwarya. Ashwarya बोला ना तुमने क्या? What is your field? MBBS. तुम्हें एक पायल भी पहननी चाहिए. I will gift you one. You come and meet me in my office tomorrow. Okay, I will be able to arrange it by tomorrow. आज नहीं है. So you danced beautifully. All of you sang beautifully. So it was a beautiful start of the session with a beautiful cultural program. Sir कह रहे थे कि my mother would have been here. She would have appreciated it. But all of us appreciated also. She made sure that we learned all of it. So Krishna also sings. I mean, Dr. Krishna also sings beautifully. And you should make him sing sometime. अगर आप सब लोग उसके सीने से छोटी छोटी रैगिंग अभी भी करा करिए. जूनियर बैचेस के लिए तो बंद है, सीनियर बैचेस की रैगिंग हो सकती है. So and after first year nobody can complain. तो अब तो वो कौन तुम क्या हो असिस्टेंट या एसोसिएट तक पहुंच गया सा. He can be ragged. So I will just say that I am sure the ending part of the ceremony can end with a song by him. So have a very, very educative session. I will just say that have a very beautiful educative session. And again, I thank all the dignitaries and all the Ma'am Vice Chancellor and all the I don't know name of everyone, so I'm not taking names, but I welcome you all. We have a very wonderful, beautiful campus, a beautiful medical college, a wonderful hospital. So please do visit all the departments, not just the surgery department. And the surgery department has a lot of branches. We do a lot of work here. I hope you can appreciate all of it. I'm very proud of it. I'm sure we can make you as proud of it. We can have some association with your faculty and students who can come and do a faculty exchange or a student exchange and take research forward, something like that. So I hope you have a very educated session and have a wonderful, knowledgeable day today. Thank you. Jai Hind.
Thank you so much, ma'am, for your May we please request on stage Dr. M.K. Maheshwari sir, Professor, Department of Surgery, Vice Chairman, Surgery Subharti Update 2023.
The session will be moderated by Sanjay Pandey sir, who is currently Professor, Department of General Surgery, Vice Chairman Subharti Surgery Update. He's been an extraordinary teacher to the undergrads and postgrads. Sir has been associated with Subharti since 2010 and has witnessed major milestones in our Department of Surgery.
Thank you, Dr. Tripta, Dr. Maheshwari sir. Jai Hind, I welcome you all to Subharti Medical College. When we were planning some anal colorectal problems, Dr. Shashank asked me to conduct some session. Then I thought what to say, what to speak about. What I found the most difficult thing was the complex anal anatomy to understand, more complex than the colon or the rectum. And believe me, till today, I know a very much little about the complex anal anatomy. And you will be surprised to know all the diseases, the basis is the anatomical facts behind it, all the anal diseases. So I try to decode these anatomical or physiological changes which are there, which are the pathogenesis of the various diseases. So I requested many people who have done quite a lot in this field. I have got two sets of people. Number one, the decoders. And number two, the explainers. So I will first request the decoders to come and decode the number one point, the complex anatomy. For that, I'll request Dr. Shobhit to please come and decode this complex anal anatomy. My request to all the speakers, be very precise, very crisp, so that everybody should understand and be attentive. Thank you.
Thank you, sir. I'll be dealing with the anatomy of the anal canal, and I'll be adding a very brief note on the physiology of defecation. And my talk would be dealing with these following subheadings: the location and extent of the anal canal with its dimensions, the relations, the interior of the canal, the sphincter mechanism, the surgical planes and spaces, the blood supply, nerve supply, and the lymphatic drainage. And finally, I'll end with the physiology of defecation. So, as we all know, the anal canal is the terminal most part of the GIT, and the surgeons and anatomists have always differed regarding the definition and discussion of this anatomy of the anal canal. So instead of getting into that, I'll just take a middle path and try to be very brief. I'll quickly talk about the basic anatomy, and I'll emphasize on the points which are more important regarding the surgical aspect. So we can see that the anal canal is situated in the posterior half of the perineum, that is the anal triangle, which you can see here. I hope it is visible. And it is bounded anteriorly by the perineal body and attached to the terminal part of the coccyx with the anococcygeal raphe. The extent again is debatable, but basically it extends from the pelvic diaphragm here to the anal verge, which is here. And we can see that the anal canal is anterior and slightly inferior to the terminal part of the coccyx by around 2 to 3 centimeters. And in front, it is related to the apex of the prostates in males. This diagram shows that the various coverings of the anal canal, which are continuing from the coverings of the rectum, that is the internal muscular layer that is circular, and the outer longitudinal layer. So these layers, they when they enter the region of the anal canal, they get modified, which I will deal with in a minute. Talking about the dimensions, again, as you can see, the anal canal surgically can be said to be between the anorectal ring, that is located at this level, and the anal verge, whereas the anatomical anal canal is usually described to be from the dentate line, which I'll describe again very shortly, to the anal verge. So it is roughly between 3 to 4 centimeters, according to what definition we go for. Now, talking about the relations, the antero-posterior relations in this figure showing the male relations, the posterior relations are both common for males and females. That is the anococcygeal body posteriorly, and in males anteriorly it is related to the perineal body, the bulb of the penis, the urogenital diaphragm that is here, and we can also include the membranous urethra. In the female, as I said, the posterior relations are the same, but in anteriorly, there is the perineal body and the lower part of the vagina. One small point I'd like to add here is that in females, the longitudinal muscle is slightly deficient, and there is also a deficiency in the transverse peninae muscles. So that makes the females more prone for anterior fistulas, right? Because of the deficiency in the anterior wall of the anal canal. So anterior fistulas are seen to be more common in females. And laterally, the anal canal is bounded on each side by the ischiorectal fossa, or we also call it now the ischioanal fossa, which is on both the sides. The yellow part you can see, which is filled with fat, and it is surrounding the anal canal posteriorly, so that both the left and right ischioanal fossae are meeting on the posterior of the anal canal. Then when we come to the interior of the anal canal, again, we can see that the anal canal can be divided into multiple zones, basically 3 zones, starting from the anorectal ring here. There are presence of vertical mucosal folds, which you can, I hope you can see them. These are the anal columns of Morgagni. These are around 6 to 10 in number, and on their basis, they are connected by semilunar folds, which are known as the anal valves. So these anal valves include a potential space, which is known as the anal sinus, which we'll see later. The anal valves and the anal sinuses form this some sort of zigzag line, which is known as the pectinate line or the dentate line. After that, this forms a watershed region, both developmentally and otherwise, regarding the vascular and neural supply. Again, I'll deal with it. And in the lower part of the anal canal, we can see this groove. So this is known as the intersphincteric groove, or also known as the white line of Hilton. One more point that is more important surgically is the submucosal tissue that contains these blood vessels. This submucosal tissue, this extends inside the anal canal, and especially if we see the anal canal in 3 o'clock, 7 o'clock, and 11 o'clock positions. This projection of the mucosa, because of the vessels in the submucosal space, these are known as anal cushions. So these anal cushions are the reason for the anal continence in the normal resting phase, right? So these 3 anal cushions provide continence to both fluid and flatus. Now, very importantly, the anal mucosa, this is changing as we go from proximal to distal end of the anal mucosa, the anal canal. So initially in the proximal part of the anal canal, this region is having the columnar epithelium, you can see, which is the continuation of the rectal columnar epithelium, and it converts into cuboidal epithelium just before the dentate line. So this transitional zone where the columnar epithelium converts into cuboidal epithelium is known as the pecten. And this should be differentiated from the pectinate line, which is actually the lower margin of these anal columns, right? So pecten is the transitional zone where the mucosal lining is changing, and pectinate line is the lower margin of the anal columns. Then below this zone is the mucosa changes into a stratified squamous non-keratinized type of epithelium, and which obviously differs from the skin in the absence of sebaceous glands, sweat glands, and hair follicles. And below or distal to the intersphincteric groove or the white line of Hilton, the mucosa gets converted into the keratinized type, which includes the sweat glands, sebaceous glands, as well as hair follicles. So this is the differentiation of the anal mucosa from one zone to the other. Now, very importantly, the anal sphincters or the sphincter mechanism. This is composed of multiple muscular layers. So starting from the top, you can see the muscle that is the puborectalis, which connects to the pubis anteriorly, and it winds around the lower part of the rectum at the anorectal junction. So it pulls this junction forwards, and because of that, the anal canal is directed posteriorly and backwards because of this pull on the upper end, right? So the other sphincters, the other muscles which form the sphincters are the internal anal sphincter, which is the continuation of the circular muscle layer of the rectum, and the external anal sphincter, which is again divided into a deep part, a superficial part, and a subcutaneous part. Out of these, as you can see, the superficial part has some bony connections posteriorly to the tip of the coccyx, and anteriorly it is connected to the perineal body. Apart from that, these sphincters do not have any bony connections. This is a sagittal section, sagittal image of the same sphincters, as you can see. So the circular muscle layer of the rectum converts into the internal anal sphincter, which is over here. And the longitudinal layer of the rectum continues as the conjoint longitudinal layer, which separates the internal anal sphincter internally from the external anal sphincter externally. And as you can see, the external anal sphincter is divided into a deep part, a superficial part, and a subcutaneous part. However, these are somewhat divided by the projections of fibers from this conjoined longitudinal layer, which divides these various parts into separate compartments. Now, just a brief about the anal rectal ring. This is the junction between the rectum and anal canal, and it is a swelling. In the rectal examination, it can be felt. It is the swelling formed by the puborectalis, which I showed you earlier, the deep external sphincter, and the upper part of the internal anal sphincter. So this is the surgical beginning of the anal canal. Very importantly, I'll talk about the intersphincteric plane. This is a surgical potential space between the conjoint longitudinal muscle fibers and the external anal sphincter. So if there is any surgery that is required for the rectum or the anal canal, this space can be used for the access, right? So this is the, as you can see, it is present between the external sphincter and the longitudinal muscle. So this plane, apart from providing a surgical access, also is a reason for the spread of any abscess or infection between the various regions of the perineum. For example, this is the intersphincteric plane. So this region here above, this is the supralevator space, which can be a site of spread of infection from the intersphincteric plane. Also, as I said, intersphincteric plane is can be a site for spread of infections from the anal canal, as the anal glands are present in this intersphincteric plane. So retrograde spread of bacterial infection from the anal canal into the glands can again cause an abscess in this intersphincteric plane. These anal glands are around 10 to 12 in number, are arranged circumferentially around the anal canal, and they open, their ducts open at the anal sinuses, again at the bases of these anal columns. So this intersphincteric plane is important both surgically as well as pathologically, because it can cause spread of infections between various planes, various spaces. Also, it provides a very important access for various colorectal surgeries, anorectal surgeries. Then, as I mentioned in the previous slide, this you can see the supralevator space is the space above the levator ani muscle, and obviously the ischiorectal space on each side of the anal canal, which is continuous posterior to the anal canal. So the intersphincteric plane again is a site of communication between the various planes. This is a sagittal view showing us the deep post-anal space, which is again slightly superior to the levator ani, and superficial post-anal space, which is again deep to the levator ani. So these spaces are again sites of infection and abscess, again being connected via the intersphincteric plane. So this is the pictorial representation of what I was saying. You can see this is the region of the intersphincteric plane, and various spaces can be reached by any abscess. Now, very quickly about the arterial supply. As I said, the pectinate line is the watershed line. So above the pectinate line, the arterial supply is via the superior rectal artery, which is usually coming from the internal iliac. Also, the middle rectal arteries are again coming from there. And the inferior rectal artery is the branch of the pudendal artery, which is supplying the distal anal canal, distal to the pectinate line. Here again, I would like to mention a very important point, that in the midline, especially posterior to the anal canal, in the midline, there is deficiency of the arterial supply. So this region is very prone for anal fissures, the posterior anal canal, because of the deficient arterial supply to the midline of the posterior anal wall. The venous drainage also follows the same pattern, differing between the two parts of the pectinate line. The superior rectal vein is draining into the inferior mesenteric vein, whereas the inferior rectal vein is draining into the internal pudendal and ultimately into the internal iliac vein. Venous drainage is again important because the veins are forming various submucosal plexuses in the anal canal. So the superior and the middle rectal veins form an internal venous plexus, whereas the middle and inferior rectal veins form an external venous plexus. Both are submucosal, and they are a very chief important factor in the formation of hemorrhoids. Nerve supply, as you can see in this picture, again separated by the pectinate line. Above the pectinate line, because of the differential development, the zone of the anal canal above the pectinate line is derived from the dorsal cloaca, that is the endodermal origin, and distal to the pectinate line, it develops from the ectoderm. So the zone proximal to the pectinate line is pain insensitive, whereas the zone distal to the pectinate line is sensitive to pain, touch, temperature. Again, a very important point I'd like to mention here, that there are a very there is a very rich supply of nerve endings which are thermosensitive, and these are the cause of sampling of the type of contents that are entering the anal canal, whether it is flatus or whether it is fluid, right? So the importance of different types of receptors in the anal canal is very important, because if these get disturbed, then it may cause anal incontinence. Lymphatic drainage is again important regarding the spread of the various tumors. So above the pectinate line, the lymphatic drainage is towards the internal iliac lymph nodes, which you can see here. And below the pectinate line, the lymphatic drainage is towards the superficial inguinal lymph nodes, especially the horizontal group of the superficial inguinal lymph nodes. So even the lymphatic drainage differs accordingly. Now, coming to the physiology of defecation, the most important aspects to control the anal continence are the sphincter mechanism. So the puborectalis, which I said is pulling the upper end of the anal canal anteriorly and causing this anorectal angle, which is somewhere near 90 degrees, and it prevents the passage of contents into the anal canal. So this is very important for maintaining of the anal continence. And then internal anal sphincter and external anal sphincter also are very important. The internal anal sphincter accounts for almost 50 to 85% of the normal resting tone for the anal continence, whereas the external anal sphincter accounts for somewhere between 10 to 15%. Also, the anal cushions, which I showed you earlier, they are in the resting stage, are very important for continence regarding fluid or flatus. So when defecation is required, first step is the passage or the arrival of contents into the rectum. So the stretch of the rectal walls, it provides reflex relaxation of the internal sphincter. So first thing is stimulation of stretch receptors of the rectum, and in reflex there is relaxation of the internal sphincter. Again, internal sphincter, which was very important for the continence of the normal continence. So this is relaxed. Whereas the external sphincter, which is having a somatic nerve supply, it is under voluntary control. So increase in abdominal pressure in voluntary defecation is causing the relaxation of the external sphincter, right? And also the relaxation of the puborectalis. So when the puborectalis relaxes, so the anorectal angle that straightens out, which we can see in this picture. So puborectalis muscle is relaxing here, and the rectum and anal canal come into a straight line, straight passage. Also, the internal sphincter is relaxing due to the reflex of the stretch receptors in the rectum, and the external sphincters relaxing because of voluntary action. Another thing that is important in defecation is the role of the conjoined longitudinal muscles. So the conjoined longitudinal muscles, instead of being circular, they are sort of spiral like this. So when they contract, they widen the anal canal and they shorten the anal canal. So widening and shortening of the anal canal because of the longitudinal fibers also is very important for a quick passage of contents through the anal canal into to the outside. So the physiology of defecation is mainly starting with the contents coming into the rectum, stretch receptors activated, reflex relaxation of the internal sphincter, voluntary relaxation of the external sphincter, also simultaneous relaxation of the puborectalis and the longitudinal muscles, causing widening and dilatation of the anal canal, causing defecation. So this was about the anatomy and a brief about the physiology of defecation. Thank you.
Thank you, Shobit. By now, you must agree with me how complex is the anatomy. But for a surgeon, this anatomy is either seen peroperatively or preoperatively by a radiologist. How do a radiologist see? And what we must know on a CT or MRI or endoscopic ultrasound, how does it look like? I'll call upon Dr. Sachin to decode this problem.
Good morning, everyone. Dr. Shobit described the anal anatomy very well. Now I am going to describe how it's look like on MRI on ultrasound. First, I am going to show the MRI. As Dr. Shobit described internal anal sphincter, external anal sphincter very well, and intersphincteric plane and ischioanal fossa. On MRI, in MRI, this is the coronal image. This is the coronal image. ये pointer नहीं आएगा क्या? चलो कोई. This is the coronal image in which we can see the external anal sphincter, internal anal sphincter, and intersphincteric plane. Corresponding MRI, coronal MRI T2 weighted MRI shows the external sphincter leveling number 2 and internal anal sphincter leveling number 1, and intersphincteric plane is labeled as a continuous black line. This is look like on MRI. If we see the axial section of anal canal on the same level, we can identify the puborectalis sling. This is the puborectalis sling. On this is the puborectalis sling. Level 1 is internal anal sphincter, and number 2 is external anal sphincter, and number 4 is ischioanal fossa, which is filled by fat. Now, few another images showing external anal sphincter, which is corresponding to this anatomical external anal sphincter, and images of internal anal sphincter, which is a continuous black line, and there is a potential space, intersphincteric space seen on the coronal images, which is well visualized when there is any infection, fistula, or any collection. This is another similar images, and this is the ischioanal fossa. This is the anatomy of or how it's look like on MRI. On ultrasonography, on endo anal ultrasound or EUS, similar anatomy can be seen on the ultrasound, which is very difficult. We can see this is black line. This black circle is corresponding to internal anal sphincter. This is the internal anal sphincter. This black line is corresponding to internal anal sphincter, and this echogenic line outside this is relatively brighter or white, is correspond to external anal sphincter. In female, there is a slight discontinuity of external anal sphincter, as Dr. Shobit told. They are more prone to anterior vaginal fistula. Again, in male, this is the endorectal ultrasound, which showing internal anal sphincter, which is black line continuous, and external anal sphincter outside this. This is endorectal ultrasound of female, which shows continuous internal anal sphincter, but slight discontinuity of external anal sphincter in its anterior part. Now, we can see some example. This is the internal anal sphincter. This is external anal sphincter, and there is a collection in between both internal anal sphincter and external anal sphincter within the intersphincteric plane. This is another example of intersphincteric fistula. We can see there is a collection outside this black layer, which is called internal anal sphincter, and inside the external anal sphincter. Now, this is the transsphincteric fistula, which shows collection is gone through this black part, which is called internal anal sphincter, and through this white part, which is called external anal sphincter. See the track crossing the both internal and external anal sphincter. Another example of perianal abscess, ischioanal abscess. There is a large collection seen outside the internal anal sphincter and as well as external anal sphincter, which represent the ischioanal abscess. Another example of supralevator abscess. There is a fan-like structure seen, which is corresponding to levator ani muscle, and there is a large collection which is extending above this. This is corresponding to supralevator abscess. This is another fistula which is making a horseshoe track. This this is very well visualized on this endorectal ultrasound. Now, on MRI, we can see grade 1 fistula. Grade 1 fistula is intersphincteric fistula, which is travels between the internal and external anal sphincter. This is the diagrammatic representation of intersphincteric fistula with corresponding MRI images on coronal section. We can see this is the collection, which is corresponding to intersphincteric fistula. This is the corresponding axial section, which appear as a dot-like structure. This is the track which is seen in axial section. Grade 2 fistula is intersphincteric fistula with abscess or secondary tract extending from this collection. This is the another grade 2 fistula. There is a intersphincteric plane with extension in superior extension of this collection. The corresponding MRI image shows there is a intersphincteric fistula with a small collection superior to this track. Now, grade 3 is transsphincteric fistula, which is crosses external as well as internal anal sphincter. Now, corresponding MRI of the are there, which is showing a black track. This is the black linear track, which is crossing external as well as internal anal sphincter and open into anal canal. Grade 4 fistula is transsphincteric fistula with abscess formation. This is like similar to this grade 3 fistula, but there is associated collection or secondary tract. Example of grade 4, a complex tract which is crossing this from the perineal skin to the external sphincter, internal sphincter, and there is a secondary ramification of tract. It's along its superior margin. This is the secondary ramification. Now, grade 5 is supralevator and translevator disease. It includes extrasphincteric fistula and suprasphincteric fistula. In extrasphincteric fistula, the fistula's tract is crosses outside the sphincter. It's not crossing the external or internal sphincter. It's going supralevatorly and opening usually in the rectum or making the collection in ischiorectal fossa. But it is not crossing the internal or external sphincter. But in case of suprasphincteric fistula, the fistula's tracts arise from anal canal. It's crosses the internal as well as external sphincter, but it extends superiorly into supralevator space, and then it's open into the skin or subcutaneous plane. That is all about fistula.
Thank you, Dr. Sachin, for such wonderful images. So is the beauty of this small 3 to 4 centimeter canal. Now I'll call upon the explainers who are dealing with the pathologies. The common things which I have taken are usually the benign things, because we have got an entire session on the malignant ones. First of all, I'll like to call Dr. Anuj for a very common problem in the OPD, surgical OPD, that is the anal fissure.
Hi, good morning, everyone. So, I'm dealing with a very common topic and a very simple topic too. So it's an anal fissure, but it may be simple for us, but a person having this problem has a phobia of going to washroom. Just think, when you wake up in the morning and you have a phobia, how will I manage today? So this problem is very much painful. So just to define, it is a tear in anoderm below the dentate line. That's why it is so painful. And a patient present to us with bleeding and pain during defecation. It's a very common thing which you see in surgery OPD. If the history is of 6 weeks, we call it acute fissure. And if history is more than 6 weeks or a failed conservative treatment, we call it a chronic fissure. So we all know how to see and how to identify which is a chronic fissure and which is an acute fissure. A very important question for PGs and UGs in exams. Okay, how will you? I'll come to it later. Nothing much to discuss about it. What is the pathogenesis behind it? There again, we can classify fissures into primary and secondary fissure. 90% of the fissures are primary fissure, which is seen in posterior part of the anal canal. So the pathogenesis is there is a stretching or trauma of any kind which can lead to break in the continuity of anal mucosa, leading to fissure. And when it happens, obviously ये body की tendency है अगर किसी जगह कोई problem है तो it will go into spasm. It will try to protect itself. कि pain से बचने के लिए the anal sphincter will go into spasm. And whenever you have to defecate or you have to go for it, and thus you have to go against that pathological phenomena जो spasm कर रहा है, so it will be very painful and the vicious cycle continues. So coming to the etiology, the primary etiology is local trauma, as I told you. It can be due to hard stools, diarrhea, anal sex, and secondary fissures are usually neither anterior or posterior. Mostly they are lateral, which can be commonly due to inflammatory bowel disease, malignancies, sarcoidosis, tuberculosis. So this is what all is happening. Any trauma, infection, inflammatory bowel disease, malignancy, these are the causes which can cause a mucosal injury, leading to ischemia and ulceration, and which cause a pain and spasm. Pain and spasm will lead to decreased bowel movements, poor mucosal position, bacterial infection, and finally a non-healing fissure or ulcer will be there. So why posterior? Why posterior is the most common? Any of the postgraduate will like to tell? Because so before coming to treatment, I like to give you a very important take-home message. बेली में एक लाइन लिखी हुई है. If you don't put your finger in, then you will vasovagal spasm, vasovagal shock. So whether we should do it or not, any takers कि we should do per rectal examination in every patient of fissure. So there are indications. We should do examination under anesthesia in some cases. What are those cases? If it is not in the primary position, मतलब अगर lateral fissure है तो आपको examination under anesthesia करना है, चाहे वो कोलोनोस्कोपी करो, एनोस्कोपी करो या कुछ भी करो, आप malignancy जैसी चीज को मिस नहीं कर सकते हो. If you are suspecting something wrong, when you part the buttock and you see the bleeding doesn't match the way it is not coming, it is coming from inside or tickling from inside, then you should always go for examination under anesthesia. Failed conservative management, patient is not getting any relief after your treatment, then you should go for examination under anesthesia. So these are the few things you should always consider for it. Coming to a treatment is very simple. Mostly सीधे हम ड्रग्स पे आ जाते हैं, but ड्रग्स से पहले इसमें बहुत कुछ है. You have to just relieve the spasm of the sphincter. आप उसे कैसे भी करिए. सबसे पहले जो उनका फोबिया है उसे दूर करिए. Relax the stools, उसको सॉफ्ट करो, soften the stool by dietary measures, taking lot of waters. हम लोग normally advise नहीं करते, but these things are very important. Directly laxative dinner doesn't work for everyone, so you have to modify their diet. You have to tell them what all you have to take, what all you have to avoid. And sitz bath also helps in relieving the sphincter, relieving the pain. It also helps in cleaning. तो वहां पे infection develop नहीं करता अगर वो regularly sitz bath करते हैं. And there is a proper way. I hope everyone knows how to tell your patient how to take a sitz bath, कितने टाइम करना चाहिए, किस तरीके से करना चाहिए. तो ये मेरे टॉपिक में नहीं है, बट अगर नहीं बताते तो आप बताना शुरू करिए प्लीज. एंड देन यू गिव अ फार्माकोथेरेप्यूटिक ट्रीटमेंट व्हिच इज कॉमनली यूज्ड इज ग्लिसरल ट्राइनाइट्रेट. क्या करता है ये वस्कुलैरिटी बढ़ाता है, स्पाज्म को कम करता है. उसका मैकेनिज्म सर ने एनाटॉमी रेडियोलॉजी वालों को बुला दिया, फार्मा वालों को बुलाए होते तो वो बताते. And similarly, calcium channel blocker, it also helps in releasing the spasm. Botulinum toxin is injected in some areas, though it's not FDA approved, but many papers are there which show promising results on it. So after giving a trial of 1 month, if it doesn't heal, then you should think again. First thing you should do is examination under anesthesia. You are missing something. Because most of the acute fissure, 80 to 90% of the acute fissure will heal. अगर नहीं हो रहे हैं तो आपको कुछ प्लान करना चाहिए, कोलोनोस्कोपी करनी चाहिए अंडर एनेस्थीसिया. एंड अगर आपकी कोलोनोस्कोपी नॉर्मल है, यू कैन अगेन गिव अ ट्रायल ऑफ 1 month फॉर कंजर्वेटिव मैनेजमेंट. एंड अगेन इफ इट इज नॉट हीलिंग, यू शुड थिंक ऑफ सर्जरी. द मोस्ट कॉमनेस्ट सर्जरी वी ऑल डू इज अ वेरी सिंपल सर्जरी टू डू इज लेटरल इंटरनल स्फिंक्ट्रोटमी, एंड इट हैज द मोस्ट प्रॉमिसिंग रिजल्ट्स इन ऑल द पेपर्स टिल नाउ. अब वो आप कैसे भी करो, आप कुछ केमिकल से करो, लेजर से करो, क्लोज करो, ओपन करो, इट डजंट मैटर, रिजल्ट इज सेम. सो सम पीपल आर डूइंग फिशरेक्टमी विथ एडवांसमेंट फ्लैप. दे सेज कि हम स्फिंक्टर को नहीं छूना चाहते और हम फिशर को हटाएंगे एंड वी विल इंप्रूव द वस्कुलैरिटी बाय गिविंग अ फ्लैप. सो एनल एडवांसमेंट फ्लैप has also good promising result, which is a very easy procedure to do. So fecal incontinence is obviously less comparatively, but fecal incontinence is less than 1% nowadays in lateral internal sphincterotomies. Botulinum toxin, I told many people are still doing it. I haven't seen also, so I cannot comment much on it. The outdated thing is Lord's anal dilatation. Initially पहले ये बहुत प्रचलित था, सब लोग करते थे, बट इनकॉन्टिनेंस काफी ज्यादा देखी गई, रिकरेंस बहुत ज्यादा देखी गई, तो अब ये नहीं किया जाता है. स्फिंक्ट्रोटमी इज द सेम. अगर आप लेजर से करते हो तो उसको लेजर स्फिंक्ट्रोटमी बोलते हो, तो नथिंग न्यू इन इट. Complications post surgery, it can be rectal bleeding, abscess, hematoma, recurrence, incontinence, patient satisfaction and healing. एक छोटा सा टेक होम मैसेज जिससे मैंने शुरू किया था कि when you don't put your finger in, you have to put your foot in. कोविड के टाइम पे एक जज साहब थे, मेरे पास अपनी वाइफ को लेके आए, bleeding per rectum and pain during defecation, and was getting treatment under very renowned surgeon since last 6 months. So, but no relief. तो पता नहीं कहाँ से मेरे पास आ गए. तो I asked, I like to do a rectal examination, and she said, okay. I didn't see any fissure. I proceeded with the rectal examination, and she has a hard growth, and it was a late stage. I was not able to reach my finger above the growth, and the doctor missed it because not following the basic guidelines. So I request you all to be very vigilant. जो आपका पेशेंट बोलता है उसको सीरियसली लेना शुरू करिए. थैंक यू.
Thank you, Anuj, for a crisp presentation. Just to add to it, sphincterotomy, yes, open or close method, what you are trained with, is a good option. Classically, sphincterotomy should be done just to avoid the aim of all these surgeries, say hemorrhoids or fistula or fissure or abscess. You have to relieve the pain or the bleeding of the patient, but you have to preserve the continence somehow or the other, whatever you are. The classically described sphincterotomy should be done up to the level of dentate line, what they say. But what most of the people are now advocating with the evidence base is just do a sphincterotomy up to the apex of the uh, apex of the fissure. So by that, it is a conservative sphincterotomy which will relieve the patient. A second thing is a chronic fissure. Chronic fissure, it is very easy and matlab, sphincter is visible at the base of the chronic fissure. There is always the excitement just to divide that sphincter, internal sphincter, and that problem is solved. But one should not go for it, otherwise a keyhole or gutter deformity occurs where there will be fecal swelling. So sphincterotomy should always be done in a lateral position. And you were absolutely correct. We are not explaining to the patient. One of my patients was not relieved of his pain. When I asked, you are doing sits bath? Yes, sir, I am doing. तो कितनी देर बैठते हैं? सर 15 मिनट बैठ जाते हैं. मैंने कहा आराम से बैठ जाते हो? बोले साहब तकलीफ बहुत होती है बैठने में. सारे कपड़े पहन के बताइए, बैठना जो है 15 मिनट टब के अंदर बड़ा मुश्किल काम है. मैंने आप कपड़े पहन के बैठते हैं? बोले सर वो तो बताया नहीं था आपने मुझे. तो you learn by your patience, by your small mistakes, I must say. Thank you. I'll call Dr. Virendra. There were so many spaces shown. Anorectal abscess is the next topic.
Good morning, chairpersons. Good morning, my teachers, Dr. Bharti sir, Dr. B.K. Jain sir. First of all, I will like to thanks organizing team, Dr. Shashank, Dr. Pandey sir, Dr. Maheshwari sir, for inviting me for this important surgical update. Anorectal abscess is a very common problem, and it is sometimes very difficult to manage because of the lack of knowledge. So anorectal abscess, usually I will give a small and presentation. It is arising from the cryptoglandular epithelium, and the internal sphincter is thought to have a protective role in this spread of the infection, but this protective mechanism breach at the level of the crypts of Morgagni when internal sphincter, as Morgagni penetrates through the internal sphincter into the internal sphincteric space. Extension of the infection can involve the internal sphincter space, then it's the perirectal space, ischiorectal space, and it can spread up to the supralevator space. One thing we have to remember that abscess cavity is often associated with the fistulous tract. As we already described by the Dr. Sobit, anatomical location, the most common is the perineal abscess, followed by the ischiorectal abscess, intersphincteric space abscess, and the supralevator abscess. Perineal abscess is most common type. It is present in more than 60% of the cases. It is located below the skin of the anal canal and do not traverse the external sphincter. The next common is the ischiorectal abscess. It is when the infection traverses the external anal sphincter into the ischiorectal space. And ischiorectal abscess may traverse deep through the post-anal space into the contralateral side. Then they form the horseshoe-shaped abscess. Next, third most common type is the internal sphincteric abscess, when the infection contained between the internal and the external sphincter. They may lie completely within the anal canal, and they mostly lead to the severe pain. It can be found by the digital examination or by the proctoscopy. The least common type of the abscess is the supralevator abscess. They may be spread by the two types. It may be the caudal extension of the internal sphincter space abscess, or they may arise from the abdominal conditions such as appendicitis, diverticulitis, gynecological sepsis, and they usually very difficult to diagnose only by the clinical examination, and we need to go for the computerized CT scan for that or MRI for the diagnosis of the supralevator abscess. So what is the pathophysiology? It has been seen that in more than 90% of cases, it is the obstruction of the anal crypts, it is the anorectal disorder which is count for the formation of the anorectal abscess. And the most common cause is the increased sphincter tone. Infection of the static glandular secretion result in the abscess formation within the anal gland, and this typically the abscess form initially in the intersphincteric space and then gradually it is spread to the other potential spaces. Both aerobic and anaerobic bacteria are present in case of the abscesses, and the most common anaerobic bacteria is the Bacteroides fragilis, and in aerobic bacteria most commonly are the implicated are the Staphylococcus aureus, Streptococcus, and the E. coli. More recent studies have found the role of MRSA, methicillin resistant Staph aureus, in case of the ischiorectal abscess and anorectal abscess. In 10% of cases, it is the basically abdominal causes are present in case of the anal abscesses, and the most common it may be because of the Crohn's disease, it may be because of the trauma, immunodeficiency in patients, in HIV infection and malignancies. In few cases, there is a tuberculosis, sexually transmitted disease, radiation therapy at the foreign bodies. In some cases, the perforated perforated diverticular disease, inflammatory bowel disease, or the appendicular perforation may be the cause of in few cases. Now, what is the clinical presentation? The clinical presentation differ according to the location of the abscess. In most of patients, perirectal pain is present. In most of patients, in perianal abscess is basically the dull perianal discomfort and pruritus, and this discomfort or pain increase while defecation or while doing exercise work. In case of the ischiorectal abscess, it is often present with the systemic fevers, chills, and the perirectal pain. In case of the intersphincter abscess, it is quite painful. It may present perianal abscess may present as the swelling around the rectum, and in around 50% of cases, there may be the rectal or perirectal drainage present ho sakta hai. It may be bloody, mucopurulent or purulent discharge may be present in case of. Usually this pain, these are associated with the constipation, and the most likely cause of constipation is the pain or during the defecation. Physical examination, in case of ischiorectal abscess and supralevator abscess, there is only few signs which are present. But in case of the perianal abscess, there may be a small erythematous, well-defined flatulent subcutaneous swelling or mass near the anal orifice. On distal rectal examination, a flatulent innervated mass may be encountered. What may be the complication? The one thing we have to remember that the most common and dreaded complication of the anorectal abscess is the fistula formation. And before dealing with giving any management to the patient, we should properly explain to the patient that this may be the end result of the abscess cavity, whether you are treating it or not treating it. And fistulas occur in around 30 to 60% of patients with anorectal abscess. Apart from them, in case of if patient is diabetic or immunocompromised, there may be the bacteremia and sepsis. There may be fecal incontinence, and in few cases, in case of fistula tract, there is a malignancy may be present in case of fistula tract. How will you work up this patient? Laboratory studies are not indicated in all cases, but if patient is a immunocompromised or a diabetic patient, then we should go properly work up of this patient. We should have all the investigations. In case of laboratory studies, it is basically polymorpholeukocytosis which is present, but the absence of leukocytosis is not essential. In 20% cases, anal abscess may be present without the leukocytosis. Now, what is the role of ultrasonography, computer CT scan, and the MRI? Ultrasound is not very much informative, but the nowadays role of endorectal ultrasound is quite useful in case of the complicated rectal abscesses, such as in case of the supralevator abscess and the ischiorectal abscess. CT scan for perirectal abscess confirmed by surgical drainage yielded a sensitivity of around 77%. MRI is the basically the standard criteria test for the complex ischiorectal abscesses, supralevator abscesses, but in case of emergency, MRI is not freely available in most of the colleges, in most of the hospitals in India. What is the management? As a rule, the presence of an abscess is an indication for the incision and drainage. Watchful waiting while administration of antibiotics is inadequate. The main role is the basically incision and the drainage is the main part for the management of these patients. Delayed surgical intervention result in chronic tissue destruction, fibrosis and stricture formation, and may impair the anal incontinence. Simple perianal abscess may be treated in the emergency department. More complex perirectal abscesses are treated by an experienced surgeon in an operating room. Surgical intervention. When the abscess is in the perianal or superficial, drainage can be done in the emergency department with local anesthesia. A small incision is made over the area of flatulence to shorten the length of any fistula formation that may occur after surgery. That incision should be as close as anal opening. Pus is collected and sent for the culture, and wound is packed. After 24 hours, the gauze is removed and the patient is instructed to take the 6 baths regularly. Post-operative analgesia and stool softener are prescribed. The formation of fistula sac is an important potential complication of anorectal abscess drainage. We have to focus on this, that there may be the formation of the fistula sacs after the surgery. The type of organism culture from an anorectal abscess is an important predictor of the fistula formation. If there is an organism which are intestinal, it predicts that there may be the formation of the fistula. But if there is a staphylococcus or other skin organism, that there is a less chance of the fistula formation. Treatment of ischiorectal, intrasphincteric, and supralevator abscess. In all these things, we require general or basically regional anesthesia. Ischiorectal abscess is treated as the same manner as we treat the perianal abscess. But in this case, we have to, because the cavity is quite deep, we have to probe with the help of finger or hemostat to disrupt loculation and facilitate drainage. So in case that is basically we have to, as the ischiorectal abscess, that the cavity is quite deep, then we have to break all the loculi. In intrasphincteric abscess, a transverse incision is made in the anal canal below the dentate line posteriorly. The intrasphincteric space is identified and the plane between the internal and anal and external sphincter is exposed. The abscess is open to allow the drainage. A low intrasphincteric abscess can be typically be treated by the drainage, division of the internal sphincter, and the marsupialization of the cavity. But in case of the it is a deep intrasphincteric abscess, then we have to leave a catheter in the cavity for the proper drainage. Now, the supralevator abscess, the management of supralevator abscess depend upon the location of the abscess and the cause of the abscess. Here we have to remember, if the abscess is the extension of the ischiorectal abscess, we can do the external drainage through the ischiorectal fossa, if it is the extension of the ischiorectal fossa. But if the cause of the supralevator abscess is the upward extension of as we saw that the cause is the basically is the other than the extension of the intrasphincteric abscess, then we have to drain this abscess into the rectal mucosa. Otherwise, there is the formation of the grade 5 supralevator fistula, which is very difficult to drain. The thing which we have to remember. What is the prognosis? Early data indicate that the abscess formation occurred in approximately 10% of the patients, and the patient which usually present with the chronic recurrent abscesses, in this case, again there may be the formation of the abscess in the 50% of the cases. Approximately 2/3 of the patient with rectal abscess who are treated by incision and drainage or by spontaneous drainage will develop a chronic anal fistula. So this thing we have always explained to the patient that in treating the fistula in a perianal abscess, there is very, very high chance of the fistula formation. And this fistula formation is not because of the surgeon incompetency, but it is because of the anatomical location and the physiology of disease. Otherwise, patient will be behind you, and we were quite lucky at our time that we always refer the patient to the GTB hospitals. Sir के पास भेज दिया करते थे, but now it is really a challenging. Because patient को most of time they think that the improper surgery or inadequate surgery is the cause of the fistula formation. Thank you.
Thank you, Viren. DOA seems to be a minor problem, but believe me, at times he is absolutely correct. The patient is just after your life. Sir, wound नहीं heal हो रहा है, ऐसा operation कर दिया है. The cryptoglandular hypothesis, yes, definitely it is there. One thing is certain, an abscess has to be drained. A perianal, I like to always have a perianal abscess, simple, a cruciate incision will do. A ischiorectal, yes, at times difficult to diagnose. I have to do a rectal examination. A deep exploration is required. Intersphincteric, yes, I'll perform an internal sphincterotomy. Intersphincteric abscess is important because the patient will present to you with pain in and around the rectum. No external sign, mind it. And that many of the patients are being treated as fissure because rectal examination is not being performed. If after separation of the buttocks, you find no fissure, acute fissure, always do a rectal examination. There will be tenderness at the lateral wall, indicating an intersphincteric abscess. Supralevator, yes, supralevator abscess, that is the rarest thing, and it definitely creates problems, I must say. If it is the extension of the internal sphincter fistula, it can be safely, very safely drained through the rectum. If you are trying to drain it through the external, a difficult suprasphincteric fistula will take place. If it is a pathology of the pelvis, then deal with the primary pathology. Drain it either through the rectum or through the pelvis, but treat the primary pathology. At times, it may be an upward extension through the levators of the ischiorectal fossa. Then you have to give an incision in the perianal skin and drain this abscess. It will lead to a fistula, but it will be easier to treat. That is the point. But one thing is always there in the mind of the surgeons, especially young surgeons. What if I treat in a single go? I have opened an abscess, I am doing a rectal examination, and I know there is an opening in the posterior midline. Now, I know this is a fistula. I must go with a single stage fistulotomy with this abscess drainage to deal with this complex problem. Too much literature has been on it. Definitely, it is difficult to locate the internal opening. If you have located it, the chances of incontinence, they are high if you deal with the fistula primarily at this time. A better approach would be drain the abscess, put in a draining set-on to it, and you can always very well, after 6 weeks or 8 weeks, deal with this fistula without the risk of incontinence. Thank you. I have started with fistula. It's a complex thing, and Dr. Shalab is the best person to narrate upon it.
So good afternoon to all. Thank you very much, Dr. Shashank, Dr. Sanjay sir, Dr. Maheshwari sir, and everyone from Subharti for inviting me over here. First of all, at the outset, I would like to compliment the Department of Surgery for having this series of surgical updates, because last year also I came here for the surgical update on road traffic accidents. And while I was going back to Ghaziabad, I drove at 140 and I had a challan. So the emphasis was there. As regards of the fistula is there, होता बहुत लोगों को है, करवाना कोई नहीं चाहता, और जो करवाता है वो गारंटी चाहता है कि मेरे को दोबारा ना हो. So it's a very complex kind of thing, because once we speak about the fistula part, so we follow this rule of good salts. So once we follow this rule of good salts, in most of the cases we are able to justify where is the internal opening. External opening दिखती है, but internal opening has to be seen. But at times, once you don't see the internal opening, then comes the problem. There you are just confused, and it is your fingers, it is your vision, which prompt you for a proper mechanism of treating the fistula surgically. Or believe me, at so many times, the internal opening is not seen even after a good MRI scan. So radiologically, it has been beautifully explained. Anatomically, it has been beautifully explained, but still you get lost during the fistula surgery because you are not able to find the internal opening. So the basic principle is that whatever tough tissue or fibrotic tissue you find during surgery, it has to be excised just by finger palpation if you are not able to go to a internal opening. So as Dr. Sanjay had asked me to just have a brief overview, so these are the two goals. One is to identify the external opening, internal opening, and the course of the tract along with secondary connections. And the second goal while you are operating is to abolish the primary fistula, secondary tracts, prevention of fistula recurrence by your a good approach, and the sphincter should not be damaged. So if there is a chance of sphincter damage, then you have to take a call whether to abort the surgery and call the patient for a second sitting. And during the clinical examination, we do it by proctoscopy. During the proctoscopy, if you have got kind of internal opening, you can see it's too good. Otherwise, during the perrectal examination also, you can just feel an induration. Most of the time, the induration is there at 6 o'clock position. Apart from that, probe examination is also described. Small catheter can be placed through which methylene blue dye or hydrogen peroxide can be infused inside so that you can see from where the dye is coming. So these are very cost-effective manners by which we can do. Where there is a problem, we can do examination under anesthesia in cases where the patient is not allowing you just because of severe pain. Otherwise, once the patient goes to a diagnostic lab, then these are the things that you can offer to him. You can do a fistulography, endoanal ultrasound. MR fistulogram is the diagnostic modality of choice because under the Clinical Establishment Act, it has been written in the Government of India Gazette that all the patients of fistula to have a MRI. So if you don't get a MRI done, tomorrow if there is a recurrence and the patient goes to the court, then he may sue you that since it is written in the Government of India Gazette under Clinical Establishment Act, why my MRI was not done. So this has come as a surprise to me because while I was going through the document, CT scan and anal manometry can also be done. Manometry is generally done in recurrent cases. So the patient does not claim afterwards because today is an era of litigation. So patient may claim that आपकी surgery के बाद I have got incontinence. So these are the things which are there. This is a small declaration from my side because my all slides are based on the evidence base. The first declaration is that there is no specific management of fistula, which is a gold standard, you can say, apart from the routine things that we are doing it. Second thing is the specific implementation of given treatment often has to formulate personal schemes according to the actual situation of the patient. So you have to devise a method by which you can treat the patient properly. It is patient who should get the maximum benefit. And there is no simple technique that can completely heal complex anal fistula. So it has to be phased wise. Documentation becomes very, very important in all the cases. If the documentation is not there, then it is going to be a problem. And the effectiveness of surgery and protection of anal function must be considered comprehensively during the treatment. So these are the 4 disclaimers. So coming to the management of fistula, basically the fistula is
having the management in terms of saving the sphincter and not saving the sphincter. So fistulotomy, like Dr. Saab has just now narrated about the abscesses. So you can open the track, you can allow it to drain, but at the hindsight of it, there is a fibrotic track. So once we do a fistulectomy, it becomes the gold standard. So these are the two procedures which are applying. But once we come to more advanced procedures, then we come to the era of lift or sloughed. Lift is basically ligation of intersphincteric fistula tract, and sloughed stands for submucosal ligation of fistula tract. So these are the two procedures where if you are having a doubt that it is an intersphincteric fistula and there can be a complexity related to the incontinence, then you can do such kind of procedures which are very comfortable, and the patient's healing is also very good. So these are some of the pictures of my patient, in which in figure 1 we have just put the probe. It's a copper probe which is used. In fistula, it is very important to have your own probes. Don't rely on the probes given at the hospital OT, because sometimes they will be deformed. So always have a set of fistula probes with you. It is available in all conferences with surgical instrument companies. Once it is distorted, you can throw it. There's no point in using it again and again. They are very, very cheap. They're not very costly. In the second figure, we can see that we have opened the track, and from the track, we are going to take a suture, so that we just override the track, and from behind it, we have passed a suture. And then we tie this suture towards the mucosal part of the fistula. And after that, we excise the whole track by tunneling, and then we can close the whole skin, so that the whole of the lateral fistula is out now, and the internal part of the fistula which is there, it will be ligated. So these are the steps which we do. Like, we place an incision at the intersphincteric groove, identify the track, we ligate the track at its internal opening, then remove the intersphincteric track, scrap out the granulation tissue, and suture the defect. So these are the 6 steps by which we can do these procedures. Cetons, we have got a challenge from our Ayurvedic friends, because they use Shar Sutra Vidhi. So many of the patients who come to us with Shar Sutra, they generally form an abscess. They form a fissure, and it is very, very painful, I tell you. So these cetons, we use polypropylene, or we can use any thread which has got a good consistency and can stay over there. But there are a variety of patients. So these variety of patients will irritate you like anything. Like in 2007, there was a patient of ours in one of the units at my medical college who complained to Mayavati, because Mayavati gave a letter to our unit head saying कि आपने इसका काम ठीक नहीं किया, सिटॉन आपने इसका अंदर छोड़ दिया. अब सिटॉन एक ऐसी चीज है जो कि छोड़ी नहीं जाती है, पेशेंट को बताई जाती है कि तुम्हें दोबारा आना पड़ेगा, दोबारा आके इसको कसवाना पड़ेगा, लेकिन उसके बाद भी उसने कसवाया नहीं, वो लेके घूमता रहा उसको. एंड देन देयर वाज अ कंप्लेंट फ्रॉम मायावती, वी कॉल्ड दैट पर्सन. अब आप उसका नरेशन सुनिए, क्या बोलता है जी. कभी कभी जब मैं फ्लेटस पास करता हूं तो उसमें से आवाज मोहम्मद रफी जैसी आती है, और कभी कभी करता हूं तो लता मंगेशकर की तरह आती है. मैंने उससे पूछा तुम दारू कितनी पीते हो? कहता है जी मैं रोज एक पौवा पीता हूं. तो मैंने बोला मुझे बात समझ में आ गई, बट यू नीड अ फिक्सिंग ऑफ द सिटॉन, एंड सिटॉन हैज टू बी टोल्ड टू द पोस्ट ग्रेजुएट्स ऑल्सो, because while I was doing my residency from Jaipur SMS, so in the morning my postgraduate came and he told me, sir, वो जो आपने कल धागा छोड़ दिया था ना सर्जरी में, वो मैंने सुबह काट दिया है. So it was my fault that I did not explain him that भैया इसको रखना है संभाल कर. So he was my first year postgraduate. Now he's practicing as a urologist at Delhi, very good urologist. So these are the different varieties of ceton, like drainage ceton. And anti-TNF alpha was tried in some patients, but it has come out as a failure. So 45% of the patients will fail with this first procedure of drainage ceton. Second is a drainage ceton only, but here the failure rate is around 8%. Then the pulling ceton, जिसमें हम tight करते रहते हैं उसको, here the failure rate is still 4%. Then these are the 2 new procedures which has come, like rerouting ceton with mucosal advancement flaps, which has got a failure rate of still 3.5%, and external sphincter sparing seton, जो कि नीचे आपको दिखा रखा है एक figure में. So this seton is having a failure rate of 3%. Still, setons have got a failure rate because it goes very high, it goes intersphincteric. So that's why, and I am not a preacher of use of Shar Sutra, so I don't use Shar Sutra, I use basically polypropylene suture. In 2014, we did UPSC Con. So usme it was a great challenge to do lots of procedures of good variety and of new things. So we did WAFT over there. Dr. Rajiv Verma is sitting here. He was in the OT at that time. Madam was there. So my patient was there. उसको मैंने समझा बुझा के मैंने कहा कि 10 patients ऑपरेट करने हैं, वाफ्ट करेंगे. तो वाफ्ट के लिए मैंने उसको वाफ्ट तो करा, लेकिन वाफ्ट करने के बाद उसने मेरी ले ली क्योंकि it came out to be a total failure. उसको ठीक ही नहीं हुआ कभी भी. But since it has got a literature where waft has been now in advocacy at major corporate hospitals with such kind of system which has been Johnson and Johnson ने इसको करा है, and it has got a 8-degree angled camera. It's a very fine diameter is there. You can put it and then you can have it with the operative length of 18 centimeter. So if it is a very straight track, I say it can be done. But the whole problem is that fistulas do not have a very straight track. Where there is a straight track, you don't need a waft actually. You can do it like a fistulectomy. Why do you want to put a scope in everything? It is just like putting a scope in everything, like we surgeons are now putting scopes in most of the things. Then laser has also come these days. So those people who are having laser, they are also doing the laser. So it's a laser is a beautiful concept where the fiber is there, but this fiber has got a life. It comes out to be quite expensive. And once you put the fiber inside, then you can withdraw the fiber with the laser energy. And basically, it is basically cauterization of the labor. And with this labor, the whole, with the laser, the whole of the track can be sealed. It's a good procedure. Endoscopic ablation is also a kind of technique where you can use a kind of a cautery and you can just cauterize the whole track and you can pull it out, and so that the internal part of the epithelium is all destroyed. Advancement flap procedures are also recommended these days. So internal advancements of the mucosa can be placed over the internal opening. So that's how we can just go and we can take a flap of the tissue and we can have. But still, it has got a lower success rate than a simple fistulotomy or fistulectomy, but avoids the need to cut the sphincter muscles. So perfect is a new kind of thing. So new terms are also coming in fistula, like filac, perfect, all these things are also coming. So this is being advocated by an Indian surgeon in which he has done a proximal superficial cauterization and with emptying regularly of fistula tracts and curettage of the tracts. So these are the indications, like these can be done for recurrent fistulas, horseshoe fistulas, and all complex variety of fistulas where there is a collection of abscess and pus over there. But simple low fistula and fistula with supralevator rectal opening, which is seen on MRI, is generally not indicated for such kind of perfect procedures. Another fancy name is of tropis. It is a transanal opening of intersphincteric space. So in this complex fistula with significant intersphincteric component, we can use it because it acts on an abscess. So once it acts on an abscess, you have to open that space. Once you drain that space in the intersphincteric area, as you do it with the lift procedure, this could lead to recurrence of the things in most of the 50% cases. So these type of fistulas can be treated with tropis, and it is a good procedure. There are some non-surgical procedures also, like washing the fistula with 1% silver nitrate solution. There are some people who are not able to go for surgery. There you can try with these things, but the success rate is 76.3%. And recently ozone has also been tried, but it has also got a success of just 25%. So fancy things have also come, like fibrin glue. It's a mixture of fibrinogen and thrombin, and these components are put inside and immediately it has to be placed, so it coagulates over there, and the glue encourages the fistula to heal. So it is, but it is still less effective than fistulotomy despite the cost of these glues, which is quite high. And then we have got these porcine plugs. So these three photographs can show that previously what we used to do, we used to have a probe inside, and then we used to apply this plug. But now there is a brush which has come. So what we do is we put the probe inside, we cure it with the brush. बिल्कुल ऐसा होता है ब्रश जैसे कि वो बॉटल ब्रश होता है उस टाइप का बहुत माइक्रोस्कोपिक ब्रश होता है एंड देन वी कैन जस्ट क्यूर इट एंड देन वी कैन पुट दिस प्लग. लेकिन इसके साथ भी प्रॉब्लम क्या है, डिस्पाइट द हाई कॉस्ट ऑफ 90,000 rupees ऑफ दिस प्लग, इट विल पॉप आउट समटाइम. So here the difficulty comes. So best जो हम लोग mechanism मानते हैं, that is still fistulectomy, and after doing a fistulectomy the patient has to be educated with hot sits bath. So like Dr. Sanjay had just now told that patient कपड़े पहन के बैठ गया टब में. मेरे पास भी एक ऐसा हादसा हुआ जिसमें पेशेंट बिना कपड़ों के बैठा. तो मैंने उससे पूछा कि आप सिकाई कर रहे हो? कहता हाँ जी बिल्कुल कर रहा हूँ. तो मैंने लोग कैसे कर रहे हो? कहता जी भाप आती है ना उसकी, तो मैं भाप लेता हूँ उसकी. तो मैंने कहा भाप कैसे? कहते हैं मैं 1 फुट ऊपर बैठता हूँ, नीचे से उसको ऑन कर देता हूँ, नीचे से भाप आती रहती है. तो मैंने उसको बोला कि भाई आपको टब में अंदर बैठना है, भाप नहीं लेनी है. तो कहता है जी आपने बताया नहीं मुझे. तो दिस इज वन मोर एग्जांपल. सो थैंक यू वेरी मच फॉर द पेशेंट लिसनिंग. आई एम रियली ऑब्लाइज्ड फॉर कॉलिंग मी. थैंक यू सो मच.
Thank you, sir. Informative and humorous talk, but yes, definitely fistula management means eradicate this cryptoglandular disease. Fancy things, fibrin glue, even porcine mucosa, mucosa has been used. Now this plug, people have even tried, they have pulled the plug and stitched to the external opening so that it should not pop out. Person has to avoid all sorts of efforts. He cannot run, he cannot even cough or sneeze. That too much precautions have to be taken, otherwise it will come out. Again, definitively a intersphincteric fistula or a low transsphincteric fistula can be dealt with fistulotomy. You can very well divide the internal sphincter, but if you are dividing more than 30% of the external sphincter, chances of incontinence, they are very bright. So the crux of fistula surgery, again, to prevent recurrence, yes, definitely, but your patient must be continent. You have to give, you cannot make your patient incontinent. Either you divide, do repair it, or you give either drainage or a cutting set on. Lift is a very good procedure, I must say. What we are employing, sir, we are using lift, and because we have got laser with us, so we are obliterating this rest of the track. The distal track we are obliterating with the laser. We have done, I think, 10 out of 10 such cases with good results, I must say, but it's a very small data. But definitely, the sphincter knowledge has to be there. Dr. Jain must be talking about the complex anal fistulas. All other fistulas, anterior fistulas in females and other fistulas, they are the complex one, and they have to be dealt with tricky things. Mucosal advancement flap, yes, definitely something has to be done for the internal opening. Most of the time, the cause of recurrence is not dealing with the internal opening. Mucosal advancement flap is, if brought to the lower fistulas, the ectropion will be a problem. So it is a good thing for a higher fistula. Thank you, sir. Thank you again for coming to us. Next thing, again, most of the patient of their anal problems, they say, we have got piles. But what actually heme and Rios means will be narrated by Dr. Madhuwala.
Very good afternoon, all my teachers, colleagues, and junior doctors. Today I'm going to discuss the approach to a patient with hemorrhoids. So, definition of hemorrhoid, it results from enlargement or protrusion of anal hemorrhoidal cushion This can be internal, external, or mixed hemorrhoids depending on the site of the origin. So this is about the etiology and risk factors. These are chronic constipation, pregnancy, obesity, prolonged straining, portal hypertension, anorectal varices, chronic diarrhea, colon malignancy, loss of rectal muscle tone, etc. So depending on origin with anal canal and relation to dentate line, hemorrhoids are divided into internal hemorrhoids, external hemorrhoids, and mixed hemorrhoids. Internal hemorrhoids lie about dentate line, develops from embryonic endoderm, covered by columnar epithelium, and these are not supplied by somatic sensory nerves, so cannot cause pain. While external hemorrhoids, they lie below dentate line, develops from embryonic endoderm, covered by squamous epithelium. These are innervated by cutaneous nerve that this will result in pain. So this is external hemorrhoid, internal hemorrhoid, and interno-external hemorrhoid. So this is well-known classification of hemorrhoids, internal hemorrhoids, grade 1 and grade 4. Grade 1, there is no prolapse, and in grade 4, irreducible protrusion of hemorrhoidal tissue. So clinical presentation of the hemorrhoid. Painless bleeding is the earliest symptom, and peculiarity of this bleeding is it is separate from the motion, and it is seen either on the paper on wiping or as a fresh splash in the pan. There can be perianal pruritus, irritation, discomfort, prolapse of hemorrhoidal mass, acute pain when it is incarcerated or strangulated. Thrombosed external hemorrhoid may present with acute painful mass at rectum. There can be skin tag. How to approach a patient, proper history, clinical examination, digital rectal examination and proctoscopy should be part of this examination. And in patients where you suspect any neoplasia or ischemic bowel disease, you can go for flexible, and all patients, you should always go for flexible sigmoidoscopy and colonoscopy. Complications are strangulation, thrombosis, ulceration, gangrene, and portal pyemia. So now come to management of the hemorrhoid. Treat only symptomatic hemorrhoids. Management can be conservative, non-excisional, and surgical. Conservative management is treatment of choice in grade 1 internal, non-thrombosed external hemorrhoids. This consists of warm sitz bath, at least 15 minutes thrice daily, high fiber diet, adequate fluid intake, stool softener, calcium dobesilate, which is vasoprotective, topical analgesics, and proper anal hygiene. Non-excisional managements consist of sclerotherapy, rubber band ligation, bipolar diathermy, infrared coagulation, ultroid, cryotherapy, laser therapy, and radiowave ablation. Sclerotherapy is indicated in first or second degree internal hemorrhoids whose symptoms are not improved by conservative measures. The aim is to cause fibrosis that obliterates the vascular channel and a scar that supports prolapsing anorectal mucosa. 5% phenol in arachi's oil or almond oil is used as sclerosant. Patient is positioned in left lateral position. 3 to 5 ml of sclerosant is injected submucosally into apex of pile pedicle. Patient is reassessed after 8 weeks. Too deep injection has disastrous consequences like pelvic sepsis, prostatitis, impotence, and rectovaginal fistula. Next is banding. Baron's bander is used to slip tight elastic bands on the base of the pedicle of the each hemorrhoid. Bands cause ischemic necrosis of pile, which slough off within 10 days. The resulting fibrosis supports the remaining anal cushions. It is essential that the band is applied above the dentate line, as below it can cause intense pain. Side effect is bleeding. All 3 primary hemorrhoids may be treated at one session, and the process may be repeated after several weeks. So bipolar diathermy, this is not commonly used. It employs electric current to coagulate the hemorrhoidal tissue, including the mucosa and submucosa, and the approach is applicable for small bleeding hemorrhoids. Other variation include use of infrared coagulation and ultroid, that is direct current therapy. Infrared coagulation employs a tungsten halogen lamp that generates heat heat energy for 1.5 seconds, resulting in destruction of mucosa and submucosa at the application site. The depth of penetration of this injury is usually 3 mm. Conversely, the ultroid uses electric current that is applied for up to 10 minutes per complex treated. So this is surgical management, traditional this hemorrhoidectomy, which is gold standard. Indication include 3rd, 4th degree hemorrhoids, 2nd degree hemorrhoids that have not been cured by non-operative treatment, fibrous hemorrhoids, and mixed hemorrhoids when the external hemorrhoid is well defined. hemorrhoidal bleeding sufficient, hemorrhoids which cause anemia due to severe bleeding. Preparation of surgery, all of you know, stool softener and preoperative enema, done usually under general or regional anesthesia. Open technique is called Milligan-Morgan operation, where anoderm subcutaneous tissue between hemorrhoids is injected with dilute adrenaline. External and internal components of hemorrhoids are grasped by artery forceps with scissor or cutting diathermy. V-shaped cut is made through the skin. The dissection is proceeded up the anal canal with the sides of the mucosal dissection covering towards the pile apex and with the internal sphincter visible separate from the dissected pile. A transfixation ligature is applied to the pedicle at this level and it is excised well distal to the ligature. Care is taken to leave adequate mucocutaneous breach to avoid stenosis. Close technique is called Hill-Ferguson technique. Hemorrhoids is excised together with the overlying mucosa and the pedicle is transfixed with 3-0 polyglactin suture. The mucosal defect is closed with a continuous suture. This is technique of closed hemorrhoidectomy and care is taken to leave adequate mucocutaneous breach so that it will avoid stenosis. Post-operative complications, there is pain, acute retention of urine. So Foley's catheterization is must before procedure. Reactionary hemorrhage. Late complications are secondary hemorrhage, anal fissure, anal stricture, and incontinence. Now, though hemorrhoidectomy is gold standard treatment, one should always know what patient wants. And in in this era of minimal invasive surgery, there are too many options. What patient wants is painless or procedure with less pain, short stay, minimal excision, minimal dressings, less recurrences, and early resumption of duty. So there are various techniques like stapler hemorrhoidectomy, stapler hemorrhoidopexy, laser hemorrhoidopexy, Chutez procedure, Doppler-guided hemorrhoidal artery ligation. I am going to describe all procedures one by one. So first is staple technique by Longo. Staple hemorrhoidopexy, also known as procedure for prolapsed hemorrhoids, PPH, and described by surgeon Longo. It utilizes circular stapling device to excise a cylinder of mucosa and submucosa together with the vessel within above the dentate line while simultaneously stapling the mucosal ends together. Care is taken to ensure the staple line, it should be above dentate line and that the posterior vaginal walls should not be accidentally included. Less painful with quicker recovery, but the recurrence rates are higher. Complication might include staple line dehiscence, infection, rectovaginal fistula, tenesmus, stapler line stricture. Urgency, there can be urgency which may last for 8 weeks. 1 year recurrence rate is 8% and long-term 5 to 7 years recurrence rate is almost 36%. So I'm going to describe the steps in detail. First, assess instrumentation and reduce the prolapse. An obturator coated with local anesthesia jelly is inserted first, followed by circular anal dilator with obturator. The circular anal dilator having 3 centimeter length is insertion pushes the prolapsed mucosal tissue mass, ensuring no damage is done to dentate line and internal sphincter. Buttock skin is milked and circular anal dilator is fixed to the perianal wall using skin sutures. Next is pursing suturing. The pursing anoscope is introduced. 20 round body polypropylene suture is used for this suturing. The sequence of pursing should be even and circumferential and it should involve only mucosa and submucosa. This pursing anoscope should be withdrawn, repositioned and reinserted to avoid sliding off of the prolapsed tissue. Introduce finger, tighten the pursing to check the uniform circumferential closure. This suture bite should be initiated clockwise and for even pursing, one should follow the sequence of either odd numbers or even numbers, means 3, 5, 7, 9 or 2, 4, 6, 8, 10. If you are starting at 3 o'clock, you have to end your pursing at 3 o'clock. And it should be at same height and same plane. Pursing anoscope is withdrawn, reinserted, and ideally it should not be rotated to avoid the overlapping of the mucosa. Now the introduction of the stapler. Fully open circular stapler is inserted. Anvil is placed beyond the pursing suture. Surgical knot confirming the center is done along with the center of the anvil shaft. Using suture threader, the strands of the sutures are pulled in through the suture ports. Stapler is partially closed to ensure prolapse mucosa started drawing in the housing with moderate restriction to pursing to continue mucosal mass drawing in the housing. The 4 centimeter mark on stapler housing is positioned at the level of anal verge. Align the stapler along with the axis of the canal and check posterior vaginal wall. It should be being away from the staple line. Now firing of the stapler. Reduce the anvil by rotating the knob and keep observing the gap, setting scale to bring the red line in green zone as near to the lower B. Release the safety latch, wait for 30 seconds before firing. With one complete uniform pressure, fire the stapler, wait for 30 seconds, post firing for uniform hemostasis. After post firing and the closure, open the stapler with gentle rotation by half or 3/4 for smooth extraction. Move the stapler 90 degrees on each direction. Fishtail and withdraw the stapler. The pursing anoscope is carefully examined, reinserted. Examine the staple line and close any bleeders. Check the donut on the staple shaft, 3 centimeter mucosal mass of hemorrhoidal tissue. Care is taken, there should be this donut should be complete. Extraction of the stapler and CAD simultaneously is useful. Long-term recurrence rate is very high, that is 36%. So next is Doppler guided hemorrhoidal artery ligation or THD, transanal hemorrhoidal dearterialization. Here the feeding vessels of the hemorrhoidal mass with or without suture mycopexy can be used to treat the 2nd and 3rd degree hemorrhoids. Recurrence rate is lower but cost is high. Also, the complication rates and post-operative pain score are better after DHL. It is described by Morinaga in 1995. It is based on Doppler-guided ligation of terminal branches of hemorrhoidal arteries by a designated proctoscope associated with a Doppler probe. Once identified by Doppler, each terminal arterial branch is ligated using a figure-of-8 suture. This results in reduced blood supply of hemorrhoidal plexus, causing atrophy and fibrosis. This can be combined with mucopexy. Overall success rate is 90.7%. Morbidity is 18% in terms of pain and tenesmus. So here proctoscope with Doppler is inserted. The number of arteries, these are variable person to person. Average are 8 to 12 in number. First by Doppler artery is located and then ligated with figure-of-8 suture. Now come to laser hemorrhoidopexy. It is usually indicated for 2nd and 3rd degree hemorrhoids, and it is also used for 4th degree hemorrhoids superadded with mucopexy. Diode laser is used and the wavelength used are 980 nanometer and 1470 nanometer. Mechanism of action is heat is absorbed by RBCs and water in the blood vessel, that is hemorrhoidal artery and vein and tributaries beneath the mucosa, and these are obliterated. Light energy is transformed into thermal energy, which is delivered with precision to body tissue. This results in vaporization, coagulation, hemostasis, and ablation. How to optimize energy delivery and limit heat damage. Bare tip fiber should never touch mucosa while delivering energy. That is, the tip of laser fiber to remain 1 to 2 millimeter away from the mucosa. Tip to remain in the submucosal plane. Blanching of the mucosa is the indicator of optimum distance between tip of the fiber and the mucosal surface. For 2nd degree hemorrhoids, 150 to 250 joule per segments are given, and for 3rd degree hemorrhoids, 250 to 350 joules per segments are used. Apply ice after delivering energy at each segment. It is done in 3 steps: step A, step B, and step C. 8 watt is used bare tip fiber. Total dose 200 to 350 joule per segment. In step A, fiber should be intraluminal. Partial coagulation of hemorrhoidal artery and plexus. Tip of the laser fiber should not be at a single point for more than 1 to 2 seconds. That is, there should not be any hot spot. The tip of the fiber should be kept on moving sideways. In step B, submucosal delivery of energy to hemorrhoidal artery and plexus is done. Pierce bare tip fiber through the intersphincteric groove. In step C, homogeneous laser energy delivery within hemorrhoidal mass. If bile mass does not shrink, do not keep on giving energy, because appropriate effect of laser, it comes after 7 days. That means shrinkage of mass will be mainly after 7 days. Complications of laser: immediate are primary hemorrhage, submucosal hematoma, mucosal burn, puncture, and delayed are submucosal hematoma, infection, abscess, fistula formation. So this is the video showing laser hemorrhoidopexy. Small leak is given in intersphincteric plane, and fiber, laser fiber, bare tip laser fiber is inserted. We should not force, or there should not be any undue resistance while inserting this fiber. And tip of the fiber should not touch mucosa. There should be always side to side movement, and tip should not be at one place for more than 2 seconds. One can inject local anesthesia in perianal area, and after procedure, collagen sponge is inserted. So this one is the last transanal suture mucopexy, that is Chiute's procedure. This is 21st century procedure. Dr. Chiute is a senior colorectal surgeon in Bombay. The superior rectal artery and its branches at the level of plexus are numerous, which enhances the development of collaterals in a short period. There is free arteriovenous communication through capillary circulation in the carpona cavernosa recti, which is the probable cause for recurrence in stapler or DGHL procedure. This procedure involves the blockage of vessel at 2 sites at the distance of 2 cm, which reduces the chances of development of collaterals and recurrences. The hemorrhoidal mass is reduced by head low and manually. The mucosa and submucosa were transfixed to the muscle of the rectum by 0.5 to 1 cm long stitches. The stitches are passed through the depth of the mucosa, submucosa layer and part of muscle, started at 3 o'clock position at a distance of 4 cm proximal to dentate line. 20 polyglactin on a traumatic 30 mm half circle needle is used. Precaution should be taken that stitch should not pass through and through the rectal wall. The double locking should be continued for every stitch to avoid bursting effect. The vessel will get blocked at 2 sides at a distance of 2 cm, which reduces the chances of collaterals and recurrences. 2 rows of similar circumferential sutures should be placed proximal to the dentate line. There are 2 methods, apex to down or down to apex. It is successful in controlling mass prolapse and recurrence. It needs specialized Chiute's proctoscope made up of polycarbonate, that is hard plastic. It is self-illuminating. It contains proctoscope with obturator and fiber optic light candle. So there is a blockage of the arterial segment at 2 levels. The length of the bite should be 5 mm to 1 cm, and double locking should be done after every bite to avoid the bursting suture. Though it needs Chiute's proctoscope, it is more cost effective than stapler hemorrhoidectomy and stapler hemorrhoidopexy and laser hemorrhoidopexy. So post-operative care in all patients, like sitz bath, laxative, adequate analgesia, antibiotic, dry dressing, and follow-up. If evidence of stenosis, then patient is encouraged to use anal dilator. So these are the famous quotes for hemorrhoids. Awards are like hemorrhoids. Sooner or later, every household gets one by Sarah Morton. And hemorrhoids are like awards. Sooner or later, every household wants one by Ajit Kurkeja. So surgeon should be all-rounder to treat hemorrhoid because you have too many competitors like traditional home visitors, homeo, Ayurveda, Unani, RMPs, fax, gynecologists, and private aggregators. Thank you.
Thank you, Madhu, for your exhaustive discussion about the hemorrhoids. One must be able to differentiate between rectal varices and hemorrhoids. That is a very important aspect. I'll be requesting Dr. N.K. Singh, sir, to please give a narrative on anal stenosis. Madhu, what complication Madhu is doing with the hemorrhoids, with the hemorrhoidectomy, rather, I must say, how it should be treated.
Thank you, Dr. Pandey. And good morning to all of you, and compliments to Surgery Department of Subharti Medical College for organizing series of the surgical updates. Hope we will get more advanced updates in future also. Thank you very much. And प्रोक्टोस्कोपी या अभी प्रीवियस स्पीकर्स ने बताया, प्रोक्टोस्कोपी अगर प्रॉपरली नहीं किया, फर्स्ट फेलियर. Right from that, you are bound to be having complication in post-op. Most of the anorectal surgery, it is very difficult to predict which patient will go to land up in anal stenosis and which is not. But once it's happened, it's a really nightmare for any surgeon, because in my lifetime only one case I have, और उस पेशेंट को समझाते समझाते एनल डायलेटेटर दे के फॉलो कराते कराते थक गया. Finally, we have to go ahead with the some of the advancement flap. So again, you don't know about the surety of your flap, which you have done. So yes, anal stenosis is one of the major complication for any anorectal surgery. Commonest is the overzealous hemorrhoidectomy when you are dealing with the grade 3 or all the 3, 7, 11 positions. So you have to take very much care. See the funnel, inverted funnel shape. In case of the normal anatomy, you see when there is stenosis, that is the decreased passage size is there. So it is very difficult to pass the stool, even after lot of pressure exerting by the patient. So what are the etiological causes? If I go through, as I said, 90% it is related with the iatrogenic. That is by the surgeon himself. Overzealous hemorrhoidectomy. You are not able to judge the bridge in between the segments where you are doing the hemorrhoidectomy. The very less amount of mucous bridge is left. It is bound to happen the anastenosis. Then anal malignancy, trauma, inflammatory bowel disease, Crohn's, radiation on the pelvic tumors, then venereal disease like lymphogranuloma, then tuberculosis, chronic laxative abuse from the old age patients, then chronic abuse of ergotamine tartrate for the treatment of migraine headache may lead to stricture in the long term. Symptoms, there is variety of symptoms, but the classical ones are progressively increasing constipation, finally will end up in pipe stem stool formation. With lot of exertion, only pipe stem formed stools are coming in a little amount only, and associated with painful defecation and rectal bleeding. And later on, tenesmus, mucus discharge, these all will accompany. Diagnosis, the best is again go for the digital rectal examination and proctoscopy. You will feel a shelf-like projection in the lumen of the anal canal by your fingers. It can be tubular, it can be annular. depending on the length of the stricture of stenosis which has developed post-operatively or due to some reasons. So digital rectal examination, then proctoscopy, then anorectal manometry is an objective method for assessing anal musculature, rectal compliances, anorectal sensation, everything. Because you see, in the morning itself, it is a very complex anatomy. And you have disturbed whole of the anatomy. His life is hell for whole at all. So it is important to ascertain the cause of the stricture. If it is inflammatory bowel disease like Crohn's disease, never go at any cost for any form of anoplasty. It is doomed to fail. Or if it is some malignant lesion, you have to go for the major surgical procedure, not just to treat the NSA. Don't think it is a stricture, it is a malignant stricture. You have to do biopsy, precautionary. Now, classifications. Yes, it is a very difficult topic to classify. The three assessments are there. One, basis of severity. It can be mild, moderate, or severe. For mild, with the tight anal canal, you can examine with the well lubricated fingers. But with moderate, you have to go for the forceful dilatation to insert either the index finger or medium hill Ferguson retractor. But if it is severe anal stenosis, neither the little finger nor a small Ferguson retractor can be inserted unless a forceful dilatation again. The severity, then it can be diaphragmatic after inflammatory bowel disease. Then it can be ring-like or annular like post-Crohn's disease. Then it can be tubular like post-lymphogranuloma infection. Then on the basis of the levels, it can be low, middle or high anal stenosis. Low anal stenosis, distal anal canal at least 0.5 centimeter below the dentate line. Then 0.5 centimeter proximal to 0.5 centimeter distal to the dentate line is the middle one. And high is proximal to 0.5 centimeter above the dentate line. And it can be diffuse all anal canal, that is 6.5. The most it is the 65% is the low stenosis. Why this classification? Because when you are going for the advancement of flap, there are various methods. For low stenosis, you have another types of flaps. For higher one, another group. 90% are due to excess skin removal in the hemorrhoidectomy. Whenever you are dealing, even with the staple hemorrhoidectomy, it is 8% to 10% stenosis is there. The failure is 35 to 36%, recurrence is there, stenosis is 10%. What about the stapler? Very popular. Most of the novice surgeons are very fond of having stapler hemorrhoidectomy. They should do. It is very fascinating for them, just like laser. You know the result of laser hemorrhoidectomy? Again, it is a failure in a long term. So my young colleague, please be careful not to run behind the technology, run behind the anatomy. Prevented by preservation of adequate mucocutaneous bridge, which prevent anal stenosis. And why not post-op, post-hemorrhoidectomy anal dilatation on a routine basis? Every 3 to 5 days, some form of proctoscopy should be done. Nowadays, I've seen residents, they are not doing proctoscopy even in the OPD, in the wards. And that is why everybody is in this. And I'm telling you, if the anal stenosis develops, it's very difficult to treat, very, very difficult. Treatment is based on the severity, cause, localization. Accordingly, I have classified. What are the options? When you say to a patient of hemorrhoidectomy or fissurectomy that you have to go for another surgery, and how you will explain, how you will counsel the patient, because it is the surgeon's induced. It is iatrogenic. How will you explain the patient why you have to go for the another surgery? So better to prevent it and not to go for this. So it can be with the mild to moderate symptoms. You can go with the conservative like fibers, bulk laxatives, and lifestyle modifications or gentle dilatation in a sequential manner. But if it is going with the severe symptoms, with the progressive constipation, painful, bleeding, for the simple stricture, you can dilatation and anatomy, but for extensive, you have to go for some or other form of anoplasty. It can be YV or island, house, or advancement of flaps or S-plasty, whatever. So just say that with the laxatives and fibers and analyzer, patient can improve. So okay, I'm not going details. So see, most of the figures, they are going for diamond shape or some form of advancement flap. That is the only option after stenosis. If it is malignant, you have to go for the resection enhancement. If it is a Crohn's induced, you have to go with the conservative treatment and treat the Crohn's disease medically. So there are various operative procedures like Martin's abdominoplasty, YV advancement flap, VY advancement flap, diamond shape flap, house shape flap, U shape flap, and rotational flap. YV plasty and VY plasty, they are mostly when the stenosis is below the dentate line or the low stenosis. When it is on the higher side, you have to go with the other, that is house shaped or U shaped or rotational flap. If it is less than 50% circumferential stenosis, then you can go ahead with the YV or VY. But is more than 50% circumference, then you have to go with some or other form of rotational flap only. So these are some of the pictures. In first, it is the diamond flap designing with the advancement, and in the second is the VY flap. And finally, longitudinal design, which can be closed in the transverse manner. This is all from my side in a short. Thank you.
Thank you, sir. My personal thanks to Dr. N.K. Singh, because his father-in-law is not well, still he was able to make it. Thank you, sir. What to add now, sir? I must request you and ma'am to have the final closing words.
A very good afternoon to all of you. All the esteemed faculty of Subharti, especially Professor Mishra, the HOD, Dr. Pandey, Dr. Maheshwari, and my mentor, Dr. B.K. Jain. I was a student also, and all the delegates and students. I think we have had a very nice session today, in which we have started from the beginning and to the end of the benign diseases of the anorectal canal. And the one thing which I want to say is that I think the most complicated, as already the speakers have said, is the anatomy of the anal canal. And a small advice from my side is that the younger surgeons who are not experienced in doing the anal surgeries, they should first go into the depth, read the anatomy of the anal canal first before they attempt a surgery on the anal canal. And they should be supervised by some senior persons, because it's not all that easy. And the complications are many more than expected. So that is it. And like every speaker has done a fine job, and they have like in very brief, they have very clearly enumerated the causes, the treatment, and the complications of all the benign diseases of the anal canal. I must congratulate Subhati faculty, especially the HOD, and again Dr. Pandey and Dr. Maheshwari for conducting this session. Thank you so much.
आप कुछ कहना चाहेंगे? हैं? I think Madam has already elaborated about the speakers of the day, but I must say few words about my moderator, Dr. Sanjay Pandey. For last 1 week, he is practicing and he is preparing the talk in such a way, and he is able to coordinate with the speakers. So it is really, he is a wonderful human being, good teacher, good surgeon, and I must say this panel discussion, the credit goes to him, because he is able to moderate in such a way that everybody is participating in it. Thank you very much.
Thank you, sir, for the humble words. But I must say, all the speakers who have taken all the pains to come here, thank you once again.
Thank you, sir, for this wonderful talk. I would like to invite Dr. Tripta Bhagat to felicitate Pandey sir, Dr. Sanjay Pandey sir.
Thank you, ma'am. Thank you, sir. I would like to call upon the stage Dr. VK Jain, sir. I would like to call upon the stage Dr. VK Jain, sir, to felicitate Dr. Tripta Bhagwat, ma'am. Sir, kindly felicitate. Sir, I would like to call upon stage Dr. VK Jain, sir, to kindly felicitate Dr. Maheshwari, sir.
I would request Dr. Maheshwari sir to kindly felicitate Dr. Shalabh Gupta, Dr. N.K. Singh sir, Dr. Madhubala Gaur ma'am, and Dr. Viren Kumar sir. Thank you, sir. I would like to invite Dr. Arun sir to kindly felicitate Dr. Anuj sir. And Dr. Shobhit Rezada sir. Sir, excuse me, sir. Thank you, sir. Next on stage, we are honored to have with us Dr. Shibumon M. Madhavan, who is a leading hepatobiliary surgeon.
Sir, graduated from Medical College, Kottayam, Kerala, and completed his surgical residency from PGI, Chandigarh. He has had the privilege of serving in esteemed institutes like PGI Chandigarh, MIOT International Hospital, Chennai, KIMS Hospital, Kochi, and he has had good fortune of providing the expert service in overseas like in Middle East. Sir has completed his MCH in gastroenterology surgery from RML Institute of Medical Sciences, Lucknow, and worked in his capacity as an assistant professor before joining the LLRM.
Sir is a member and fellow of the American College of Surgeons, as well as a founder member and fellow of Association of Minimal Access Surgeons of India. Sir is also a member and fellow of Indian Association of Gastroenterologic Surgeons and a lifetime member of IMA, ASI, Hernia Society of India, and IHPBA. Sir has a commendable number of publications in national and international journals. Today, Sir is going to enlighten us with his talk on energy sources and staple devices used for colorectal surgery. We would like to invite you on stage, sir.
We would like to invite Dr. Salabh Gupta, sir, as a chairman. To chair this succession, I would like to invite on stage Dr. Salabh Gupta, who is an accomplished and ambitious surgeon with 23 years of working experience, completed his MS from SMS Medical College. He has been at a center point of organizing many national conferences and training programs. Sir is the proud recipient of President Appreciation Award from IMA Ghaziabad and Gyanpi Lal and Suman Academics.
He has received the Suman Academic Achievement Award by UPIMA. Sir has also been presented with the Exemplary Services Award by ASI, Dr. V.K. Kapoor Award for Best Local Branch President Award for his tenure as the President of IMA Ghaziabad. The list of honors bestowed on him is never ending. We can only hope that some of his enthusiasm and excellence rubs off on us. We would like to invite Dr. Shalabh Gupta sir on stage to chair the session.
Very good afternoon to all of you. Thank you, Dr. Mishra and the entire team of Subharti Department of Surgery for inviting me to this wonderful event. I have two topics. First is energy sources and the other one is staplers. In fact, it is a little bigger. We'll try to finish in time. I'll be talking on these are the highlights of my topics: fundamentals of electrosurgery, various types of energy devices used in colorectal surgery, monopolar, bipolar, ultrasonic vessel sealing system, APC. I will skip the laser and the infrared cryoablation, which is already covered. In the stapler session, I'll be discussing about the basics of stapling, various types of staplers used, staplers in colorectal surgery, and I'll show a 2-minute small video where we use these things. Coming to certain terms, we all every day use the term cautery, which is derived from the Greek word koterion, which means hot iron. We don't use cautery nowadays because that is the application of heat, direct heat to the tissue to burn it or cause hemostasis. This will use very high temperatures. It is already described in it dates back to even 2000 BC in Indian literature, as well as during Hippocrates' time, 500 BC, application of cautery is all described in the olden literature. This is the cautery which we don't use. It is either heated by fire or by battery or electric power. This is the electro cautery with the different kinds of tips. I think dermatology people still they use it, but surgeons we don't use it nowadays. Diathermy is a better term. That is the commonly used term, maybe more accurate. This is an interesting article regarding the awareness of diathermy among surgeons. This study was conducted in the UK, Ireland, including consultants, specialist registrars, fellows, as well as the housemen. And surprisingly, 82% of them had no formal training. 89% of them felt it was safe instrument. 56% felt that they had inadequate understanding. And 57% exhibited dangerous lack of awareness in managing the equipment and not yielding the desired effect. 22% were unaware of any special groups which require special caution. And despite of all these, only 42% wanted a formal training. So if we conduct this kind of study in our country, this will be even worse, I think. Diathermy means, dia means passing through, therma means heat. So it is passage of heat, and we use the electric current for passing heat or heat the tissue using high frequency current. The electric current is converted to high frequency alternating current by the generator in the range of 2000 kilohertz to 3.2 megahertz. And it performs three basic functions, that is cutting, coagulation, and fulguration. Probably the best term to use is electrosurgery. And the equipments which we use nowadays are called electrosurgical units. They are not cautery machines. They produce very high frequency, that is 202 kilohertz to 3.3 megahertz. Also, some of them produce radio frequency current in the region of 500 kilohertz. This picture shows the various electromagnetic spectrum. The 60 watt, we have 50 hertz current in India, 60 is there in US. By around 100, the neuromuscular stimulation stops. Electrosurgery uses, as I already told, 200 to approximately 550 kilohertz. The basic principle is electromagnetic energy is converted to first kinetic energy, then converted to thermal energy in the cells. The tissue effect, the effect on tissue is determined various electrical properties like resistance, voltage, current, and as well as the size, shape of the electrode, duration of the exposure, and the tissue impedance or the tissue resistance. The operating temperature is around 200 to 400. It can reach up to 200 to 400. It may be at a lower temperature also. The basic principles in different modes is like a very high density in the tip will cause focus of energy and will cause vaporization. Slightly lower current, little bigger area will cause heating. Very large area probably may not produce that much effect. This is like you focus a lens with the sunlight. You can see the focus it nicely. You can see the fume and fire, and there'll be a hole in the paper. Exactly same like this. You focus, finer the tip, more will be the cutting, blunter the tip, more will be the coagulation. And it's very wide one, probably no effect will be there. Just like the return plate of the cautery. What happens in the tissue is about 45 degree onwards, there will be tissue necrosis. Protein will get coagulated, 80 to 100 degree total desiccation, carbonization, drying, shrinkage. Above 100, the water will get vaporized. Then above 125, complete oxidation of proteins and lipids lead to carbon residue or extra. Coming to the history, the first modern electrosurgical unit was invented by William Bowie in 1920s, and the father of neurosurgery, Harvey Cushing, used the initial models. They were working together. And he had sold this technology for a price of $1 in those days, and he never benefited from that. That is Bowie and with his initial machine. These are the initial commercially used available machine in those days. Basically, we have two types of electrosurgery, monopolar and bipolar. Actually, all these, there are two poles. The difference is where these two poles are located. In monopolar, one is at the tip of your instrument which you hold, and the other pole is in the patient return electrode or the patient plate. Bipolar, both the poles are in the same equipment, the tips of the same equipment. That is only difference. Again, the same thing only. Another picture which shows how it works. You use the pencil, the current passes through the patient body, then goes to the generator through the return plate or the return electrode. In bipolar, it passes between both the tips of the electrode. So there is no passage of current through the patient body, so it won't interfere with the equipments like cardiac pacemaker or other monitors. These are all various kind of modern machines available in the market, and these are the latest ones, which by AirB. But the first one is called YO3 with the modern bipolar technology. Second one is by Medtronic, which has got a monopolar, bipolar, as well as the vessel sealing system. The instruments, we are familiar with all these things. The blue one is the hand pencil, which has got a active button, blue for coagulation and yellow for cutting. The monopolar hook, all of us are familiar. The umbrella-like one is the one which use for radio frequency ablation of the tumors, mostly in the liver. And on the right side, you can see different kind of patient electrode plates, which returns the monopolar energy back to the generator. The return plate should be bigger so that there should not be any concentration of current. It should be at least 22 square inches, placed well over a muscular area, because the muscle and the nerves are the conductors of electricity. And the area where you apply it should be ideally free of hair and should be properly contacted. Otherwise, you will have a burn at that site, short circuiting. Poor contact will cause burns, but nowadays all these hi-fi machines come with the sensors. If it is not properly applied, it will make noise and warn you that it's not properly applied and the equipment doesn't work. The active electrode can be sharp or blunt. The sharp edges is used for cutting. Blunt edge is used for coagulation. The same instrument, you little tilt, you'll get the sharp edge. If you keep it flat, it will become blunt. You can use the same thing different way. Coming to the monopolar, it's commonly used in lap colorectal surgery as well as the open colorectal surgery. It can control vessel up to 1 to 2 millimeter, small oozes. The advantages are it's very easy to use, very minimal smoke. It preserves tissue planes and the area, you can see the planes nicely. And it helps to maintain the tissue planes, especially in the total mesorectal excision and rectal surgeries, as well as total mesocolic excision. Complication, we should be very careful while using this, because you can have burns outside your field. They can have explosion of the inflammable gases used by anesthesia as well as the bowel gases. Direct coupling is you contact the instrument, another metal instrument, just like we cauterize or diathermize the vessel. You catch with one instrument and touch the pencil. That is direct coupling. Accidentally it happens, it's called direct coupling. Capacitive, it happens in the laparoscopy. It can interfere with the pacemakers and defibrillators. Insulation failure, improper application of the electrode, all can cause thermal injury at unwanted site. So you should be very careful. Bipolar instrument, it comes as a forceps with both the electrodes in the instrument tip. Now, for open as well as laparoscopy, various shapes, size are all available for lap. It is much more effective than monopolar. It can seal, coagulate the vessel up to 3 to 5 millimeter. You can apply when there's a bleeding. Best to control even major vessels before clipping. So we use even bipolar coagulation followed by then clip so that it remain sealed. It is better than your harmonic scalpel or ultrasession in terms of hemostasis. Cutting and coagulation current, there is slight difference in the electrical aspect. Cutting is a continuous, slow wave, high frequency, low voltage, and there is rapid tissue heating and cutting effect. Coagulation is pulse, high frequency, high voltage, and slow heating. It will cause protein denaturation, and there will be coagulation. This is the waveform in cutting as well as coagulation. There is something in between called blended current. It is not a combination of cutting and coagulation actually. There is something called a damping. So you remove the current flow in between. That's all about monopolar energy. Next is about ultrasound energy. It's commonly used one is the harmonic scalpel by ethicon endosurgery. It uses very high frequency ultrasound, that is 23 to 55 kilohertz. We know human hearing is 20 to 20,000. Above 20,000 is called ultrasound. For ultrasound machines, we use 2 to 18, and all the device like harmonic scalpel, we use 23 to 55 mega kilohertz we use for harmonic scalpel. CUSA uses a lower one. And these instruments, the tip gets heated, and it can even get heated up to 150 degree. The monopolar or bipolar instrument, the tip doesn't get heated, the tissue get heated. This one, because of the vibration or oscillation, the instrument itself can get heated. So it works with the mechanical oscillation, just like a to and fro movement, 55,000 per second. Manifest the tissue effect by a combination of mechanism, mechanical cutting, desiccation, protein coagulation. Then the technology used in CUSA is called cavitation. There is some kind of vibration and to and fro motion. And in some tissue, like hepatocytes, it produces a cavitation. Tissue with more elastic fibers like the vessels and pedicle, it just preserves that. Because the heat is there in the tip, unlike the monopolar and bipolar devices, the accidentally you touch the intestine, you can have thermal injury. There is a cooling period also. We'll come to that later. So we should be aware of the principles, how it works, because all these hi-fi things doesn't mean that you should just use it. There should be understanding. So you must have seen there is one level 1 to 5 that indicates how to and fro this, how much it moves. So 1 is approximately 30 to 50 microns and 5 is 100 microns. That is the to and fro movement. And on the left side, you can see the old generation. On the right top, you can see the new generation equipment, which has got vessel sealing as well. This is by the ethicon endosurgery. This is the one by Medtronic, which is hands-free, means wireless. There is no connection, you can use it. Everything is same. So if you keep the setting at 1 means there is more coagulation, less vibration of the tip. So there is more coagulation, but less cutting. If you keep at 5 means there is more cutting, less coagulation. How to use means there is a combination of compression. There is a combination of lift as well as the setting. If you compress very well, lift the tissue, then keep the setting at 5 means it will get cut very fast, but it may bleed. If you compress less, don't lift the tissue, keep the setting at a lower one, you will get a nice coagulation. That's about the setting of this equipment. Safety measures, don't go and touch the instrument on hollow viscous, because there is a cooling time around 20 seconds when you are working inside the liver, around 45 seconds for the rest of the area like mesentery, peritoneum. So be careful while using with these instruments. The tip can be as hot as 150 degree. The advantages, there is no electricity going through the body, so no direct or indirect coupling. It is very controlled and precise cutting as well as coagulation with one equipment. Then multifunctional device can reduce operating. You are not changing the instrument. Instrument use, go ahead with surgery, so some time is saved. Minimal thermal spread approximately around 2 millimeter. The newer diseases, they claim even much lesser. Less blood loss can be used in patients with pacemakers and defibrillators. In colorectal surgery, it's not a must for colorectal surgery. Most of the things can be used, can be managed with monopolar and bipolar. But the advantage is, especially in laparoscopic, selectively we use, especially for the lateral ligament division, then splenic flexion mobilization, dividing the peritoneum, dividing the mesentery, mesocolon. So it is quite helpful. Many surgeons use the harmonic or the ultrasonic throughout the surgery, finish off with one instrument. Can be done. It produces some particle, especially because of the water vapor created. It can smoke the camera, and tissue planes are not clearly seen like a monopolar electrosurgery, especially in the rectal resection. You seal with the harmonic, everything will look white, then you can't make out where is the fascia, where is the tissue. That is one disadvantage. Next is about the vessel sealing systems. These are nothing but advanced hi-fi bipolar energy. They seal the vessel by melting the collagen and elastin and seal it like a permanent plastic seal. Up to 7 millimeter you can seal, and it can withstand 3 times the systolic blood pressure. That is 360 millimeters of Hg it can withstand. So it's very secure sealing. Lateral thermal damage again less. Smart technology is involved in this, so it will give a warning sound when the sealing is completed so that the surgeon can cut after it is sealed. This is the original vessel sealing system known as Ligasure by Valley Lab. Now it's Medtronic. And those are the laparoscopic as well as open probes. Different kind of probes are available. There is a blade also inbuilt. We can use that for cutting. This is by Ethicon, the N-seal vessel sealing. This also can be used. This is the same equipment for harmonic also. So both the equipment can be used in the same machine. This has got advanced features like positive temperature coefficient. It keeps the temperature low, around 100. It also provides uniform compression throughout the entire seal area. So minimize the thermal spread, all that. So a lot of things they claim. And thermal spread is, they say it is only 1 millimeter. So more safer. The use in colorectal surgery mainly for sealing the vessels to 5 to 7 millimeter, but all of us feel more happier when you apply one clip or a ligature, even though it can safely deal with the inferior mesenteric vessel or any of the colonic pedicle. It is very good in doing hemorrhoidectomy. Nobody has talked about hemorrhoidectomy using ligature. It's very, very pleasant to do. No bleeding, no blood staining, just like open hemorrhoid. Just seal it till the end and put one suture in the apex. Less time consuming, no much pain also. This is another equipment known as Thunderbeat by Olympus, which has got all-in-one monopolar, bipolar, vessel sealer, as well as harmonic. There is the one hand instrument has got a harmonic as well as vessel sealer. So it is very handy. Take one instrument. If you want to seal, you seal. If you want to cut with a harmonic, you cut with. So that is another one. There are separate ones are also available. APC, Dr. Achal has already shown APC. APC, argon plasma coagulator, it uses monopolar energy. The argon beam or the gas beam is used for transfer of the current. It is mainly used for superficial lesions like in colorectal, angiodysplasias, radiation enteritis. That is the common use. Commonly, we use it for liver surgery. It's good for angiodysplasia, superficial small bleeds, and radiation proctitis also. It is very good. That's all about the energy devices. Next, we'll move on to the staplers. Surgical staplers are specialized devices. They're just like your skin staplers, little modification. It can be used to, it can save a lot of time. That is the main advantage. Any organ, bowel, intestine, bronchus, pancreas, lungs, anything you can close with this. But you should know how to use it, what are the basic mechanism. Then anastomosis like end to end, endoside, side to side, all this you can do. And these has made difficult anastomosis like esophagojejunostomy, where you find it technically difficult, very low and ultra low anterior section, where the suturing is very difficult, especially in the male pelvis. You don't reach there, your instrument doesn't reach, nothing is seen. So these instruments had made it feasible and more safer. Coming to the history, the Hungarian surgeon Hammerhalt is known as the father of stapling. Then there was a lot of modification by different people. The first stapler was made by the United States Surgical Corporation under the brand of Auto Suture, which is now taken over. Finally, it's under Medtronic. Johnson & Johnson came a little later. So these are the two competitive people in the market. There are n number of other companies who make stapler. Coming to the mechanism, the stapler pin is something like what is given in the left figure. When you fire the stapler, it is folded and directed into a shape like something like B. Some staplers of Ethicon, they have a crisscross. It's not like a B. It will be little twisted, but most of the staplers, it fire like a B. What are the advantages? It is definitely faster than suturing. If you want to close one bowel stump, it will take at least 10 minutes. For stapling, it just 1 minute, you can finish it off. Reducing operating time, reduces tissue trauma. There is no need to hold with the forceps many times, no need to pass needle, tie, all those things are not required. So tissue trauma is definitely reduced. It is more accurate and consistent. How much ever you try, it's very difficult to precisely put the areas in between the sutures. At the end, it may not be very happy. It doesn't look beautiful. So many times we feel that it's not looking beautiful, even though it is safe. So those things are avoided. Then it is comparable to result with suturing. It is not superior. Made difficult procedures like a ultra low anterior section, esophagojejunostomy, all more feasible and made it easier. These are the various kinds of staplers available in the market. Linear stapler, it's otherwise known as TS stapler, thoraco-abdominal staplers, which has got 2 rows of stapler. There is no knife, no cutting. You have to cut it with a knife. Linear cutter has got 4 or 6 rows of stapler with a knife cutting in between. Laparoscopic staplers are nothing but linear staplers made fashion like for laparoscopic use. Curve cutters also in a curve configuration meant for using in the pelvis. They are also linear cutters. Circular staplers are otherwise intraluminal staplers. They are used for intraluminal end-to-end anastomosis. Then hemorrhoidal stapler already they have described. That is also modification of a circular stapler. Then nowadays we have seen circumcision. That is also a circular stapler. Skin stapler we all use, we know. Then which stapler to be used where? Closure of bowel, bronchus, blood vessel, or you can use with a linear stapler. Division of bowel, bronchus, vessel, pancreas, you use a cutter. Side to side anastomosis, use a cutter. Functional end to end, again linear cutter, and can close with a linear stapler. End to end anastomosis, end to side anastomosis, we use a. Example for end to end anastomosis is a colorectal anastomosis. End to side is a Roux-en-Y esophagojejunostomy. Linear stapler, it fires 2 rows of stapler without division. Whichever side you want, you can cut on that side. Then commonly used for closure of duodenal stem, bronchus, closure of enterotomy. You can use multiple times. It comes in different sizes. White, blue, green reloads are available based on the, we'll come to that in detail. This is how it looked like by Covidian. That is the Ethicon, both look almost same. Slight difference is there in the firing and the other shape, all that. This is how you use. You fire it across, pass across the duodenum, then apply it, then cut on the stomach side so that the staple line remain with the duodenum. If you want to close the enterotomy, lift it with either a Babcock or sutures, then fire it, cut off what is above the level of stapler. Linear cutter is otherwise known as GIA stapler. GIA stands for gastrointestinal anastomosis. It fires 2 or 3 rows. The newer ones comes with the 3 rows. And there is a blade in the cartridge or blade in the stapler which cuts in between. It used for dividing as well as anastomosing, cutting, all use you can use. This is the old generation linear cutter, which has got 2 rows of stapler. It's COVID in it comes with the 60, 80, 100 millimeter, Ethicon 55, 75, and 100. 3-4 types of cartridges are there. The white is for thin, which is used for blood vessel. The normal stomach, normal intestines, we use blue. Green is for thick, especially for stomach or thickened bowel. Then if you want something in between, you can use the yellow. This is the newer generation linear cutter known as NDLC. It has got 3 rows of staplers and it has a blade in the cartridge itself. So it cuts in between. That is the Covidian 3 row. It works exactly in the same 3 rows. There are 3 rows are there, 2 rows are 3 rows. People claim that it is little more safer, but I don't know. 2 were also equally safer. This is how you use. You introduce the one lumen, you introduce the anvil, other lumen, you introduce the stapler with cartridge and just fire it. And the stump you close, you will have a side-to-side anastomosis. Want to divide, you just apply across, fire the stapler, cut it. It is done. That is the linear cutter. This is the laparoscopic staplers. This is called the universal stapler. This stapler handle, all the staplers fit into this handle. These are the various kind. One short one is for open surgery, long one is for laparoscopy. Various kinds are available, various shapes used for laparoscopic as well as open work. This is powered stapler called iDrive. There is a button for firing. You just press the button, no need for hand movement. This is the latest generation of powered stapler called the Signia stapler by the Medtronic. I have not used this. I have not seen also. So what they claim is deliver consistent staple lines, provides precision, and everything is power operated. You press button for articulation, rotation, clamping, everything power buttons are there. I don't know. I have not seen. Then there is a display on the stapler which will show all the details. We need to see what it is. This is the Ethicon Endo GA powered stapler. This one we have used. This is the important slide. Though these are the color coding for different types of cartridges which we use. Gray is the thinnest one, which the stapler height is 2 millimeter, and when you close it, you have 7.75 millimeter. It is for the thin tissue, like mesentery, thin mesentery, or blood vessel also you can apply. White is mainly for blood vessel, 2.5, close height is 1 millimeter. Blue is the usual regular one, which we use for intestines and normal and not thickened stomach. Regular thick yellow, then green, then very thick tissue you feel, then you can use the black one. When tissue is too much thickened and edematous, you feel that it is not safe, suturing is the best, because you compress something which is very edematous and thick with a stapler, crush it, anastomose it, invariably it will leak. So edematous tissue, emergency, and when you compress the tissue, you have to compress it slowly and wait for some time so that the tissue fluid will get displaced and you will have nice sealing with the staples. Otherwise, you will have, you cut, you apply, immediately you fire. Either you will have bleeding or you will have leak or you may have both. Curve cutters are used for dividing the rectum, especially when you have a low anterior resection. The two types are there. One is called a contour by Ethicon endosurgery. Other one is a radial stapler, the purple one which is there in the contour is a stapler by itself, which we need to buy separately. Cartridges are reloadable. The radial will fit into their universal gun. You just need to buy the cartridge. How to apply? This is how you apply. Then fire it. That's all about the curve cutters. Coming to the circular staplers, again, it comes in straight configuration as well as curved one, depending on how far you need to use. The Covidian or the Medtronic one comes with a tilt anvil. The other one has got a straight anvil. It doesn't tilt. The mechanism of firing and everything is almost same, rather a little bit difference as recommended by the company. So you see, you can have a knob, black knob behind. If you turn, that will open. It's all written there. Anti-clockwise is opening, clockwise is closing, and there is one red thing, lever is there in the at the junction of the handle. That is a lock. You unlock it, then just fire it. The anvil is detached. We'll show in. So this is used for end-to-end anastomosis. Different sizes are available. Rectal anastomosis, anterior section, low anterior section, restorative proctocolectomy, esophageal anastomosis, Roux-en-Y esophageal anastomy, bariatric Roux-en-Y gastric bypass. All these we use. Then these are the newer ones. These are the 3-row staplers, the latest ones. This is the powered stapler by Ethicon. Medtronic doesn't have a powered circular stapler. 25 to different based on the size where you are using. Rectum usually we use around either 29 or 31. We can even use 33 also. Esophagus we use a smaller one, 23, 25, depending on the size. There are pediatric smaller ones are also available. Hemorrhoidectomy stapler already covered. It is a straight circular stapler with Covidian has got a detachable anvil and Ethicon a non-detachable anvil. These are the components of the stapler. Procedure has already discussed, so I don't need to go. I'll skip all this. There's a small video which shows the usage of, this is the last slide, of, I don't know whether it's visible. This is a video of anterior resection where there is you can see some blue color, the tumor is tattooed, the very old video, sorry for the poor quality. That is the inferior mesenteric pedicle, that you can see the monopolar hook is used to cut the peritoneum and mobilize the inferior mesenteric pedicle. This is very old video, around I think 7-8 years old video, which is all ready made. So I put this short one. It is tied. You can apply clips. You can just apply clips only. Then the pedicle is divided. The rectum is further mobilized. That is the mesorectum. What you see is the holy plane of healed. You need to stay in that plane. That is the mobilization of the lateral attachment of the mesentery and left colon using monopolar. You can use harmonic also, no problem. That is the mobilization of splenic flexure area. Once you completely mobilize the left colon splenic flexure, if you need to bring it down, many times you may get away without splenic flexure mobilization. Then you decide where you need to divide. 5 centimeter distal to the mark area is sufficient. Even 2 centimeter also is fine. But if you have more length, obviously 5 is more happier. That is, harmonic scalpel is used for a thicker mesorectum. After everything is mobilized, there is a small Phalanstein incision is given. The specimen is already marked where to divide. That is a linear stapler. You just divide. That is the anvil of the circular stapler in the proximal end. Then you take it inside. That is the colorectal anastomosis. It is closed and checked for patency by injecting some air, and that's a Jackson Pratt drain kept. And that is the end of this video. Sorry. Yeah, that is the final outcome of. That's all about the talk. Thank you. Thanks once again for inviting me. Any questions? I'll try to answer.
Thank you so much for your crisp presentation. It was so nice and it was covering all the aspects. It is a boon like the presentation which for the postgraduate students. So if there are questions, you can ask him directly, or we can talk about the questions during lunchtime also.
Yeah, that will be better. I think people are already waiting
Yes,
for
yes,
lunch.
yes,
Only
I
we are
think,
delay
yeah.
by.
Yeah. So thanks a lot.
Now I request Dr. Shalabh Gupta sir to facilitate Dr. Shibhumon Madhavan sir. I request Dr. Shashank Mishra sir to facilitate Dr. Shalabh Gupta sir.
Moving ahead with the mind streaming session, now we progress to the arena of the anal incontinence, which will be chaired by Dr. N.K. Singh sir, Senior Consultant Surgeon with Unit in Charge position in Surgery Department and also working as Professor Surgery with TMU Muradabad. He has published many papers in reputed journals and is a member of IMA India, PHAGES and FLS. The session will be
The session will be discussed by Dr. Devinder Singh sir, Assistant Professor in the Department of Surgical Discipline AIMS, New Delhi from November 2022. Sir was also Assistant Professor, super specialist in Surgical Gastroenterology as ESI Medical College, Faridabad from February 2021 to November 2022, and he has worked as a senior resident in Department of Minimal SS and General Surgery, AIMS, New Delhi from January 2018 to 2020.
Thank you for the kind invitation. So first of all, I would like to congratulate the organizers for organizing such a wonderful academic event. And I also am thankful to them for inviting me to present here. So I will discuss about anal incontinence in the next 30 minutes in quite detail. I will discuss the presentation under the following subheadings: a brief introduction, followed by the normal physiology defecation, which has already been discussed, the etiology and its pathogenesis, how to evaluate a patient presenting to us in the OPD, and the management option, which is supported by the current literature. So the term fecal incontinence and anal incontinence are used interchangeably, but there lies a difference. The term fecal incontinence means involuntary passage of solid or liquid stools, whereas anal incontinence means involuntary passage of solid or liquid stool as well as flatus. And incontinence is broadly of two types: urge incontinence or passive incontinence. The term urge incontinence means in which the patient has a desire to defecate, but he is not able to control. Whereas in passive incontinence, patient does not have any desire to defecate and he is unaware of the incontinence episode, and he become aware only after the incontinence episode has already occurred. The prevalence of this condition ranges widely in the literature on 2 to 20%, and it is slightly underreported because of social stigma. Now coming to the normal physiology defecation, the defecation process starts as soon as the fecal matter comes into the rectum from the sigmoid colon, which leads to reflex relaxation of internal anal sphincter. And during defecation, the anorectal angle, which is created by the pivorectalis muscle, gets straightened, which is facilitated by the squatting posture. The intra-abdominal pressure is increased by straining, which leads to descent of pelvic floor muscles, and there occur voluntary relaxation of external anal sphincter that leads to passage of stool. And the point to be noted here is that the squatting posture is the normal posture for defecation. However, most of us, and even in the patient house, the toilet is of Western type. So to facilitate normal defecation, it should be converted to Indian type by using a footstep below the knee, below the feet, so that on squatting, the anorectal angle becomes straightened. So the anal incontinence is maintained by some of the anatomical barriers, and if there is any breach in any of these, it may lead to incontinence. The first one is the rectal pliability or rectal distensibility. Next is the internal and external anal sphincter and the pure rectalis muscle. So, as I have discussed, any breach in any of the following may lead to anal incontinence. So, first is the dysfunction of anal sphincter. Next is the decrease in rectal compliance or rectal distensibility. Next is the decreased rectal sensations. Next is the fecal retention or impaction because of any cause. And last is the idiopathic. So, dysfunction of anal sphincter can be either traumatic or atraumatic. The traumatic cause of anal sphincter dysfunction includes the forced vaginal delivery, the prolonged stage of labor, or the instrumental delivery, or the surgery of the anal sphincter or the surrounding structure like fistulectomy surgery or Botox injection in the anal fissure may also lead to traumatic sphincter injury. And the atraumatic causes includes diabetes, spinal cord injury, or infiltrative disorder like systemic sclerosis. Next is the decreased rectal compliance or decreased rectal distensibility, which leads to increased frequency and urgency of bowel movement. And it is pointworthy to note that fecal incontinence in this condition can occur even if the sphincter function are normal. If the rectal is not pliable, which is by the maintained by the three seminal curves which normally rectum has. So if there is decreased rectal capacity, it will lead to incontinence. And the condition which leads to decreased rectal compliance include the ulcerative proctitis, the radiation proctitis, and proctectomy surgery for low anterior resection in case of C rectum. The decreased rectal sensation can be seen in patients with diabetes mellitus, patient with Parkinson's disease or spinal cord injuries. And diabetes may also reduce the internal anal sphincter resting pressure. And diarrhea secondary to autonomic neuropathy may also contribute to fecal incontinence. The fecal retention or impaction is the common cause of incontinence in old age group, as they have usually have constipation and have hard impacted stools, which leads to incontinence. The hard impacted stool leads to constant inhibition of internal anal sphincter tone, and the sphincter cannot constrict completely, which leads to a leakage of solid or liquid stool from the side of impaction. Like in any other medical or surgical disease, the importance of history cannot be denied in incontinent patient. On the basis of history, a surgeon should be able to differentiate true incontinence from just increased frequency or urgency, which can be seen in any normal patient in case of severe diarrhea. History of low back pain, perineal pain, motor or sensory neuropathy, lower extremities, and urinary incontinence should be taken. Any history of prior anorectal surgery, history of pelvic irradiation for any malignancy in the perineum, history of diabetes, neurological disease should be taken. And in a female patient, obstetric history should be taken in great detail, like the number of vaginal delivery, a history of obstructed labor, history of episiotomy, etc. An attempt should be made to know about the history of prolapse by asking the patient that there is something coming out of the anal canal during defecation or on straining. Next comes the examination. On inspection, we try to look on the perineal skin for any scar mark or prior surgery, any skin tag because of external hemorrhoids, which may permit complete closure, any keyhole deformity because of prior surgeries or any prolapse. On digital rectal examination, we try to assess the tone of the internal anal sphincter, any pathology like any mass or fecal impacted stools. We try to assess the anorectal angle, which is found by the pivorectalis muscle, and by asking the patient to squeeze, we can assess the squeeze pressure, which denotes the indirect evidence of external anal sphincter function. And anocutaneous reflex should be elicited with it is a simple test. In it, a cotton wick is taken in the perineal region and the perineal skin is taped, and it leads to reflex contraction of the external anal sphincter. If it is absent, it means there is some neurological deficit. There are various scoring systems described in the literature to assess to grade the severity of incontinence, and the Wexner score is the one among the most commonly used. On the y-axis, it considers the type of incontinence, like it is incontinence to solid or liquid stool or to gas, or whether the patient has to wear frequently the pads, or there is any disturbance in the quality of life, or there is lifestyle alteration. On the x-axis, it is the frequency of incontinence, whether it occurs never, whether it occurs rarely, that is less than 1 month, it occurs sometime less than a week, it occurs usually means once a day, or always means more than 1 time a day. So on this score, we can grade the severity. A patient with perfect continence has a score of 0, and with complete incontinence, the patient has a score of 20. Another important tool is the bowel diary. In this, the patient notes the symptom date-wise, and he notes the aggravating and relieving factors such as the type of food, after which he noted the incontinence episode, the type of medication which is leading to incontinence. So after seeing the bowel diary of 5 to 7 days, we can make out the common causes, and it also encounters the patient has any urge to defecate, which help to differentiate urge incontinence to passive incontinence. Now coming to the investigation, the first line of investigation that should be done in a patient of incontinence is the endoscopy to see the any evidence of mucosal inflammation like in proctitis or any malignancy or neoplasm. For a patient of less than 40 years of age, flexible sigmoidoscopy should be done to exclude any mucosal inflammation or mass lesion. And a patient of more than 40 years with a high risk of colorectal malignancy, full colonoscopy should be done after adequate bowel preparation. And if we are not able to find any etiology for incontinence on endoscopy, then endorectal ultrasound or MR should be done. Endorectal ultrasound or MR determines the structural abnormality of the sphincter, the rectal wall, and the pivorectalis muscle. Endorectal ultrasound is better for the internal anal sphincter, and MRI is better to assess the external anal sphincter. Depending on the availability of the resources, we can order these investigations. And if we are not able to find the cause on endorectal ultrasound also or MR, then we order. Now, this is the image showing the normal anal sphincter. The inner hypoechoic part shows the internal anal sphincter, and the outer hyperechoic ring shows the external anal sphincter. And the other, on the left side, the image shows the disruption. It is a endorectal ultrasound of female patient after episiotomy, which shows complete disruption of the internal anal sphincter and partial tear of the external anal sphincter. So if on endorectal ultrasound and MR there is no abnormality and sphincter are looking normal, then we should go for next investigation, that is anorectal manometry, to assess the functional sphincter weakness. And on manometry, if there is decreased resting pressure, which suggests isolated internal anal sphincter dysfunction, and if there is decreased squeeze pressure, it suggests isolated external anal sphincter dysfunction. Manometry also helps to detect abnormal rectal sensation, which is an important predictor of response to biofeedback therapy. Initially, manometry was very cumbersome. It takes 30 to 1 hour, and it was done by water perfusion. Nowadays, very sophisticated manometry probes are available, and by pull-through technique, it is quite easy and can be done in 15 to 20 minutes. Next, the reserve investigation is the defecography, which can be done by either MR or barium. It should be performed in patients with refractory fecal incontinence, in whom we are not able to find the cause after detailed investigation, to detect the occult enterocele or rectocele or rectal prolapse, which may be the cause of incontinence. And on defecography, we try to evaluate the length of anal sphincter, the anorectal angle, and any pelvic descent. Now coming to the management part, the first line of management is the supportive care and medical therapy. The supportive care includes the avoidance of foods or activities that worsens the symptoms, such as the concentrated sugar like fructose and sucrose, and the caffeine aggravates incontinence, that should be avoided. Improve the perianal hygiene by using sanitary diapers or by continuously cleaning the perianal area with using cotton wicks. Maintain the food and symptom diary, and the pelvic floor muscle exercises should be taught to the patient to increase the pelvic floor muscle strength. In the medical therapy, the aim is to decrease the stool frequency and improve the consistency, as more than 80% of patients have incontinence to liquid stools. So our target is to increase the stool consistency. It can be achieved by a various of bulking agent like psyllium husk, the isabgol, and the antimotility drugs like loperamide and lomotil, and bile acid binders like cholestyramine. Tap water enemas can be used after defecation to clear the lower rectum, so to decrease the incontinence episode. And barrier creams like zinc oxide and cotton wicks can be used to improve the perianal hygiene. This is randomized control trials comparing the efficacy of loperamide with psyllium husk, and the author found that there was no significant difference between the loperamide and psyllium group. However, the constipation occurred in more patients in the range of 30% as compared to 10% with psyllium, and they concluded that psyllium is better than loperamide as a medical therapy. Now coming to the next line of management, there is biofeedback therapy. It is a very good alternative option. And it should be given to the patient if the manometry shows weak external anal sphincter or rectal hyposensitivity. In this therapy, the patient is trained to improve by using the own signals from their own body. By looking at the height of contractions which he or she is able to make, patient can be make better contraction in the next sitting. And it is been proved that feedback information can adjust thinking and behavior, which leads to voluntarily alter and improve the sphincter function. This is a randomized trial showing the efficacy of biofeedback over pelvic floor muscle exercises. It included 108 patients. 63 patients has undergone simple pelvic floor muscle exercises. 45 have undergone biofeedback therapy. And at 12 months, 76% patient treated with biofeedback have better results compared to 41 patients treated with pelvic floor muscle exercises. This is a recent systemic review published in 2022 on biofeedback therapy. It included 46 patients with 46 studies with more than 1,300 patients, and the author found the cure rate of 50% with the improvement rate of 72%. The limitation here was that the studies use different methods of biofeedback. Some have used the electromyography, some have used the transducer technique, so there was heterogeneity. And also the criteria for success in different studies was not uniform. Some have used the incontinence score as the outcome measure, and some have used the frequency of incontinence episode per week. And only 8 of 46 studies employed any form of control group. So these results should be taken with cautious. Another option which is available for patient with anal incontinence is the use of anal bulking agent. The most commonly studied and commonly used is the dextromer injection stabilized in hyaluronic acid. It is simply a dextran polymer, which is useful for patient with passive fecal incontinence. 4 1 ml injections are injected into submucosa above the dentate line. The dextran polymer causes fibrosis and thickening of the overlying tissue, which leads to increased resting pressure and thus improves the fecal incontinence. The other less commonly used anal bulking agent includes the autologous fat, carbon-coated beads, cross-linked collagen, the silicone biomaterial. The advantage of using these agents is that it is a simple and can be done in OPD sitting procedure without any hospitalization. This is a randomized study showing the efficacy of transanal injection of dextromer, which include 206 patients. In 136 patients, in the treatment arm, the hyaluronic injection was given, and in other 70 was the control group. And the primary endpoint was response to treatment based on the number of incontinence episode. And the author found that 50% or more reduction in the incontinence episode was seen in the injection arm compared to the control arm. Another attractive modality available in the literature is the gatekeeper device. In this, the thin solid cylinders of around 2 centimeter length of polyacrylonitriles are injected. These are hydrophilic material, and they get swelled when come in contact with the human tissue, and their volume increases tremendously. And by increase of volume, the resting anal pressure is increased, and it is postulated that it decreases the anal incontinence. This is a study showing the 5-year results of gatekeeper device. It included 40 patients, and the author found that the incontinence score decreased from a mean of 16 to 7, and the quality of life improved from 7 to 13 at 1 year of follow-up, and there was no peri or post-operative complication. However, the prosthesis migration was observed in 12% of patients, means 4 out of 40 patients have spontaneous expulsion of the device. And however, the author concluded that the gatekeeper implantation is a safe approach to treat patients with passive fecal incontinence. This is a systemic review on the anal bulking agents, which include 8 studies. And the author found that fecal incontinence, the severity improved in 5 of the 7 studies by using the incontinence scoring system, and the quality of life improved in all. However, the procedure-related and device-related adverse events occurred in 10 and 30% of patients. So the results should be taken with a pinch of salt, as the complication is very high. However, the author concluded that the implantable anal bulking agent is an effective and safe minimal invasive treatment option for fecal incontinence. Next in the line is the anal sphincteroplasty. Before planning a patient for sphincteroplasty, pudendal nerve terminal latency should be checked, and if there is suboptimal findings, then sphincteroplasty should not be attempted. And the on endorectal ultrasound there is evidence of anatomic sphincter injury, then the results are better with sphincteroplasty, and the short-term improvement in fecal incontinence is very good to the range of 85%. However, the failure rate at 5 years is high, reaching up to 50%. This is an image showing the anterior sphincteroplasty. In it, cruciate circumanal incision is given anteriorly. The skin and septal tissue is separated. The levator ani muscles are approximated and the internal anal, external anal sphincter are buttressed in a by using horizontal metra sutures to increase the internal anal sphincter resting pressure, and the wound is closed using a drain. Another attractive minimal invasive option available in the literature and also available in India is the sacral nerve stimulation. And it has been proven that electrical stimulation of sacral nerve improves the fecal incontinence by central and peripheral mechanism, and is most effective for patients with neurological disorders and those with fecal incontinence after low anterior resection, or LAR syndrome. In it, the first temporary electrode is inserted into the third sacral foramina to provide, and a low-grade electrical stimulation is done for 2 weeks. And in patient in whom there is good results, we transfer we do the placement of permanent electrodes. And it has been objectively proven with manometry that it improves the resting and squeeze pressure and rectal sensation. The complication include dislocation of the device of the electrode or perianal infection, and significant number of patients may require revision for different reasons like empty of battery, electrode dislocation, or infection. So this is a recent study showing the long-term results of sacral nerve stimulation for fecal incontinence, which included 235 patients with follow-up 5 years. And the author found a median incontinence score decreased from 19 to 7 at 6 months of follow-up. And this was maintained at 10 years also. The incontinence score was 10 out of 24. The author concluded that sacral nerve stimulation is an effective treatment in long term without any long-term morbidity. This is another study showing the long-term results, 10-year results. And the author also, similar to the previous author, found that sacral nerve stimulation is better and it decreases the incontinence score significantly compared to the baseline. Next, less invasive or less expensive treatment available is the tibial nerve stimulation. It is associated with short-term improvement of fecal incontinence. And tibial nerve stimulation has been suggested as a less invasive and less expensive alternative to sacral nerve stimulation. This is a systemic review and meta-analysis showing the efficacy of posterior tibial nerve stimulation. It included 5 IRCTs with 250 patients having the treatment was in the treatment group, the tibial nerve stimulation group, and 240 patients in the control group. And author found that the number of fecal incontinence episode decreased significantly in the treatment group, and the fecal incontinence score, the resting score, the squeeze pressure were comparable in the 2 arms. And the author concluded that the tibial nerve stimulation alone should not be used as a standalone therapy, but it can be used in conjunction with other medical therapies for treating fecal incontinence. This is a systemic review and meta-analysis comparing the efficacy of sacral nerve stimulation with tibial nerve stimulation. Included 4 RCTs, 4 studies. 1 was RCT and 3 were prospective studies. 100 patients has undergone sacral nerve stimulation and around 200 have undergone tibial nerve stimulation. And all studies noted improvement in the symptoms after treatment. However, the Wexner score improved significantly, or the incontinence score, after the sacral nerve stimulation, and the difference was statistically significant. Author also found that the fecal incontinence related quality of life and the number of incontinence episode were significantly lower in the sacral nerve stimulation. And on the basis of our result, they conclude that sacral nerve stimulation is better than posterior tibial nerve stimulation. Now there is a subset of patients which do not respond to any form of treatment and have refractory symptoms. So we first try to look for the cause of the refractory symptoms, which can be looked by the difficography, which is the commonly the cause is the occult rectal prolapse or rectal interception, which permits tight closure of the anal canal leading to seepage of mucus or liquid stool. And repair of pelvic organ prolapse has been shown to improve or cure the symptoms of fecal incontinence. That modalities available for patients with refractory symptoms include the artificial anal sphincter or graciloplasty. However, currently the data is insufficient to compare these treatment options as they carry high morbidity. This is a Acticon neo-sphincter or artificial bowel sphincter made up of silicone biomaterial. In it, occlusive cuff is implanted around the anal canal, with the pressure regulating balloon is implanted in the perivesical space, and patient has the control of it to increase the by using a pump mechanism to increase the sphincter pressure and to maintain incontinence after the defecation episode. However, the complication rate was higher. The newer FDA approved is the magnetic anal sphincter, that is the Phoenix device, which is much similar to the Lynx device used for GRD symptoms. And it contains a series of titanium beads with magnetic cores that form a ring which is implanted around the anal canal outside the internal and external anal sphincter. The magnetic attraction of the beads helps to augment the sphincter function and reduce the fecal incontinence episodes. And it is proven that it increases the resting pressure and squeeze pressure. This is a study showing the efficacy of magnetic anal sphincter augmentation. But the sample size was very small. It contains only 18 patients, and the mean incontinence score decreased from 18 to 7. And the author proved objectively by manometry that the mean anal sphincter resting pressure and squeeze pressure improved significantly after implantation of this magnetic device. And there was 76% patients had reduction in incontinence episode, and more than 50% has maintained this improvement even at 12 months of follow-up. And the complication rate includes the postoperative pain to the tone of 30% and erythema and swelling in the tone of 23%. And in this series, no patient required device explantation. This is a study published in 2019 in Annals of Surgery showing the efficacy of magnetic anal sphincter, which included 45 patients. The median follow-up was good of around 3 years. And the author found that the major leak rate, the incontinence case, the quality of life improved significantly compared to baseline. And there was no significant difference to passage of flatus or minor leaks. And in this study, the 2 patients had needed explantation. One has spontaneous explantation, other has severe perianal sepsis, for which the device was removed. Now, coming to this study from Italy, published in 2022, which shows that the clinical experience with magnetic anal sphincter ranged from satisfactory success to partial failure. And there are only non-randomized comparisons comparing the magnetic anal sphincter with sacral nerve stimulation, which shows equal effectiveness. However, the adverse events were more frequent with magnetic anal sphincter compared to sacral nerve stimulation. So, from the Italian market, the magnetic anal sphincter has been withdrawn. So, we should take into account before considering this to our patients. Now, research is ongoing to develop a 2-plaque anti-continence system instead of the ring mechanism, as it leads to dynamic closure of the anus, and the advantage is that it does not have mechanical sliding parts, which is postulated to erode the rectal musculature in long term, and the in between parts of the beads can be blocked by the fibrin, which leads to halt in the mechanism of magnetic attraction, which is not seen in the 2-plate incontinence device. Now, coming to the graciloplasty, it can be either dynamic or adynamic. In dynamic group, just a neurostimulator or battery is implanted. It includes the complete mobilization of gracilis muscle along its whole length, along the proximal neurovascular bundle, and it is transposed through a subcutaneous tunnel around the anal canal and fixed to the opposite ischial spine. And in dynamic group, the 2 electrodes are inserted into the muscle near the neurovascular bundle to continuously stimulate and increase the resting anal pressure. This is a systemic review and meta-analysis showing the efficacy of graciloplasty and comparing the both dynamic and adynamic. It included 14 studies. The median follow-up was good ranging from 1 to 13 years. And the most common etiology of incontinence was obstetric trauma, followed by anorectal trauma. Both were iatrogenic. The mean rate of continence after dynamic and adynamic graciloplasty was comparable, ranging up to 70%. However, the complication rate was significantly higher in the dynamic group. So the author concluded that adynamic graciloplasty can be considered in center of expertise. Now, there is a subset of patient who is not responding to anything, and each and every surgeon in this house has this option in their hand, that is fecal diversion or colostomy. Diversion is act as a definitive therapy for patients with intractable symptoms, and it is very well said that pouchable stoma is generally preferable over an unpouchable stoma between the buttocks. So colostomy is a viable option, loop sigmoid colostomy in patients who have intractable symptoms. And it has been scientifically proven that colostomy improves the quality of life significantly before the procedure. And I am quoting this last study, which is a systemic review and network meta-analysis. The network meta-analysis means comparing of different treatment options, more than 3 treatment modalities, which included 47 RCTs, comparing 37 treatments with more than 3,500 patients. And the results were interesting. The author found that no single treatment ranked best or worst, and there was no difference in the resting pressure, squeeze pressure, and quality of life in different treatment modalities. And there was no difference in incontinence episode, comparing the most commonly used sacral nerve stimulation, tibial nerve stimulation, artificial bowel sphincter, or injectable anal bulking agent used. And the author concluded that the large multi-center RCTs are still required, with long-term follow-up are needed. So incontinence is a very gray area which requires further research, more and from India also. So finally, to conclude, ladies and gentlemen, fecal incontinence is a common disorder with a variety of underlying causes. Its prevalence increases with age, and it is underreported because of social stigma. It is not a life-threatening condition, but is a life-impairing. And careful history and examination should be done to elicit the diagnosis, potential etiology, and to select the appropriate therapy. And the first line of treatment includes the supportive care and medical management. And the second line of treatment includes the biofeedback, the sacral nerve stimulation, the injectable biomaterials, the prolapse repair, and sphincteroplasty. And for refractory patients with intractable symptoms, magnetic anal sphincter, if available, can be done, or the creation of stoma should be done to improve their quality of life. Thanks for patient listening, and thanks for invitation. Please move.
Thank you, sir, for covering such a complex topic in an excellent and elaborative manner. Any question from the audience? So still well supported by the systemic and meta-analysis research papers, and still it is a growing field. Thank you. Thanks again for your nice.
Thank you, sir.
Thank you so much, sir. I would like to invite Dr. Dr. N.K. Singh, sir, to kindly felicitate Dr. Devendra Singh, sir. Thank you, sir. I would like to invite Dr. Shashank Mishra, sir, to kindly felicitate Dr. N.K. Singh, sir.
Now we will take a short lunch break of 15 minutes. We would urge you to come as soon as possible. I would like to call upon stage Taposundar Majumdar, clinical training specialist with Varions since last 8.5 years. Prior to that, he was a senior radiation therapist for 7 years in radiotherapy clinic in various departments.
You can please proceed outside for lunch, but please try to make it fast because we're running a little late as it is.
He is a clinical training specialist with variant since 8.5 years. Prior to that, he worked as a senior resident radiation therapist for 7 years in radiotherapy clinic of various hospitals.
Good afternoon, all the delegates, and thanks to the organizers for giving us an opportunity to showcase our products. I can see a good number of students or maybe PG residents. I am from a different world. It's a surgery conference is going on, and really things we talk about, but it's very nice to hear and see how you do things in clinics. And usually those patients comes after the surgery to the radiotherapy and vice versa sometimes. So without not wasting further time, I am starting my talk. So basically, I am going to talk about our latest portfolio, the machines that we have to treat cancer patients with the help of radiation. Treatment delivery system portfolio I will include here, and sorry. So here, what are the challenges of radiotherapy? What is our new product, that is TrueBeam 3.0, and with the integrated and automated imaging, and then new two products, Halcyon and Ethos, and the summary. So this is our portfolio. We have Vital Beam, TrueBeam. Already TrueBeam is installed in your hospital with full capability, and also it's clinical. They are treating patients on couch, a good number of patients. Halcyon Edge, it's a dedicated radiosurgery system. So here there is a niche between the surgery department, and also we perform surgery with the help of high dose radiation on the patients, and for the adaptive radiotherapy to accommodate the daily changes in the patient tumor shrinkage and patient anatomy is called the Edge machine. So what are the challenges we face in the radiotherapy? There are two types of challenges. One is technical challenge and another is clinical challenges. What are the technical challenges? They are the geometrical constraints, treatment acquisition time, because we cannot spare a long time that the patient is on couch, and some artifact. There are the technical challenges, because patient comes gas in the bowel, there are some metal implants, so image artifacts is there in the images. And the clinical challenges, we cannot tell the patient to breathe hold, like in the radiology department. If the person is going under a CT scan or an X-ray, it takes a really less time, just for few seconds. So we have the liberty to ask the patient to do a breathe hold, and then we finish the scan. But here patient keeps on breathing because it's a time consuming process. So for such a long time, patient cannot hold the breath. So we have to take care of that breathing, some involuntary movement in the body, and of course some the voluntary movement like swallowing and other thing. So we have some patient motion management solution. We try to restrict those motion with the help of immobilization devices. We can mimic the internal movement in the patient body with the help of real-time position management, and of course through the image guidance. Like whatever the imaging we are taking, we can see what's happening inside and target the beam. So TrueBeam 3 is the latest product. The same version or the same model machine is installed here in this hospital. It was a long journey. In the market in 2010, the first version came, and now it is the latest one, 3.0, launched last year and got approval from Atomic Energy Regulatory Board, and it is fully functional. Now we have a good number of installation worldwide. Even in India, there are more than 100, I think currently it is more than 120 systems clinical already. So mostly I will talk about some excellent imaging. We can do 2D imaging in this machine, 2D, 3D imaging, like we can take image at any angle. Then 3D imaging, which is called a cone beam CT. Then we can perform gating. Gating is nothing but the synchronizing our radiation beam with the patient respiration. And 4D. 4D is a scan with respect to time. We all know 3D. The fourth dimension is the time here. So we can perform a 4D scan with our machine as well. So these are the type of 2D image, 3D image, and also 4D image. If you see the pink color thing, these are the new additions. These are the type of new scans with better image quality, with lesser artifact and much more control. And there are, what is triggered imaging? It is the imaging during the intrafraction. That means when the treatment is going on, we can take some image. So This is the intrafraction. We can monitor the motion that is taken place in the patient body. Triggered on time, it can be time based, like such, say for example, every 10-second interval of time we can take an image. It could be based on dose. It could be based on gantry rotation angle. So this is an example. If you see, there are 3 markers planted in the patient body. Of course, that is done in the surgical clinic. And then treatment beam is on. Patient is allowed to do a free breath, and we are taking images to see whether the marker are in place or not. Sometimes the tumor we cannot see, but the markers are placed in the tumor body if the patient has undergone surgery or not, or sometimes in the tumor itself in some cases. There are different CBCTs. Now, this is the latest CBCT with a very good image quality. We all know the diagnostic CT machines, they are far advanced, but the same quality is now here with this new iCBCT. This is an example of 4D CBCTs, a CBCT scan with time. There is a new technique called SGRT, surface guided radiotherapy. We have a product called Identify. So here an image is taken. There are 3 cameras additionally installed in the treatment room, and we are getting a shadow of the patient body and matching with that reference. And in this, we are targeting the surface. So if there is any deviation from the surface matching, the treatment will be automatically stopped. Here we are not able to see the internal anatomy, but external anatomy, it's totally visible. So there are a lot of advantages in terms of different group of the who deliver the treatment, like the therapist, physicist, patients, and clinician. I'm not going to explain those things. One very important feature of TrueBeam 3.0, it is based on Windows 10 system. So it is very much robust system. Like you cannot insert any USB or other thing, considering the latest cyber security norms and provisions and other thing. This is an example of intrafraction when the treatment beam is delivered. Again, it's a case of prostate where we have placed 3 markers from surgery clinic, and we can see the position of this marker, and we can put a search region like the green circles along those markers to see whether they are in position or not as per the plan. If there is any deviation, automatically treatment beam will be held. So now we can do imaging with more frequency. As I told earlier, it was 3 seconds. Now it is with 0.5 second, 5 mu dose, and gantry rotation with 3 degree of angle. This is the example of iCBCT, much more better coverage with imaging control. So this is all about TrueBeam 3.0. Now I quickly jump into the Halcyon. This is another machine with a ring gantry look, but it is the same DNA which is followed from TrueBeam and placed with Halcyon. What are the facilities of installing a Halcyon? We can do a volumetric imaging with a single breath hold. That can be done. IMRT, all treatments are intensity modulated treatment as rapid arc. The rapid arc speed is very higher than the normal one. We can treat a patient in 10 steps or even less, and the machine installation is very quick, very fast. We have a lot of cobalt bunkers till date, which is obsolete treatment in first world, we can say, or the modern countries. So we can replace this cobalt bunker into Halcyon because it takes less footprint. And finally, it achieves the highest patient comfort as well. So it is built on few pivots like high quality therapy, patient safety, operational excellence, patient experience, staff satisfaction, and capital efficiency. As I told, it takes a very small footprint. If you compare with TrueBeam, with a smaller bunker size or existing cobalt bunker size, we can install a Halcyon machine. So these are the 3 pillars of Halcyon functioning: high quality of care, operational excellence, and human-centered design. I'm not going to in details for all the features, but it has a large bore, few salient points, like if the patient is claustrophobic, the large bore give a lot of space, so patient comfort is higher. The treatment delivery is very fast than the normal linac. The couch moves also very fast. Other thing, there is low leakage radiation for the radiation staff. Then the CBCT can be acquired much more faster than the existing true beam. Image matching can be done. Like it is aimed for the places where we have lesser staff strength or staff are not that much educated with lesser experience. So a lot of process has been kept automatic. So it helps in decision making and also the correct decision making. And for this machine, you cannot go without treatment, without imaging to deliver the beam. So 100% quality care is maintained. So this is the total thing that is developed with Halcyon: service, product, infrastructure, management. So in terms of capital gains, as I told, it takes less footprint size. So your electrical consumption is also less. You can treat more patient in less number of time. So in this way, there is a capital satisfaction for the installer or the institution as well. The shipment is also minimal, just 2 crate shipment, easy transportation. It can be taken through any maze wall. If you have come to the radiotherapy department, you will see a kind of zigzag architecture to stop the radiation. The commissioning time is very less. So it is once the system arrives in your department, it takes hardly 2 weeks from installation to be clinical. So I just quickly skip few slides. Yeah, in terms of patient satisfaction, you can think on this. It is the quite very less sound. So patient almost sleep inside the bore, low couch height. So patient can get up and get down from the couch easily. Treatment time is spent very less number of time on the couch. Lighting is very nice. It's a large bore, so for the very nice for claustrophobic patient. And the smooth motion is very smooth of the couch. Like there is no jerky movement. In terms of patient safety, like there is patient verification, then only you take the patient. So there is no chance of mistreatment or the delivery of the treatment to another patient. There is collision detection technology, so there is no chance of collision with the bore and patient or any other object in the room. There is an integrated camera. We called it live view camera. You can see the patient movement and monitor the patient, and the gantry is enclosed. In terms of staff experience, it's a consistent and easy workflow, very user-friendly, very less number of buttons, ergonomic placement of the touchscreen. It's a touchscreen-based, quietest machine and intuitive workflow. So now, based on this Halcyon principle, the new system is Ethos, where you can do the adaptation. Why adaptation is needed? Because there will be changes in the tumor volume. Tumor can shrink, some swelling can occur. So when we start the treatment from the day 1 with the planning scan, how the external contour, body contour was there is highly changes after 15 fraction or maybe after half of the treatment. But doing adaptation, of course, the machine you have, you can do adaptation, but that is a time consuming and labor consuming process for the staff as well. So you will do adaptive treatment for adaptive plan, replan, re-CT, or you will treat a new patient. But here you can perform an adaptive treatment on couch. That is the facility of Ethos. In Ethos console, you have the access for all the diagnostic modality of images, which is not usually available for the existing Linux. Here you can see the daily changes with iCBCT, and instantly you can decide whether you will go with the plan, like that is done by the AI instantly on the machine. A QA is performed in 2 minutes and it gives the result. Now it is your call whether you will go with the adaptive plan or you continue with the existing plan. You are doing adaptive doesn't mean you are forced to do the adaptive. Okay, so it is your choice whatever you choose. So there are 2 or 3 plans are generated for particular day based on that CBCT. Yeah, so this is Ethos basically. If you have any other question in depth how the AI works, I am available to answer your question. And the delivery platform is still remain Halcyon. So we are applying AI doesn't mean the workflow is suddenly changed or something. No, it's not like that. So the workflow has been changed. The delivery part of the machine is like Halcyon. So the same way you deliver treatment in Halcyon, you do a image guidance. Here also you do the same. So maybe you can ask some extra minutes which I have spent to do the replanning. So you can redo a CBCT again to see if there is any changes of the patient or any patient movement during that AI calculation or not. And you can apply those shifts and then you treat with a correct plan. So this is how Ethos looks like. It's very similar with Halcyon, the lighting and some changes in the other outside body. So if you want more information, you can visit our site, varian.com/ethos. So this is how Varian is there to advance your capabilities in the fight against cancer. Thank you. Yes, sir, if any question. Yeah. No, you can do. There are some now latest, even you can do TBI or TMI with Ethos, but still for radiosurgery, we prefer LINAC. But for an SRS treatment, adaptation is not required because your treatment is over in 3 or maximum 5 fraction. So Ethos is mainly focusing to the adaptation. Like there is a long course of treatment and you are expecting a lot of changes in the daily treatment images. So for that Ethos is, so there is no comparison between. This is for one requirement, this is for another requirement.
Requiring SRS machine also. That is the message. If we have Ethos, even though we require a separate unit for the stereotactic surgery.
Yes, so it depends. Actually, though I am not from sales, but still, like, it should be suggested such a way that where you are doing your clinical practice, what kind of cancer prevalence is higher in that. So if you are treating more head and neck cancer or those kind of thing where radiosurgery is not required, then Ethos is, because again, you are not bound to do adaptation for every. So maybe still we have 4 or 5 installation with Ethos. Say for example, they are treating 100 patient. Out of that 20, they are going for AI based. So rest 80 are normal IMRT that they are doing.
Okay. Thank you. Thank you.
Thanks again.
Thank you, sir. It gives me immense pleasure to invite Dr. B.K. Jain, sir, for the next session. Sir is the former director, professor, and head of the Department of Surgery and medical superintendent at Guru Tegh Bahadur Hospital and UCMS, Delhi. He is a former member of the advisory board of the esteemed Annals of NAMS. Sir has more than 130 publications in national and international journals, which have been cited more than 1,000 times. Sir will educate us on the topic management of complex anal fistula. Can we please have you on stage, sir?
Thanks. To chair the session, I would like to invite Dr. Shanti Swarup sir, who is a renowned minimal invasive surgeon in Meerut city. Kindly join us on stage to chair the session, sir. Thank you, sir.
बेटा वो पॉइंटेड है कोई या इसमें चलेगा
इसमें चल जाएगा
बस ठीक है May I start, sir? नहीं आ रहा
पॉइंट सर अब इससे पॉइंट हो जाएगा जैसे भी करें.
Thank you. Good afternoon, everybody. I have changed slightly the scope of my presentation. Instead of talking of complex anal fistula only, I will cover simple anal fistula also. So that will interest to everybody, whether he or she is interested in, especially in anal fistula or not. I will start my presentation by showing two videos. नहीं हाँ यहाँ से होगा इसको फुल स्क्रीन कर दो ना
फुल स्क्रीन सर वहाँ पे तो फुल स्क्रीन मिलेगी आपको वीडियो दिखाना है सर
आ गया You see, this video is about fistulotomy in a simple anal fistula. So I want to show the technique of fistulotomy and the problem which one can face during a fistulotomy. You see, this is a simple anal fistula, but it is associated with the abscess. So there is a lot of scarring around it. And I have put a moist gauze piece in anal canal and injecting methylene D blue to see whether the track is patent or not. And it shows that the track is patent and we can see the inner opening. Now I am probing this with a copper probe, first type probe, but it didn't go through. So I was probing it with a malleable silver probe. It is not going on either side. This I am infiltrating adrenaline solution 1 in 300,000. Now I am opening this fistula on a probe which is partially inserted inside. Now opening has opened and it has gone in a wide cavity, so I can put a mosquito artiforceps there. Now the track is being curated. When we curate the track, if the dye is left somewhere, we have to pay more attention towards that. This I have inserted a probe from internal opening and again cleaning the track. This I am excising the scarred part surrounding the internal opening so that improve the healing of the fistula. Now, at one place, the granulation tissue is still present after curettage, so there may be a secondary track, so I am taking care of that. Now, all of the fistula track has been cleaned and layered open. Now, I will do a marsupialization to reduce the size of the wound. So, from the skin edge to the edge of the track, we put interrupted sutures of visceral plane. So this is the end result of a fistula treatment. You can see that everything has been cleaned properly. This is another case where there are two openings in this fistula. I am putting a dye through this one opening. You can see dye has come out. I am putting another dye through another opening. This I am putting silver probe which are malleable, bendable. One fistula. This is through the second fistula. Now I will lay open these tracks. These are intersphincteric tracks. Now what is very important is to curate the floor of the fistula very carefully. Remove all the overhanging tissue. And again, if there is some spot where granulation tissue is persisting, we have to take care of that part so that no secondary track is left unattended. This is a place where granulation tissue is present, blue colored, stained by the dye. So I am cleaning it. This is overhanging edges, so I will remove this mucosa. Remove the granulation tissue, do the hemostasis, make a wound a flat, clean wound. Now this is satisfactory. So I will put a small gauze there and the procedure is over. Now I'll come to my main presentation. Now we start with, already discussion has been done around fistula. The fistula is a abnormal tract which connects the internal opening in anorectum to a opening in perineum. And it starts as a abscess of the anal gland. Now we will see how we differentiate, or what is the importance of differentiating simple and complex anal fistula. The simple anal fistula is simple to treat. It can be curative by one procedure. There is short duration of treatment, least chances of recurrence, and almost no post-operative incontinence. Whereas a significant minority of anal fistula are complex and require specialist reference. Now this shows the difference between simple and complex anal fistula. On this side, we have simple anal fistula. These are low anal fistulas. This is low intersphincteric fistula, and this is low transsphincteric fistulas. Those fistulas which cover less than 1/3 of external sphincter are simple anal fistula. This side, all type of complex anal fistula are there. This is high transsphincteric anal fistula, sorry. This is a suprasphincteric fistula. Here is a supralevator abscess. This is a horseshoe tract. This is a high internal opening. This is a branching fistula, and this is a extralevator fistula. So all these fistulas are complex anal fistula. Now this diagram shows the location of deep post-anal space abscess here, which is present at the level of anorectal abscess, anorectal junction, and these are supralevator fistula. And this is showing two types of supralevator fistula, one which is extension of intra-sphincteric abscess, and this is made from extension of a istiorectal abscess. Now, what are the simple anal fistula? They are low intersphincteric and low transsphincteric fistula. They are characterized by a superficially lying tract which can be palpated from external opening to the anus. It involves lower anal sphincter only, and it has no complex branching or deep abscess. In contrast, complex anal fistula are high transsphincteric fistula with involvement of more than 30% of external sphincter, suprasphincteric fistula, horseshoe fistula, multiple tracts, deep-seated abscess, fistula with inflammatory bowel disease, malignancy, post-radiation, fistula in patients who have pre-existing incontinence, chronic diarrhea, anterior fistula in women, and recurrent fistula. How to identify simple anal fistula clinically? It is very important for all of us. If we can identify simple anal fistula clinically, we can decide whether we want to operate this or not, and there is no need of doing specialized investigation like MRI in simple anal fistula. Now, careful examination with the educated finger provides sufficient information. No probing of fistula is done in OPD setting. First thing is very important is to palpate perineum around the fistula. So with a finger as shown in the diagram, this is a finger palpation, and it is bidigital palpation of the area. We palpate to see whether the tract is palpable from external opening to the internal opening. That suggests that the fistula is superficial. The other important part of examination is that we do a distal lateral examination and we look for a palpable ridge at the level of anorectal junction which suggests horseshoe fistula. The second thing which we look for is bulge or swelling in the lower rectum on lateral side which represent supraelevator abscess, fistula or tract, and we look for a high internal opening. If any of these things are present, then your fistula is a complex anal fistula. Clinical criteria for single anal fistula is that it has a single external opening, a single low internal opening below or at dentate line. Fistula tract is palpable under skin, and there is no high abnormality on distal rectal examination, though there is no scarring at anorectal junction, no swelling above the anorectal junction. Physical signs of complex anal fistula: there are multiple bilateral distant obscure external opening. External opening at equator, I means that external opening, if they are at 3 and 9 o'clock, they're more likely the fistula is complex. The fistula tract is not palpable, high or obscure internal opening, and on distal rectal examination, scarring or palpable shelf at anorectal junction and induration and swelling in relation to upper anal canal or rectum. Now, these are some pictures of complex anal fistula. These are showing multiple external opening which are away from the anus. These are recurrent anal fistula. Multiple operations have been done in complex anal fistula. This is a result of treatment by a local doctor, what you say, a Bengali doctor. So he has converted a simple anal fistula in a complex anal fistula. This is a complex and anterior anal fistula going up to the rectum. Going up to the scrotum. This is a fistula. You can see here multiple opening extending up to the thigh and here gluteal region. And this patient has to go colostomy elsewhere. Still his condition was not cured. This is an interesting patient where patient has discharge of pus from the anus, but there is no external opening. When we do a proctoscopy, we see that there is an internal opening only at dental line 6 o'clock position. So this is a intersphincteric abscess which has opened only inside. Now, based on the clinical outcome, we can decide management. If there is a simple anal fistula, we operate. If their findings are equivocal or suggestive of complex anal fistula, we investigate these patients. Now, what are the investigation? The conventional fistulogram has no role in current times because it does not show soft tissues of pelvic region. So you cannot relate the fistula tract with the sphincter muscles. Ultrasound is a good test, but again, it is a operator dependent whether you have ultrasonologist who is interested in anal fistula or not. The second thing is the lesions which are away from the lumen of the anal canal cannot be very well seen by ultrasonography. So MRI remains the gold standard for investigating complex anal fistula. To get a good result from MRI, what is very important that you should send a requisition giving sufficient information to the radiologist. There should be a two-way communication between the surgeon and the radiologist so that if you have doubt, you can go and see films with him. And radiologist should send film which can be seen by surgeon. We see films that in one film, they will make 56 images which cannot be seen. So best is that you talk to your radiologist and he send maybe 4:5 format to you of the films. Now I send a requisition like this with the diagram, small description to my radiologist and I get good results. Now what we look in MRI is external and location of external and internal opening, fistula tract in 3 dimensions, associated abscess and collection, relation with sphincter, levator ani, and pelvic bones. MRI has advantage that it has no radiation hazard. So this, I am showing 2-3 radiation film, MRI films. These are all axial section. Here you see a small abscess and the track is going to the anal canal, and this is all abscess occupying the ischiorectal fossa. You can see gas in that, and this is a supralevator extension of the same thing. Now this is in coronal section. You see this is a large huge abscess there, and it is a supralevator portion, and this is in sagittal film. It is another fistula, which is a complex anal fistula. This is a transsphincteric part of the abscess, and this is a high intersphincteric part of the abscess. Fistula, high interesting part of the fistula. Now, another important part of the investigation is that you should look for tuberculosis in complex anal fistula. About 10 to 15% of complex anal fistula have tubercular origin. The specimen may be pus or fistula tract tissue obtained during surgery. And what tests are required? Smear for AFB staining, PCR for Mycobacterium tuberculosis, AFB culture and susceptibility tests. Even on histopathological examination, we may request pathologists to look for AFB and caseation granulomas. Now, this is the MRI of a tubercular perineal fistula. Here you can see that the track is in close vicinity of ischial tuberosity. Whenever the track or abscess is close to the bone, we must suspect this may be of tubercular origin. And because this patient ischial tuberosity showed erosion, you can see that the muscle which are inserted on ischial tuberosity or arise from ischial tuberosity, along their sheath, the infection has tracked to the thigh. Now, other investigation are required is colonoscopy or biopsy. If we think that our case is not of a cryptogenic origin, it is tubercular malignancy or Crohn's disease, we should ask for colonoscopy and biopsy. Now we talk about management. Anal fistulas are often managed inappropriately for several reasons. Privacy issue, patient does not want to go and show anybody, so it becomes late. Coax interventions, even now the patient prefer to go to the doctor and get interventions done. Disease is not assessed adequately before treatment by the treating person, and there is a general lack of clarity about the concepts. Now, this is a very important slide. What is the aim of surgery in anal fistula? And as we say that learning continues, so this is from Short Practice of Surgery, Love and Bailey, 28th edition. And it says that the aim of surgery in anal fistula is to keep patient continent and comfortable, and whenever possible to eradicate the fistula. So this is very important aim, that we must not chase to eradicate fistulas in every case and compromise with continence or comfort of the patient. Patients with minimum symptoms can be managed expectantly. Now we'll talk about operative management of simple anal fistula. The fistulotomy is the operation of choice, and we must make a clear difference between fistulotomy and fistulectomy. In fistulectomy, more tissue is dissected. There is a larger wound, so that is not indicated when a fistulotomy can be done. Marsupialization reduces size of surgical wound and hastens healing. Sometimes we may combine fistulectomy and fistulotomy together. I will show you with pictures. Now this is anus, this is external opening, this is simple straight fistula track. We pass a probe, lay open the track, curate the track, and this is subcutaneous tissue, this is skin, and then we suture these together by interrupted suture to reduce the size of the wound. The same thing has been seen in a vertical section. This is fistula track. We give an incision here, lay it open, curate the track, and then we bring this edge and this edge together by interrupted sutures so to reduce the size of the wound. This is called marsupialization. Now this is comparison of fistulotomy and fistulectomy. In fistulotomy, we lay open the track, we marsupialize the track. The wound is small. In fistulectomy, what we do, we excise whole of the track, dissect and remove whole of the track. The resulting track is, wound is large. Maybe there is more sphincter damage if we do a fistulectomy. Now this is showing how or when we have to combine fistulotomy and fistulectomy. Sometimes we find that the external opening of fistula is obliterated, closed. You cannot pass a probe through the fistula. What we have to do, we have to give a elliptical incision around the external opening, place of external opening or scarring, and then dissect this fistula for some distance. When we find the track, cord-like track, we divide it, and we see a patent opening, we put a probe inside and do a fistulotomy. So here the distal fistulectomy has been done and proximal fistulotomy has been done. So that is a way to combine fistulectomy and fistulotomy. The reverse can maybe also true that the distal part is patent, but the proximal part is obliterated. So what we do, we lay open the distal track and then we excise a postage stamp, small postage stamp size of tissue at the size of internal opening, which includes mucosa and internal sphincter, so that the operation can be completed. Now, here is some comparison of various methods which are available for treatment of simple anal fistula. We have to see both things. What is the fistulotomy treatment healing rate, what is the recurrence rate, and what is the incontinence rate. We will see that the result for fistulotomy is best. This incontinent, we have to see what is the grading of incontinence, whether it is for flatus, for liquid stool, for other things. And if the cases are properly chosen, still the best results are with fistulotomy. The advantage of fistulotomy are a single operation gives highest chance of cure, smaller wound, less damage to sphincter as compared to fistulectomy. Here is a misprint, fistulectomy. Surgery can be performed under local anesthesia on day care basis. No special equipment or material is required. The technique is simple. Now we come to operative management of complex anal fistula. Now, various operative procedures have been used for complex anal fistula. Ligation of intersphinctic fistula tract, transanal opening of intersphinctic space, TOPIS, total fistulectomy and primary sphincteroplasty, partial fistulotomy and ceton placement, and combining of procedures like waft, mucosal advancement, FACS, and fistula laser closure. Now, this is a patient which I showed you second MRI. This is a external opening and there is a low transsphincteric anal fistula, which has been laid open like this, but still we see there is an internal opening which is extending as an internal high intersphincteric fistula. So we pass a probe here and this probe is coming up high at anorectal junction. Now this probe has been bent like this because a malleable probe, and this is the space where a intersphincteric tract is there. This tract is gradually divided and the intersphincteric tract is opened in the anal canal. So this is a type of TROPIS operation. This is curative. And in the patient which I have divided the internal sphincter, I have not found any clinically relevant incontinence. Now, this is another patient in which we did TROPIS. This is a recurrent fistula who came with painful swelling near the scar. The MRI shows a bilateral tract, high tracts, and combining or joining through a horseshoe tract at the level of anorectal junction. This is same picture at the anorectal junction. This is an intersphincteric horseshoe shape. This is the picture taken at the second operation. The first operation, there was a large istiorectal abscess in this place, which was drained on the previous side, and both tracks were drained. This is the slide showing drainage of this space, this horseshoe space high in the anal canal. So until unless you drain this infection, these wounds are unlikely to heal. So this is also tropism. Now this has got a patient who's got multiple fistula, 1, 2, 3, and 2 of them were high fistulas for which I have done a lift operation, one here, and a superficial fistula, I have done a fistulotomy. Now this is a complex anterior anal fistula. I have shown a photograph of this patient. So what I found that distally the tack was superficial, so we have done a fistulotomy there. But this proximal part was going slightly deep. It was a borderline high fistula. So I have done a lift in this patient here. So this track has been defected, tied, and then this is a combination of those two procedures. This is fistulotomy and this is lift. Now, we have published our work on triple procedure for anal fistula, complex anal fistula. What we do we do a partial fistulotomy up to the external sphincter. We drain abscesses in high places like a supralevator abscess. We do a seton places, do appropriate antibiotics, and we allow the wound to heal under supervision. I will show diagram of this procedure. This is a fistula, which is a suprasphincteric fistula with a supralevator abscess. What we do, we excise this tract, do a fistulectomy up to the levator muscle, and then we curate and drain this all supralevator abscess like this. Then we pass a probe from internal opening to this space, and then we can pull this through a RT forceps, and then we pass a seton through this and tie the seton. Allow this abscess to heal gradually like this, and then we can decide what we can do for the remaining primary tract. We can do either a lift for that, or we can do a mucosal advancement for that. So complex anal fistula cannot be treated in one day or one go. We have to allow healing of abscess cavities and secondary tract before we finally take on the primary tract. Now this is again a case of bilateral horseshoe fistula. This is one opening, this is the other opening. They are coming like this posteriorly and then going to a high fistula tract. Now the partial fistulectomy is done one side, the other side, and the remaining tract we are putting draining setons, or this is an infant feeding tube, and then there is a primary tract where I have put a vascular loop. You will see that with time all the secondary tract are gradually healing like this. They have healed, and in the primary tract there is a seton lying. We can tackle this again once the wound has healed by either a lift or by a flap advancement. Now deep postanal spaces and supralevator abscesses also required attention. This is how to drain a deep postanal space, and this is how to drain a supralevator abscess. This hole is in the levator ani, you can see, and we have curated and drained this. And with time, this wound is healed and the seton is there in primary fistula. This is a patient who has been operated maybe a dozen times, but his perineal wound has not healed. Every time a new incision and new scar. When we explore all these wounds, we found the primary tract. This is a primary tract. This seton is going in a primary tract, and all other branches were curated, cleaned, opened, and seton was placed. Gradually, all seton came out except this middle wall seton, and the patient was so happy that he did not want to undergo another surgery for taking care of the primary tract. Sometimes fistula look complex, but for surgeon they are easy. This is, you are seeing so many multiple openings are there, but they are all superficial tract, and the primary tract which were there was also a low transsphincter tract. So we could leave open all these things in one go, and this wound gradually. Now this is our proposal or suggestion for fistula surgery. You see, these are the incisions which are all required for treating any fistula. The incision should be outside the external sphincter. So this is should be like this. Suppose this is a track and we want to track this either fistulectomy or fistulotomy. So we can give an incision like this. If the track is here, we can give incision like this. If a track is posterior, we can give like incision like this. If a fistula track is very much away from the anus, there is no need to open it like this. We intercept this track at this plane, and we treat or tackle the medial part of the fistula as per its merit, whether it is deep or superficial, and cure it and leave this track, it is healed. So there is no need to give many incision wide away from anus. This is role of ceton in complex anal fistula. In complex anal fistula, the ceton has a very important role. It can be left to mark the fistula tract. Many times we are not very sure while operating or while clinically assessing fistula that it is simple or deep, because the opening is always at dentate line, but the fistula tract takes a higher course through the sphincter. So we can leave a sphincter, a ceton, and when patient comes out of anesthesia and the sphincter tone is relaxed, we can assess whether how deep it is. This allows to treat deep-seated infections. It is as an initial procedure for many complex intervention like lift or flap advancement. And it can be a palliation for refractory anal fistula. If a patient requires multiple operation, he is not getting healed. If we can put a ceton in the primary tract and leave it, patient is very happy, and this is a very good palliation. Now, this slide is about passing a ceton in a high fistula. You see, a high fistula is a U-shaped tract, and you can say that if you pass a probe, it will stop here. In no way a malleable probe even can be passed to this place. So I do not know how vast or a telescope which is rigid can be passed to treat this fistula. What we do, as we have said, we do fistulotomy of the fistula tract till we reach the sphincters. Then we pass a malleable probe from inner opening to this wound, and we can pick this tip of the probe by RT forceps, pull it down, and pass a ceton here and bring it here. So that is a technique of passing ceton in a high fistula. Now this is a patient who agreed or who was happy with a palliative ceton, and it is much better than having a scarred perineum like this or like this and many operations later. Now, I found the result of various procedure for complex anal fistula, very recent, March 23 publication. So lift, they say 60 to 90%, 60 to 90% rectal advancement flap, tropis 90%, flac 65 to 90%, waft 90%. So this does not give us any guidance whether any procedure is good or bad. And the real fact is that statistics is very difficult to interpret because they are different type of patients. Then everybody will not report all the findings. They have reported healing rate, they have not reported recurrence rate, they have not reported the incontinence rate. So in our experience, the rectal advancement flap has about 50% success rate. We do lift, tropis. I don't do flac or waft. Now, what is our message is that a simple anal fistula can be identified through diligent local examination. And fistulotomy under local anesthesia is simple treatment option. Thorough assessment is required for the topography of complex anal fistula. Patients should be informed, counseled and informed. All complex anal fistula, they must be told, number one, you require prolonged treatment. Number two, you may require more than one operation. Number three is that you may develop some degree of incontinence. Number four, the result is not assured. Then we have to always locate and control deep-seated abscess. We have to always preserve upper two-thirds of anal sphincter. And some of the complex anal fistula may require specialist reference. I have 4 slides more to see that will be interesting. I have some time, maybe 4 minutes, I will use that. This is about local anesthesia for surgery of simple anal fistula. We can operate simple anal fistula under local anesthesia. We have to have a patient selection, adult patient, ASA grade 1 and 2, no history of adverse drug reaction and informed consent. We use pre-medication, paracetamol IV, diclofenac IV and midazolam IV. Antibiotic, we give a single shot of ciprofloxacin and metrogyl. We make an anesthetic solution using 50% of ligonocaine with adaline and 50% of 5.5% bupivacaine. And we take care of maximum dose of these drugs for the patient. And what is very important is the infiltration technique. We use the smallest size needle, 26-27 gauge needle. We give very slow injection. We infiltrate around the fistula tract. You see, fistula, simple fistula is a sectorial disease. It involves only one sector around the anus. So you can very easily infiltrate the tract around that, and then you can infiltrate inside also around the internal opening. So infiltrate into the sphincter and up to the internal opening. Avoid puncturing tract to spread the infection. And then we wait. It is very important that when we use local anesthesia, after we give anesthesia, we wait for 5 minutes for its effect to take. So that concludes my talk. If any questions is there, you may please ask.
Thank you very much, Dr. Jain, for an excellent presentation on complex fistula. The house is open for discussion. Thank you, sir.
Thank you so much, sir. May we request Dr. Shanti Swarup, sir, to please facilitate Dr. B.K. Jain, sir. May we please request on stage Dr. Sanjay Pandey, sir, to please facilitate Dr. Shanti Swarup, sir. Thank you so much, sir. Carrying forward with the session on colorectal and perineal trauma, we would like to invite Dr. Madhubala Ma'am, Professor, Head of Department of Surgery, GS Medical College, Hapur, to please chair the session. May we also request on stage Dr. Neeraj Kumar, sir, Assistant Professor, Department of Trauma Surgery, AIMS Rishikesh, to please moderate the session.
Same full photo.
Very good afternoon. Myself, Dr. Neeraj, Assistant Professor in the Department of Trauma Surgery. Here I'm here to discuss the various update regarding the management of the colonic and the rectal trauma. As far as the colonic injury is concerned, the most common cause of the blunt injury abdomen is the motor vehicle injuries. And therefore, the most common cause of the colonic injury as well is a motor vehicle accident. When there is a four-wheeler injury, the uh, patient is there suffering an injury from the motor vehicle crash, then the seat belt mark is a very important sign to make the diagnosis. Because if there is a seat belt sign present, then the chances of the hollow visceral injury is very high. There are the two mechanisms basically that lead to the hollow viscous injury in the motor vehicle crash. One is a rapid deceleration that leads to the mesenteric tear, and other is the formation of the loop. This formation of the loop of the bowel lead to the sudden increase in the pressure, leading to the burst out of the bowel wall. Luckily, as far as the colonic injury is concerned, the incidence is only 10% in the laparotomy cases of the trauma patients. And other lucky thing is that most of these injuries are only the superficial. Only 3% of the colonic injury are there that cause the thorough and thorough perforation. Whatever the injury of the patient in the trauma is, the approach is a universal, and that is a ATLS protocol. According to that, the patient must be initially managed with the primary survey. That is the management of the airway, breathing, circulation, followed by the neurological deficit. Only when the patient is hemodynamically stable, then only you proceed for the secondary survey or per se the clinical examination and the investigation. As far as the diagnosis is concerned, in the penetrating injury, if the patient requires the immediate laparotomy, then the diagnosis of the colonic injury is only made intraoperatively. What you have to do, that every paracolic hematoma, apart from the obvious injury, must be explored carefully so that there is no any single injury in the penetrating trauma that can be missed. But if the patient is planned for the non-operative management in the penetrating injury, then investigation of choice is the contrast enhanced CT scan. But you should not only stop up to the CT scan finding. The serial clinical examination is one of the important benchmark to make the diagnosis. As far as the blunt trauma abdomen is concerned, if the patient is unevaluable, for example, if the patient's GCS is low and the intubated, then to make the diagnosis clinically is very difficult. In this scenario, again, the investigation of choice CT scan remain the number one, though the sensitivity and the specificity of the CT scan is very low. The finding in the CT scan is free gas or the unexplained free fluid in the cavity or the thickened colonic wall. But if these findings are not present in the CT scan, it doesn't mean that you can rule out the colonic injury. Therefore, the imperfect sensitivity is one of the reasons that might lead to the catastrophic consequence in the colonic injury. Digital rectal examination might give an important clue to make the diagnosis of the colonic injury if there is especially in case of the descending colon or the rectal injury. But the absence of the blood in the rectal examination doesn't rule out the rectal injuries. As far as USG, diagnostic peritoneal lavage, and the laparoscopy is concerned, there is a minimal or per se there is no any role in making the diagnosis of colonic or the rectal injuries. Here, it is a colonic injury severity scale, and the American Association of the Surgery of the Trauma has divided the colonic injury into the 5 grades. But for our clinical point of discussion, we will divide this colonic injury into 2 different parts. One is a devastating injury and another is a non-devastating injury. The first 2 grades, one is the grade 1 and grade 2, falls under the non-devastating injury, and from grade 3 to grade 5 come under the devastating injury. This operative management of the coloning injury is very interesting because there is a lot of changes in the recommendation as far as the treatment is concerned. For example, early in the World War II, it was said that because of the high mortality of the coloning injury, the colostomy was recommended in all of the coloning injury patients. But this, depending upon the evidence, there is a lot of change in the recommendation, and we will discuss here one by one. As per se, in case of the non-destructive injuries, non-destructive injury of the colon are those injury where there is a less than 50% of the bowel wall is involved and there is no any devascularization of the colon wall. In this type of the case, these patients are mainly managed with the primary repair only. There is a class 1 evidence, here you can see, there is a class 1 evidence where the patient was compared with the primary repair with the divergent colostomy. And we found that there was no any difference as well as abdominal complication is concerned. Therefore, the primary repair should be the main recommendation for the management of this non-destructive type of the injury. But all habit, even particulate in the our scenario, and most of the surgeons, especially in case of the high risk scenario, prefer the colostomy. As far as destructive colonic injury is concerned, destructive colonic injuries are those where more than 50% of the colonic wall has involved or there is a devascularization of the colon wall. Traditionally, these patients are also managed with the resection and diversion, especially in case of the high-risk group. High-risk group patients are those where there is a blood transfusion of more than 6 units, or there is a delay in presentation to the hospital more than 6 hours, or there is a severe contamination on laparotomy, or the Patty index is more than 25. Patty index stands for the Pancreatic Abdominal Trauma Injury Score. There was a lot of debate regarding management of these destructive colonic injury. Some of the study used to say that you should go for the primary repair, and some study used to say that you should go for the bypass surgery. To make a consensus, the American Association has recommended and supported a evidence, and in which the prospective trial was done, in which 297 patients with the destructive colonic injury was included. In this studies, the patients were belonging to the low risk group as well as the high risk group. High risk group patients were those where, again, I will mention, there was a more than 6 units of the blood transfusion was done, or the patient presented on the time of presentation, patient was in the shock, or there was a delay in presentation to the hospital for more than 6 hours. When these patients were compared, then it was also found that there was no any difference when the patient were managed with the primary repair or with the divergent colostomy. Therefore, and they come on to the conclusion that colon diversion is associated with the worst outcome quality of life and require an additional operational closure, and colon injury requiring recession should be managed by the primary repair in the index surgery, irrespective of the risk factor. But there is some exception to this scenario, and that is a destructive injury due to the blast injury. Though the incidence of the blast injury is very less in our scenario, but definitely we have to take in consideration. As far as damage control surgery is concerned, the patient scenario or the indication of the damage control surgery is very different from the others what we have discussed so far. In case of the damage control surgery, the goal of the treatment is first to control the bleeding, and second one is to control the contamination. In these damage control surgery, if there is a colon injury, then the non-circumferential injury are primarily managed by just closure with the help of the 3-0 suture, and this closing is done in the transfer direction. If there is a circumferential injury or there is a multiple perforation, then you have to just do the segmental resection with the help of the using linear stapler. You don't have to think for the primary repair or the divergent colostomy. You have to just close the stump. The risk factor of after doing the surgery, the sepsis rate in the colonic surgery is more than 20%. When we compare the left versus right colon injury, then there is a usual saying that left colonic injury, the healing is poor as compared to the right. But when a study was conducted, then it is found that there is no any healing difference in the right or the colon injury, and it is comparable. But it is found that if there is a right side of the injury, then ileocolic anastomosis has a low leak percentage when compared to the colocolic anastomosis. Therefore, the procedure of choice in the right hemicolectomy is the ileocolic anastomosis. The main good supply is the cornerstone of the management of the primary repair. Therefore, before proceeding to the primary repair, we must ensure that there is a profuse bleeding from the primary resection part, and there is no any contused part present on the resection part. One of the important area for the blood supply is the watershed area. While you are repairing in the watershed zone, then you must be conscious, and if preferable, you can plan for the diversion colostomy. Associated abdominal injury. If there is any other injury in a colonic injury, then definitely chances of the septic complication increases. That is the abdominal complication. But it is not an indication that you should go for the diversion colostomy. If you do the primary surgery, primary repair, or do the diversion colostomy, the chances or the results are the same. Also, if the patient is there in the shock, then the class 1 and class 2 studies suggest that there is no any contraindication for the primary repair if the patient is in shock. But this study doesn't taken into account the severity of the shock and the duration of shock. For example, in the damage control surgery, the patient is already in the shock, and in those scenarios, the management is different. Therefore, in sustained intraoperative hypotension, damage control surgery plan should be done. Blood transfusion. In a blood transfusion also is one of the criteria that leads to depict that what management you have to take in the OT. For example, if the patients require more than 3 units of blood transfusion within 24 hours, then chances of the abdominal sepsis increases. Also, if you are researching the patient and you have given more and more amount of the fluid, then chances of the leakage increases. And study have suggested that more than 10.5 liter over the first 72 hours increase the 5-fold chances of leakage. Therefore, rather than the fluid transfusion, you must focus on the blood transfusion or the blood product. Fecal contamination. The amount of fecal contamination, definitely, if there is a more and more contamination, then chances of the abdominal sepsis are very high. But it is not a contraindication for the primary repair again. And though some suggest that there is a contraindication, but class 1 or class 2 evidence again suggests that if you do the primary repair or do the diversion colostomy, the chances of the abdominal sepsis are similar. Time from injury to the operation. Definitely, as the patient arrives and there is a delay in surgery, then the contamination increases. Therefore, rather than the presentation, rather than the delay in the surgery, it is the severity of the contamination that decides the management rather than the presentation. Now, after doing the repair, either the diversion in the primary form, the incidence of the leakage is very low. That is the luckiest part of the colonic injury. And if there is a leakage, then prognosis is also very good. Majority of the patient who leak after the primary repair, these are managed with the percutaneous drainage. These are managed with the help of the percutaneous drainage. But if there is a generalized peritonitis or it is very difficult to do the percutaneous drainage, only then you plan for the re-exploration. And in re-exploration, you do the white drainage and a fecal diversion. So the technical tips in management of the colonic injury is that first step is the manage the bleeding and followed by the contamination. If there is a suspected colonic injury, then you have to mobilize the injured part of the colon and you have to see is there any perforation in the retroperitoneal part or not. All the paracolonic hematoma, especially in case of the penetrating injury, must be explored. If there is any doubt, then you can also go for the gentle squeezing of that colonic part that is damaged, and you can see either there is a gush of air or the foul smell is coming out, or might be a leakage of the fluid from that perforated part. If there is any injury of the ascending or the descending colon, then you must have to explore the ureter as well, because there is a chances of the ureteric injury in this scenario. While mobilizing and inspecting the transverse colon, you try to push or you try to pull this colon, transverse colon, in the downward direction. But there is a problem that this transverse colon in the splenic flex is attached to the splenic part via the ligament. This attachment lead to the traction of the splenic capsule in the downward direction, and therefore leading to the bleeding. Therefore, this might lead to even the indication for splenectomy. Therefore, to prevent this tear of the spleen, what you have to do, you have to just put a 2 to 3 pads under the diaphragm, between the diaphragm and the spleen, so that the spleen comes down and you can easily inspect the transverse colon. Anastomosis. If you are moving and you have planned for the primary repair, then there is a debate that what is good, either the hands-on or the staple. The evidence has suggested that result of both, either in the hands-on or the staple, are similar, and it depends upon the surgical skills of the surgeon, the decision can be made. And because there is no any significant difference. Other thing is, if the plan is for the hands-on, then how you have to repair, either in the 1 layer or the 2 layer. Again, the evidence suggests that in whatever fashion you do, the results are similar. Means the 1 layer primary repair is also as safe as the 2 layer primary repair. Now coming to the rectal injury. We have discussed that the colonic injury, the most common injury in the colon are because of the blunt trauma. But it is reversed in the rectal injury, and most common rectal injury are because of the penetrating injury. In the Western countries, because the gunshot is sharp or iatrogenic, because of the surgical procedure. And the blunt trauma only constitute around 5 to 10%. The anatomy is very important in case of the rectal injury, because part of this rectum, the lower 1/3, is completely extraperitoneal, and therefore it is very difficult to assess to operate. As far as grading of the injury of the rectal is concerned, it is as similar as the colonic injury. Therefore, we will not discuss here. Now, coming to the diagnosis. If there is a blunt mechanism of injury is there, in case of the rectal injury, then most of the blunt injury involve this intraperitoneal part of the rectum. And principle of this management principle for this diagnosis is same as that in the colonic injury. But if there is a penetrating injury, then depending on the site, it might be the intraperitoneal or the extraperitoneal. The extraperitoneal, because it is not communicating to the peritoneal cavity, therefore the chances of the peritoneal irritation and the clinical finding are less likely. Now, because the penetrating injury are more common, so we will discuss here. If the patient of the penetrating injury is unstable or having the peritonitis, then you have to directly plan for the laparotomy, and you have to examine this lower part of the rectum, or per se the extraperitoneal part, in the OT with the help of the sigmoidoscopy or the endoscopy. But if the patient is stable and there is no any peritonitis, then you plan for the investigation choice, that is the CT scan. If the CT scan is normal and you see that you are very confident enough that there is no any tract seen in case of in the CT scan, then you plan for the conservative management and no further workup is required. But if there is any doubt in the CT scan, or there is an obvious finding suggestive of the penetration, then you have to shift the patient to the OT, plan for the laparotomy along with the endoscopy and the sigmoidoscopy to rule out the injury of the lower part of the rectum. Operative management. As we have discussed in the colonic injury, the operative management of the rectum also have evolved over the period of time. And because there was a mortality, it was a very high mortality, around 60% in early part of the World War II. the management was with the help of the diversion colostomy. But during the during the course of the time and evidence base, the management has changed drastically. With the duration of time, the colostomy was mandated somewhere after the word was second. It was again the one of the management was added in the form of the pre-sacral drainage in 1943 that also further helps to decrease the mortality. Now, after this 1943, again at the end of 1943, one management was also added to the rectal injury, and that was in the form of the distal rectal washout. Therefore, the triad of the management of the rectal injury was formed in the form of the colostomy with the rectal washout with the pre-sacral drainage. And this management triad was continued for the long time. But now the management plan has particularly changed. This pre-sacral drainage is now avoided because it is said if you are planning, if you are doing this this rectal washout, then what it will do, it will might dilute this bacterial flora. It might help to this spillage of this bacterial flora into the peritoneal cavity and therefore increasing the septic complication rate. As far as pre-sacral drainage is concerned, if you try to do the pre-sacral drainage, then chances of the mortality is very high because you need a lot of dissection, soft tissue dissection in the crucial part. So now coming to the management and the technical tips. If the patient is having the extraperitoneal injury, that is an extraperitoneal injury in the lower part of the rectum, then and you are able to manage this with the help of the local repair, then it is all what you have done. But if you are not satisfied with your local repair, then you will plan for the fecal diversion. If the injury in the extraperitoneal part is on the higher side and you are not able to assess it and it is not satisfactory, then what you have to do, you have to keep this retroperitoneum as such. You don't have to touch it and you have to just give the diversion colostomy. If there is an associated bladder injury also, then to prevent this rectovesical fistula, what you have to do, you have to put a omentum in between to prevent the formation. Also, if there is a high destructive injury involving the canals and cincture, then you can go for the abdominal perineal resection. As far as the intraperitoneal injury is concerned, then their management is as same as that of colon, what we have discussed so far. Wound management and antibiotics. After doing the rectal surgery, whether we should go for the primary closure of the skin or not, there was a lot of debate. And now evidence suggests that if you do the primary repair, the chances of the skin infection is double. Therefore, it is better to delay the skin closure in the index surgery and plan for the primary and plan for the secondary closure of the skin in the third or fourth post-op day. As far as antibiotic is concerned, then you should consider the both antibiotic covering gram positive as well as the gram negative. But the evidence also suggests that duration of antibiotic, if you give for only for 24 hours, or if you go for 3 to 5 days, are as same, and there is no any much difference. Now coming to the ostomy complication closure. Ostomy complication, as we know all, is the necrosis, retraction, prolapse, parastomal abscess, and hernia. There is a lot of debate about the closure time. As far as closure time is concerned, traditionally all the diversion are closed after 3 months of the index surgery. But few study has suggested that if you repair or you do the colostomy reversal surgery within 2 weeks, even then the results are satisfactory. But our suggestion is that the optimal time, it depends upon the individual and other injuries involved. You have to evaluate the patient thoroughly, and if you are satisfied with the other injuries, because in case of the blunt trauma abdomen and the patient is having the colonic injury, then colonic injuries are not isolated. Patient would also be having the other injury as well. Therefore, you have to see that other injury has healed properly, and if you are satisfied and the wall of this mucosa of this colon is healthy, then you can plan for the definitive surgery.
Thank you, Dr. Neeraj, for such an informative talk. Any questions from audience?
Okay. So, yeah.
The patient may go into sepsis and may have fatal complications. You have some evidence, I think.
We don't have to wait basically. In case of the if definitely if the patient is not having generalized peritonitis and there is a suspicion of the
If there is on CT, there is a leak, you will wait for percutaneous drainage or you will divert?
No, sir. First, we will go for the percutaneous drainage. And the patient is not resolving because most of the cases of this colonic leak are managed very beautifully with the help of only the percutaneous drainage. But this drainage should be the wide enough to drain this fecal material.
Oh, can you share with the data after the presentation?
Yeah, sure.
Thank you.
Thank you, sir. I would request Dr. Madhubala to kindly felicitate Neeraj, sir. Thank you, ma'am. I request Dr. Sanjay Pandey, sir, to kindly felicitate Dr. Madhulata, ma'am. Next, we have a panel discussion on management of pilonidal sinus and solitary rectal ulcer syndrome. To moderate this session, I would like to call upon Dr. Dhanesh Kumar, sir, who has been associated with our institute for over 10 years. Sir has completed his surgical residency from Himalayan Institute of Medical Sciences, Dehradun. Sir is a skilled laparoscopic surgeon and has exemplary clinical skills. He is also an avid academician and has many publications in national and international journals. His dedication to teaching is admirable and he is a mentor to all his students. Please join us on the stage, sir.
To chair the session, I would like to call upon stage our beloved faculty, Dr. Sanjay Pandey, sir. Sir has completed his surgical residency from LLRN Medical College and has been associated with us for past 16 years. Sir has over 40 publications in national and international journals.
Sir's enthusiasm for teaching and patient care is unparalleled. A generation of young surgeons stands on his shoulders. Having had the opportunity to watch Sir perform surgeries, I have learned two valuable lessons. One, to always respect the tissue, and second, that sorry has no meaning for a surgeon. Today, Sir has permitted us to partake from his knowledge. Please join us on the dais, sir.
I would also like to call upon Dr. Dheeraj Balian, sir, who is a leading minimal invasive surgeon, currently leading charge as a head of Department of General Surgery in LLR Medical College, Meerut. Sir has had the privilege of working at elite institutes like Tata Memorial Hospital, Mumbai, and Sir Gangaram Hospital, New Delhi.
Sir is a fellow of IAGS, ALSUGI, hepatopancreatobiliary and gastrointestinal surgery. He has perfected complex laparoscopic GI surgeries like laparoscopic Nissen's fundoplication. He has led charge as the chief medical superintendent at LLRM during the COVID pandemic, and he has a number of publications in national and international journals. Apart from his clinical prowess and academic excellence, Sir is also a skilled guitarist and actively participates in all cultural activities, a well-rounded personality indeed. Please join us on the stage to chair the session, sir.
It gives me a great pleasure to invite the panelists for this session, Dr. Devendra Singh sir and Dr. Sandeep Kansal sir. Dr. Devendra Singh sir is a renowned surgeon, gastroenterologist, currently providing his services at AIIMS Delhi. Sir has had the privilege of working at many esteemed institutes and has a significant number of publications in a national and international journals. Please join us on stage, sir.
Dr. Sandeep Kansal sir is a leading plastic surgeon at our institute and has been with us over 12 years now. Sir completed his surgical residency from SN Medical College, Agra, and went on to do his MCH in plastic and reconstructive surgery at SMS College, Jaipur. Sir's calm nature and gentile manner endeared him to his students and patients' hearts alike. He has a number of publications in various index journals. We welcome you on stage, sir.
Thank you. Thank you for inviting me for this talk. Now, I started with the pilonidal sinus disease. What is pilonidal sinus? So it is the pilonidal sinus disease, also known as G bottom or the driver's bottom. The pilus means hair and it is his nest. That is the nest of hair. And the term pilonidal sinus describe a condition that found in natal cleft overlying the coccyx, consisting of one or more, usually non-infected midline opening, which communicate with a fibrous tract lined by granulation tissue and containing hair lying loosely within the lumen. So it's a midline opening which lie in the natal cleft. So it has either a single opening or a multiple opening. As in this figure, we can see that is a single midline and the multiple midline opening. So it may be filled with fluid or pus, causing the formation of a cyst or abscess. A pilonidal cyst usually contain hair, dirt, and debris. It can cause severe pain and can often become infected and may ooze pus and blood and have a foul odor. So it may present as a simple opening or a swelling or as a cyst. The type, it may be primary or secondary. The primary opening, they always lie in the midline in natal cleft, and the lateral swelling or lateral opening, they are the secondary sinus opening. Now, epidemiology, incidence, it is around 2.2 per 1 lakh people, and it is affect male more than the female. Now, etiology. So the question is, it is a congenital or acquired one? So Dr. Devendra, can you make a comment over it?
As per the current literature, pilonidal disease is considered now acquired. Previously, it was thought to be congenital, but there is now enough evidence that is an acquired etiology.
Yes. Now, although acquired theories of development are better accepted than the historical congenital one, but the exact mechanism is still speculative. The evidence that support the theory of acquired one, that are the age of incidence. The age is usually the young age, 20 to 29 years, which is around the 82% patients present in this age, and this is the variance with the age of onset of congenital lesion. And the male preponderance, that is 74% are male. The male sex hormone affects the hairy body, more sweat and maceration. As they occur in young ages, they have active pilosebaceous gland, and this all they lead to in the formation of this pilonidal sinus. Hair follicles, yes, the hairs, they are present in the pilonidal sinus, but the hair follicles have never been demonstrated in the wall of the sinus. The hair projecting from the sinus, they are dead hairs, and they are pointed and directed towards the blind end of the sinus. The recurrence is common even after the adequate excision of tract is carried out. The obese and overweight into the deep natal cleft, usually, but not invariably, when diagnosis is confused with the other, like the anal fistula and hidradenitis suppurativa, the sinus run cephalad. That is, it always run towards the cephalad direction. The interdigital. The one more thing, that why it is acquired one, that interdigital pilonidal sinuses is an occupational disease of hairdresser. The hair within the interdigital clefts or clefts being the hairs found in the interdigital clefts are being the costumers. And pilonidal sinus of the axilla and umbilicus have also been reported. As in this figure, you can see that there is an interdigital pilonidal sinus, and we can also appreciate the hair coming out from it. It is not it is from the customers. And this figure showing the pilonidal sinus of the umbilical lesion. Now, it is thought, what is the etiology? It is thought that the combination of buttock friction and the shearing force in the area allow a shed hair or broken hair which have collected that drill through the midline skin, or the infection in relation to a hair follicle allow hair to enter the skin by the suction pressure created by the movement of the buttocks, so creating a subcutaneously chronically infected midline tract. The body, which consider these hairs as a foreign body and launches an immune response against it. The immune response from the cyst around the hair, and then it presented as a swelling. Sometimes a person may have multiple sinuses that connect under the skin, that is more than 2 or 3 or 4 opening in the midline. From this primary sinus, the secondary tract may spread laterally, and which emerge at the skin as granulation tissue line and the discharging opening. The histopathology, yes, the microscopically it is noted that hair within the pilonidal sinus originated from the overlying surrounding skin. That is the hairs, maybe the patient's own hair, but the follicles are never found in the wall of the cyst, but rather free in granulation and scar tissue. And the wall of the pilonidal sinus, they are not lined with the squamous epithelium, but are composed of vascular pyogenic granulation tissue. Now, the risk factor, that is the male sex, family history, being overweight or obese, trauma or irritation, the sedentary occupational lifestyle, hirsute habitus, and poor hygiene. Now, Dr. Sandeep, can you enumerate the clinical feature?
Usually there is pain, discharging sinus, the recurrent discharging sinus, tender swelling, and tough hairs are present around the area.
Yes, usually it is as present as asymptomatic, the midline opening. First, rather than a small dimple-like depression on the surface of the skin in the natal cleft. But if it is infected, or it may have a discharge from its opening, either it's a serosanguinous or purulent or foul-smelling discharge, And if it is blocked, it may have a tender swelling, which thrombing pain, and it's a persistent thrombing pain. And this tender swelling is just lie above the coccyx in the midline or on the other side of the midline, the secondary sinus. The tufts of hair may be seen in the opening of the sinus. The presentation may be as an acute exacerbation, that is as an abscess, or as a chronic recurrent sinus with pain, discharge, and discomfort. Now, Dr. Kansal, can you give that? How can we make a diagnosis? Or
Diagnosis is usually clinical, and we can also do MRI for the diagnosis.
yes, the diagnosis is usually clinical, as it is an obvious midline opening in the natal cleft. Then there is no further lab test or any other imaging is required to diagnose the pylonal sinus. But we can do some investigation in case of confusion, like the fluoroscopy or ultrasound test, when we confuse with either it is a superficial abscess or anal or perianal sinus or perianal swelling, which is extended towards this region. The MRI is more expensive, but may aid in diagnosis when there is a concern for inflammatory bowel disease, fistula and anopelvic sepsis, or neoplastic procedure. So, the most of the time we do not need radiological diagnosis, but the clinical diagnosis is enough. Here we can see a cystic collection in the natal cleft region in fluoroscopy, in the AP view and in the lateral view. Here in ultrasound, there is a collection of the hairs and the abscess. And in MRI, we can see a midline opening in the natal lesion. Now, the treatment, Dr. Devendra, can you?
The treatment should be customized as per the patient's symptoms. If he is asymptomatic, then masterly inactivity with perineal hygiene, like local shaving of hairs with wheat cream, etc., should be done. And if he is symptomatic, then only any surgical measure or other treatment should be done. And surgeon should consider that the treatment should not be higher morbidity as compared to the disease itself. This disease is very important.
Yes, as the natural history of condition is usually one of regression. That is, in those whom the symptoms are relatively minor, the simple cleaning out of the tract and removal of all hairs with regular shaving of the area and strict hygiene may be recommended when the patient doesn't require any surgical intervention. That is, if we keep the area clean, then patient can be managed conservatively. But the minimal intervention may be done, like the phenol injection. This Merrick and Greenwood proposed phenol, a sclerosing agent, as a treatment of pylonal sinus in 1964. It has been used in liquid and crystallized form. The Drury et al. Found success using phenol as an outpatient treatment. They reported a success rate of around 95%. That is, 95% is much more, and as a decreased recurrence rate. So it is important to note that the repetitive applications are required to increase the success rate of phenol application. And the success rate with a single application is around 56 to 86%. That is, after a single application, the healing rate is 56 to 86%. But if we give a 2 or 3 sitting, then the rate may be approach up to the 95%. Eventually, the treatment will cause the lesion to harden and close, but there was a high risk of treatment failure with a history of abscess drainage, and greater than 3 sinus opening. That is, if the sinus opening is more than 3, or there's a history of abscess drainage, then the chances of failure of phenol injection are higher. Now, the minimal intervention is that is the fibrin glue. This fibrin glue has been used for treatment of pylonal sinus disease, either as a primary treatment or an adjunct of surgical technique. But the study suggests that using the fibrin glue in addition to surgical excision, that is, in conjunction with the other surgical technique, It obliterates the dead space, increase primary healing up to 96%, and decrease the mean healing time. But a recent review study that determined that effectiveness of fibrin glue alone as a monotherapy or a surgical agent was uncertain. We need further evidence. And the next, this platelet-rich plasma has a promising result. The platelet-rich plasma is derived from the autologous blood that is centrifuged and contain a high concentration of platelet and growth factors. A recent study by Seminek et al. In 2020 evaluate the long-term result of a minimally invasive approach to treating pulmonary sinus with PRP. And their study evaluate 138 patients with a median follow-up of 60.2 months, and they reported a success rate of 97%. After the month, with a recurrence rate of 8.2%, at the 60.2 months, mean healing time was 13.3 days, with 82.6% completing healing after a single application. That means the patient need a single application, and 82.6% result is there. And if it repeat, then the rate is reached up to the 97%. The Seminek also continue their study, and the Curatas plus PRP group, 96 patient achieved healing after the single application. That is, if the tract is curetase and they apply the PRP, then the healing rate is very, very, very high. Now, Dr. Devendra, can you explain about the surgical treatment of the pulmonary sinus?
There are numerous techniques described in the literature for the pulmonary sinus disease, but all are debatable. And the bottom line is that the midline closure technique should be abundant because it carries a very high recurrence rate. And secondly, previously we do wide local excision and let the patient heal by secondary intention. So that carries very high morbidity, much higher than the disease itself. So the primary local excision should also be not be done nowadays. Various other techniques such as Limbach's flap or rhomboid Limbach flap or Bascom's cleft lip procedure have good success results. Nowadays, newer endoscopic treatment like VAPS, the video-assisted ablation of pulmonary sinus, or endoscopic pulmonary sinus treatment is also gaining wide spread importance. But the results are in the infancy stage. We have only 1 or 2 year results. Long-term results are unavailable. But as per now, surgery, the Limbach flap or rhomboid flap repair still remains the gold standard in my opinion.
Yes. Usually, surgeon preference influences the choice of method, which include either the open surgical method with or without flaps, and the minimal invasive methods like the endoscopic pulmonary sinus treatment, pulmonary sinus laser treatment, and the Shart Sutra. So we will discuss it later on. Now, the open surgical method, that is, what are the methods of the open surgical method? That is lying open all tract with or without marsupialization, the excision of all tracts with or without primary closure, the excision of all tracts and then closure by some other means designed to avoid a midline wound like the other flaps, and the jetplasty, Caridacus flap, rhomboid Limburg flap, and the Bascom procedures. The treatment of acute exacerbation, that is, if abscess is present, the abscess should be drained thoroughly with a small longitudinal incision make over the abscess and of the midline with thorough curettage of granulation tissue and hair. And this procedure may or may not be associated with complete resolution. Around 70 to 75% of patients will not, they do not need the further treatment. Now, Dr. Sandeep, can you explain over the excision and with primary closure or the other flaps?
I do prefer with primary excision and the flap coverage. Usually rhomboid or Limburg flap is most widely used. Alternatively, we can also do Z-plasty or Caridacus procedure.
Yes, the excision of all tracts with or without primary closure. That is, we'll excise all the tracts, the primary as well as the secondary, and then we leave as such open and lead them to heal by secondary intention, or we give them a flap coverage to heal quickly. Now, as sir says that's the rhomboid limbar flap used for excision of pulmonary sinus to reconstruct the defect. It flattens the natal cleft with a large, well-vascularized pedicle that can be sutured without tension, thus avoiding the midline suture line. This Caridecus flaps, that is, in this, we give the lateral incision and we reach into the pulmonary sinus opening. We remove all the granulation tissues, abscess, and hairs, and then we stitch at the lateral part of the incision. Now you can see here the main purpose of all the flaps that we have to avoid the midline and to heal in the lateral part. In the Bascom procedure, we involve incision lateral to the midline to gain access to sinus cavity, which is get rid of hair and granulation tissue and excision and closure of the midline pits, and the lateral wound is left open to heal naturally. The jetplasty, it is the results are good, but the cosmetically it is very it's not good. The minimal invasive surgery. Yes. Now the endoscopic, the newer modalities of treatment, they are coming into the picture. That is endoscopic pulmonary sinus treatment and a minimal invasive approach. Here we will treat the primary as well as the secondary sinus tracts. As you can see here, either we, when we reach into the cavity endoscopically, we remove all the debris and the hairs, and then we either we cauterize it and we leave the tract open and let them heal naturally. And then, as you can see, the multi-center study conducted by this Minero et al. Showed result using the APSIT procedure with a success rate of close to 95%. The success rate of 90% is similar to the best in result from the report on the open technique according to the recent meta-analysis. And now the recent treatment is the pulmonary sinus laser treatment. The sinus get removed and the wound healed without the stitches. The entire sinus is cleaned first, then a laser beam is passed into the sinus and the tract is destroyed using a radial laser fiber without leaving a large wound or needing a flap. Here, as you can see in this figure, after cleaning the entire tract, we pass the laser fiber into the entire length of the pulmonary sinus, and then we burn the entire length of the tract. Here, the combination of laser and endoscopic pulmonary sinus treatment is feasible procedure that we are using the APSIT along with the laser. That is, it's a treatment is feasible procedure with a 92.3% complete recovery rate according to the early result. As these are the newer modalities that we have to wait the long-term study results. However, study with a larger sample size and larger follow-up period is required to confirm the validity of this result. The Sharsutra, in Sharsutra therapy, the thread which are smeared with Ayurvedic herbs before using them to treat the disease, the thread is placed inside the pulmonary sinus and replaced with a new one after every 7 days. The entire Sharsutra therapy taken, the time taken is 4 to 8 weeks depending on the severity of the condition to complete. But still, now then we need the large sample analysis to provide the quality evidence. Now, the recurrent pulmonary sinus, the three possibility which lead to the recurrence of the pulmonary sinus or disappointment. The part of the sinus complex has been overlooked at the primary operation. New hairs enter the skin of the scar, and there is a persistent of midline wound caused by shearing force and scarring. In this situation, the revisional surgery may include re-excision followed by wound closure and obliteration of the natal cleft, either by myocartilage rotation, buttock flaps, or cleft closure, or endoscopic pulmonary sinus treatment with laser treatment. Now the complication, yes, the complications. The chronic pulmonary sinus can cause occasionally, though rarely you can say, the sacral osteomyelitis, necrotizing fasciitis, and rarely the the meningitis. It is not a life-threatening condition, but it's a very highly morbid disease because of high recurrence rate. The malignant transformation is rare and is thought to occur in about 0.1% of cases, and there are about 100 reported cases in the literature. The malignant transformation only occurs with chronic or recurrent pulmonary sinus, with 90% of cases being squamous cell carcinoma. As this figure shows, the squamous cell carcinoma in the pulmonary sinus. Now that's all about the pulmonary sinus. Any question about it?
So for postgraduate, to summarize, if a patient is presenting with acute abscess, then incision and drainage is standard treatment for acute presentation. And if there is chronic sinus with a single opening, then various procedures, as sir has discussed, the laser treatment or endoscopic pulmonary sinus treatment can be done. And if the facilities are not available, then the rhomboid limbac flap remains the standard gold therapy. And for recurrent disease and with multiple complex pulmonary sinus, surgery still remains the gold standard, and I think flap repair is the better.
Flap coverage is the best for treatment for the pulmonary sinus.
Actually, no one dies of a pulmonary sinus. That is something sure. Malignancy has got a very small risk. But yes, definitely, the problem is of recurrence. Unlike fistula and ano, where the chances of incontinence are there is no incontinence in this. But definitely, no treatment option offers a 100% guarantee of non-recurrence. So, you must tailor your treatment according to the patient demands. You do anything, you have to obliterate the tract. You clean the tract and obliterate the tract. Whatever you do, even with the best limbar flap or the rhomboid flaps, chances of recurrence are there. That means every patient requires a tailored treatment.
Now the next topic is solitary rectal ulcer syndrome. As the name shows, it's a solitary, but it's not always a solitary. It's usually associated with the more than one ulcer. The solitary rectal syndrome, that syndrome is rare. Yes, it is rare, benign, and poorly understood disorder that often occurs in the people with chronic constipation. The solitary rectal ulcer syndrome can cause rectal bleeding and straining during rectal bleeding and straining during bowel movements. Despite the name, the ulcers are found only in 40% of patients, and maybe the 20% of patients have a solitary ulcers, and the rest of the lesions, they vary in the shape and size from hypermucosa to broad-based polypoid lesion. Now, can you explain some etiology about it, Dr. Devendra?
Etiology of solitary rectal ulcer syndrome is unclear. It is the name suggests solitary, but it is a misnomer. And the most common pathogenesis described is the chronic constipation, the fecal infection, or digital trauma, or mucosal ischemia, which may lead to ulcer in the long term.
Yes. Now, it is a disorder of young adults. Occur most commonly in the third decade in men and the fourth decade in women. The men and women, they are affected equally with small predominance in women. However, it has been described in children and in geriatric population also. Classically, it takes the form of ulcer, and it always located on the anterior aspect of the rectum, 4 to 12 centimeter from the anal verge, and is thought to be correspond to the location of the puborectalis sling. So position is always anterior and within the 4 to 12 centimeter of anal verge. The underlying etiology and pathogenesis are not fully understood, but multiple factors may be involved. The most accepted theories, they are related to the direct trauma or local ischemia as a cause. The mucosal prolapse, overt or occult, is the most common underlying pathogenic mechanism in SRUS. This may lead to venous congestion, poor blood flow, and edema in the mucosal lining of the rectum, and ischemic changes with resultant ulceration. That is, the pressure increases at the site of the mucosal prolapse, lead to the venous congestion, ischemia, and the final, the ulcer. The cause of ischemia may also be related to fibroblast, replacing the blood vessels and pressure by the anal sphincter. Moreover, rectal mucosal blood flow has been found to be reduced in SRUS. The self-digitation maneuver to reduce the rectal prolapse or to evacuate an impacted stool may also cause direct trauma of the mucosa and the ulceration. The anorectal physiology study has shown that 25% to 82% of patients with SRUS may have the dyssynergia with paradoxical, and the contraction study have confirmed that the uncoordinated defecation with excessive straining over time play a key role in SRUS. So only the local trauma or leading to, or the cause leading to the ischemia at the local site lead to the ulcer formation. The pathology, although identifies an ulcer, the gross pathology of SRUS can range from typical crater-like ulcer with a fibrinous central depression to polypoid lesion. In recent it has been appreciated that the ulcer may heal, leaving a polypoidal appearance. That is, when we diagnose the disease, it not necessarily as an ulcer, but there may be other presentation also, that it is maybe from hypermucosa to a polypoidal lesion also. The histological appearance confirm the diagnosis and is similar to the appearance of biopsies from a full thickness overt rectal prolapse. So here, during the endoscopic imaging, as we can appreciate the ulcer in the wall of the rectum, and the histopathological finding shows there is the infiltration in the infiltration, also smooth muscle hyperplasia in the lamina propria between chronic glands and the surface ulceration with associated chronic inflammatory infiltrate. The clinical feature, the associated clinical feature are the rectal bleeding, copious mucus discharge, prolonged excessive straining, perineal and abdominal pain, feeling of incomplete defecation and constipation, and rarely the rectal prolapse. Thus, the amount of bleed is variable. A little fresh blood to severe hemorrhage that require the blood transfusion. Now the diagnosis, yes. The diagnosis, the rectal ulcer is usually found on proctoscopy or flexible sigmoidoscopy and commonly present with rectal bleeding in the setting of the straining or the constipation. Now, the other investigation modalities, that is defecating proctography, dynamic magnetic MRI, dynamic MRI, and the anorectal functional studies, including monometry and electromyography. Now, can you give us some insight of the treatment of this, Dr. Devendra?
Treatment in solitary rectal ulcer syndrome concentrate on the etiology, that there is a chronic constipation. So initially we try to give bulk laxatives and stool softeners. And if the patient is presenting with copious bleeding, which may be in less than 1% of chances, then we have to either fulgurate the ulcer base by endoscopically through, or in case of refractory bleeding, surgery may be required very less frequently.
The treatment is, the condition is although benign, but it's very difficult to treat. The symptomatic relief from bleeding and discharge may sometimes be achieved by preventing the internal prolapse by biofeedback, an interrectal stapling procedure, or an abdominal rectopexy. The data regarding the treatment of this unusual disorder, they are retrospective and studies are very small, but several common observation has been made. That is, in general, 1/3 of patients with SRUS also suffer from full thickness rectal prolapse. And if they are associated with full thickness rectal prolapse, then the treatment of the etiology, that is this, the abdominal prolapse repair have resulted in a cure rate of 80% in patients with SRUS and full thickness rectal prolapse. In the same study, patient treated with the same procedure for mucosal prolapse and in SRUS and fared far worse. Only 25% of patients respond to operative treatment. That is, only in case of full thickness rectal prolapse, they respond to treatment. And in most study, the dietary management, pelvic floor retaining, that is biofeedback mechanism, and the short-term use of topical anti-inflammatory medication containing the mesalamine, resulting in remission of those with either internal prolapse or pelvic muscle dysfunction. Yes, as the local excision usually result in the large non-healing wound and has no role in management. The rarely symptoms of severe bleeding, pain, and spasm may require a temporary diverting sigmoid colostomy, and rarely the rectal excision may be required to control the life-threatening bleeding. So this is the following chart showing the symptoms and the treatment part. Thank you.
Again, a difficult problem to deal with, especially require basically biofeedback mechanisms to treat this condition. Because if you say rectopexy, a simple rectopexy will not work in this condition. A resection rectopexy is required. What is Altmaier's procedure is there. But one thing is certain, if you are finding an ulcer and don't label it as a SRUS until you biopsy it.
Thank you. चलो
Thank you, sir. I would request Dr. Dheeraj Balyan, sir, to kindly felicitate Dr. Dhanish, sir. Thank you, sir. I request Dr. Shashank Mishra, sir, to kindly felicitate Dr. Devinder Singh, sir, and Dr. Sandeep Kansal, sir. Thank you, sir. Thank you, sir. So I request Dr. M.K. Maheshwari, sir, to kindly felicitate Dr. Sanjay Pandey, sir, and Dr. Dheeraj Balyan, sir. So I request Maheshwari, sir, to kindly felicitate Dr. Sanjay Pandey, sir. Thank you all faculty members who made this session absolutely informative. We had wonderful lectures today. We dispersed for today, and we hope to see you for dinner, which starts at 8 p.m. Thank you.